Provenge is an established cellular immunotherapy used to treat certain men with advanced prostate cancer. Provenge is customized to each individual and is made from his own immune cells. Immunotherapy is the prevention or treatment of disease with substances that may stimulate an immune response. The immune system has memory and can recognize substances it has encountered previously. Immunotherapy is designed to boost the immune system to target and attack advanced prostate cancer. This is why immunotherapy empowers the immune system to fight the cancer immediately and allow the effects to last over time. Indication: Provenge is a prescription medication used to treat certain men with advanced prostate cancer. Provenge is an established cellular immunotherapy and is customized to each individual by using his own immune cells. Important safety information. Before receiving Provenge, tell your doctor about any medical conditions, including heart or lung problems, or if you have had a stroke. Tell your doctor about any medicines you take, including prescription and non-prescription drugs, vitamins, or dietary supplements. The most common side effects of Provenge include chills, fatigue, fever, back pain, nausea, joint ache, and headache. These are not all the possible side effects of Provenge treatment. Provenge is made from your own immune cells, which are collected during a process called leukapheresis. The cells are processed, returned, and then infused back into the patient through an IV, intravenous infusion, approximately 3 days later. This process is completed in 3 cycles, about 2 weeks apart. Each infusion takes approximately 1 hour and requires 30 minutes of post-infusion monitoring. Provenge infusion can cause serious reactions. Tell your doctor right away if you have signs of a heart attack or lung problems, such as trouble breathing, chest pains, racing or irregular heartbeats, high or low blood pressure, dizziness, fainting, nausea, or vomiting. Have signs of a stroke, such as numbness or weakness on one side of the body, decreased vision in one eye, or difficulty speaking. Develop symptoms of thrombosis, which may include pain and/or swelling of an arm or leg with warmth over the affected area, discoloration of an arm or leg, shortness of breath, chest pain that worsens on deep breathing. Have signs of infection, such as fever over 100 degrees Fahrenheit, redness or pain at the infusion or collection sites. Tell your doctor about any side effects that concerns you or does not go away. For more information, talk with your doctor. You are encouraged to report negative side effects of prescription drugs to the FDA. Visit www.fda.gov/medwatch or call 1-800-FDA-1088. Please see accompanying full prescribing information.
The Prostate Cancer Research Institute is an educational organization for prostate cancer patients, their caregivers, and their families. We put patients first and are an unbiased source of information and support. For over 20 years, our goal has been to meet the educational needs of prostate cancer patients at every stage of their journey. Medical technology is advancing rapidly, and new treatments are becoming available. Patients have to make complex choices which have lasting implications. They face unexpected industry biases and doctors who may not be up to date on the latest research. Your donation helps men receive the latest, most up-to-date information, which empowers them to make informed decisions. Our website, pcri.org, is a wealth of information and resources. Our conferences and webinars are a way to get patients' questions answered by leading physicians and researchers. And we have a helpline for men to call with questions about their diagnosis, treatment choices, and side effects associated with these treatments. Each week we produce multiple videos covering concepts and every patient question that we can think of about the disease in a straightforward and easy to understand format. This was a brief overview of what we do at PCRI, and to learn more you can visit our website. Your donation directly funds our educational programs, which give life-changing information to men during a very vulnerable time in their life, and we thank you for your consideration. You can visit pcri.org to learn more. Hi everyone, it's Alex from the PCRI and welcome to our 2022 Prostate Cancer Patient Conference. Before we get our first session started, we're going to have a short invocation and we'll be right back.
All right. Thank you, Lord, that one day does not go by without your oversight or understanding. Thank you that you are faithful to your own word. Thank you that you are indeed in these days shaking heaven and earth, the sea and dry land, as the prophet Haggai told us you would 2,500 years ago. Thank you, God, that same word declares you as the healer and the great physician. We come to you thanking you for the other physicians you've raised up for men and women. And we ask you that your wisdom and your insight and your plans for our health and healing would be revealed in this critical conference this very weekend. And I personally ask that folks would reach out to you per the word of Jeremiah, that they would find you as they search for you with all their hearts. Bless this time, dear God. Amen.
Thank you, Rabbi. Just a few things before we start. If you aren't already subscribed to our YouTube channel, go ahead and click that subscribe button. Subscribing not only helps to support us, but helps you stay up to date in everything that regards to prostate cancer. This conference will also stay here on this YouTube channel after the broadcast for you to reference in the future. Also remember that this event is free because of donations from people like you. Thank you to everyone who donates to PCRI. If you haven't donated before and would like to, go ahead and visit pcri.org/donate. And there's also a link in the description below this video. Also, check out our conference webpage at pcri.org/2022-conference. We have our agenda, a virtual exhibit hall. Make sure you visit that page because we have many resources and information about our speakers and the topics we're talking about today. I want to take a moment to thank our sponsors that have helped us make this event 100% free for you. Bayer, Pfizer, Astellas, Janssen, AbbVie, Advanced Accelerator Applications, Blue Earth, Dendreon, MyEvent, and Tolmar. Thank you so much for your support. Next, we have Dr. Mark Moyad. He will give us an intro to our conference. He is the Jenkins Poe-Kempner Director of Complementary and Alternative Medicine Education at the University of Michigan Medical Center Department of Urology. Dr. Moyad has moderated over 20 of our PCRI conferences, and he's been a longtime friend to Dr. Scholes, myself, and the PCRI. But more than that, he has helped thousands of patients learn more about their disease by breaking down complex concepts and putting everything into context for us. From helping us find world-class experts to advising PCRI on education and helping PCRI stay up to date. We wouldn't be the same without him, and we are so thankful for him. So without further ado, here's Dr. Mark Moyad.
Hey, you know what time it is? Well, it's the 15th annual Fall PCRI meeting, 10th annual Moyad introduction. I don't even know if those numbers are right anymore. I'm getting so old and I'm just forgetting a lot. So Alex can correct this maybe. And I also brought, I brought this guy who's so fired up. He wants to bite my hand. This is Grazie. Grazie and I, we're going to attempt to be the first dog act to get through my introduction. But I don't think this is going to work out well. He's too hyper, but I'm going to give it a shot anyway. I know, buddy. All right, there's my information, blah, blah, blah. Love me, like me. I'm going to show you photos of my dog. Okay, he's biting me. I'm going to show you photos of my dog to increase my evaluation scores. Welcome, everybody. I'm fired up. We have so much content. I can't stand it. First, I want to do my shout out, my annual shout out to one of the members of PCRI who's having their 31st birthday. As you know, last year she had her 30th, 60th, and this year she's having her 31st, 61st. And so we love her and the staff. And if you see her when we're back in session next year at this time, feel free to give her some kind of gift, money, puppy, whatever. So there it is. Happy 31st birthday, Sylvia. One of the most dedicated members of PCRI. She's fabulous. And thanks to the team. Thanks to my BFF, Scholes. There, my dog barked when I heard the word Scholes. I do want to bring up a couple conspiracies. My first conspiracy of the conference is that every time PCRI does an advertisement of me, they give me a picture that's either really too close, so it shows like I have a big face, and amplifies the already large nose that I have, so it's not very flattering. Or they'll show a picture of me on YouTube advertisements from the side, my profile, which really shows that I have my nose is really large. So it's made me think this is a conspiracy, that they're just trying to do this to me. As you know, I love dogs, and we got, during the pandemic, we had to be very quiet. We had to figure out stuff to do, stay at home a lot. I taught my dog how to do a selfie. So that's a selfie of my dog. And then we sat around a lot, and we would talk to each other, read magazines. We didn't really do much, just sat around a lot waiting for the next PCRI meeting to happen. But interestingly enough, my dog was complaining that I need to do more, get out of the house, root for our football team. So I came downstairs one day, and he was wearing a Michigan sweater. And this was right before the Michigan-Ohio State game. And I said to Grazie, our dog, I said, well, what's the point of this? Every time we play Ohio State, we lose. And basically what he was telling me was never give up hope, always believe that you can win. So he put on that sweater, and I said, all right, I'm going to go to the game. So at the end of 2021, I went to the game. I was covered well, double masks. We played Ohio State. I thought, are they just going to do damage again to us? This is just another year. And lo and behold, in one of the greatest moments of my year in the past 12 months since the last fall meeting, they won and everybody stormed the field. I was too nervous to storm the field, but I enjoyed the excitement. And so my dog was once again right that it was a good thing I actually went to the game to see this historic moment. So the other thing my dog taught me was, he said essentially that he'd like to start driving. And I thought that was a good idea, but I would assist. And so we decided to go for a little drive. And this is a symbolic for the conference. What the PCRI does for everybody, including for me, it makes us look forward. Always the glasses half full, look forward, get excited about the future. There's incredible, incredible things happening. Another FDA approved product again this year in March, Pluvicto. We're going to talk plenty about it, but this symbolizes the PCRI to me. Always forward, always positive, always looking for hope, always looking for other treatments, ways to prevent side effects, treat side effects. It's beautiful. So I want to thank the PCRI team. I also want to thank the different speakers today. And let me just give you a quick introduction to them. Dr. Janssen, the head of nuclear medicine at Mayo Clinic, just doing a very long, wonderful talk on the effect of everything from PET-CT, the different types, to also talking a little bit about Theranostics, radioligand therapy like Pluvicto, lutetium. Dr. Brady, who was here in the spring, is actually going to expand his talk. This is not Tom Brady, although I wish it was Tom Brady in a sense. Dr. Brady is going to talk about ED and incontinence and the different procedures for them and the different medications for them. And that is the unusual talk of the conference, because I have personally asked him to just spend the hour and a half, 2 hours, giving all of the slides so that patients in the audience would be able to absorb all those slides of information. And we were going to keep the Q&A down to 5-10 minutes and do a separate Q&A maybe a couple months from now. It is, all these talks are far too important to stick my happy, wonderful, semi-attractive face in there. We had to get through these slides. We've had more information than possible. Klotz had more information than possible. Dr. Evan Yu, who's always been fantastic on advanced disease. Dr. Kwan, who's just a superstar. And you, the amazing audience. This is, to say it again, this is the most content I can remember having at a fall conference in the past 15 or so years. So we want to make sure that every slide was shown or will be shown over the next 2 days. If you don't know the PCRI team, I think of the song Simply the Best from A to Z. There's Cooper, Sylvia, Galia, Ethan, Jonathan, Austin, the Scholes trifecta, John, BOD, meaning board of directors also. I mean, superstars in their own right. These are the all-star team, I call them. And if you get to see them at our conference, we'll be back in the spring and definitely next fall, I believe. Go up and say hi, and they're fabulous. That's all I can say. And they're really young too, which is a little bit nauseating for some old dudes like myself. My partner of so many decades, I have to thank her too, because always there for all of this, supportive, incredible, behind the scenes. I just can't say enough. Anyway, otherwise I'll get verklempt if I talk about it. Usually during this time, I talk about a variety of things in my area, over-the-counter, lifestyle, the latest on certain supplements, prescriptions. Because of the content, we are going to move all of this toward the end of, to the last session during the Moyad Scholl's Q&A. And so we will cover all these topics, I promise you, including acupuncture is getting a lot of attention, not only in the area of hot flash reduction, but there's also studies going on in the United States to prevent chemotherapy-induced peripheral neuropathy. I have talked in the past about the fairly unknown fact that a certain type of acupuncture is used for a certain type of incontinence called overactive OAB, or urge incontinence. And it's something that people should ask their doctors about if they're dealing with that and they can't take the traditional medicines because of side effects. And this is called PTNS. Actually, it's a form of acupuncture, and it's called percutaneous tibial nerve stimulation. You can Google that. So forms of acupuncture and acupuncture are just getting a lot of interesting data. And you will see that some of our speakers will probably be bringing it up today, because tomorrow, and I'll bring it up during the Q&A, because with the newest FDA-approved treatment, lutetium, and possibly some other therapies in this category, one of the things that are worried about is dry mouth, called xerostomia. And in the world of head and neck cancer, there's already a good deal of preliminary evidence that people who suffer from dry mouth, who have to deal with dry mouth, may get some assistance from acupuncture. Now, we don't have studies yet in prostate, but it's interesting how some of the traditionalists are looking that direction, and I bet you will hear a little bit about that, and to be studied in the category of this new FDA-approved treatment to reduce the side effects of this treatment. So in a lot of ways, acupuncture is getting a lot of interesting, wonderful information. By the way, if you're ever wondering, this is my ear from like 20 years ago. And the reason you can tell it's my ear, it's not just the mole, but the fact that all my hair is dark. So it's before I almost went completely gray. So that's all I got to say about that. All right. I'll also talk about all the repurposed drugs and where they are. To give you an update, the largest trial of looking at adding aspirin after definitive treatment for prostate cancer, radical prostatectomy, radiation, is called the Add Aspirin trial. What a lot of people don't know is this trial is already randomized as of the last check, which was today, over 1,800 men, over 1,800 men in this phase 3 trial. In fact, Add Aspirin is 4 ongoing phase 3 randomized trials. And the prostate arm is one of the larger. And I don't know if it'll be next year or the year after. We're going to find out if adding aspirin, if your doctor approves after treatment, could reduce the risk of recurrence, or could it increase the risk of recurrence, or could it have no effect? Interestingly enough, and I think it was wise, the patients in this trial had intermediate to high risk disease. So this is not your active surveillance crowd that went on to get treatment. These are people with intermediate to high risk disease. You know, these are individuals you worry about a certain percentage of them having recurrent disease eventually. So I just love these trials and all these other trials going on. The other thing I wanted to add, if I think I had time here, is that we'll answer all sort of bizarre questions in the Q&A as to why, for example, when I go to one of the major pharmacy chains, whether it's CVS or Walgreens or you name it, and I buy one item, I get a receipt that's basically almost 6 feet long. So this is one of the greater mysteries in life, why I get a receipt that's 6 feet long when I just buy one item at one of these stores. Perhaps someone can write in and explain this to me. But I plan to try to explain these and other conundrums during the Moyad Scholl's Q&A. We cover all sorts of wonderful, wonderful stuff. And then last but not least, I will go through my best articles of the year in terms of research. I'm a reviewer for a lot of articles for the major medical journals, and I'll pick out my 3 or 4 during the Q&A, including my favorite exercise study of the year, the ERASE trial that occurred in Canada, and how it impacts prostate cancer patients, not only physically, but mentally. Beautiful, beautiful studies. So with that, I'm going to turn the microphone over to our first speaker, Alex whatever comes next here, I want to say thank you again to the PCRI team. Thank you again to the speakers. Thank you to our audience who have made this one of the largest crowds of any cancer meeting in the world. And I can tell you, we always want to do right by you. We always want to be better. Always feel free to write in your questions and comments, especially the nice comments. If you write in nice comments, we'll always read them. But your questions are important too, because we take all of them and I literally review all of them with Alex and the team. And then we pick out them and group them, and then we use them in our Q&A, and we also use them for our speakers in the future when we bring them back. So I still have questions from 2 and 3 years ago at the meeting that we're still holding on to and utilizing for future speakers. So that means a lot to us because we want to know what you're thinking about. Thank you. I hope you enjoy the show. I hope you enjoy the education, and thank you for letting me come into your living room or your computer room or whatever we call it. And I'll see you at the Q&A.
Thanks, Dr. Moyad. Before we get started with our prostate imaging presentation, I just wanted to remind everyone to visit our exhibit hall on our conference webpage. There you can find lots of helpful resources and information about treatments, payment assistance programs, and much more. Our next speaker is Dr. Geoffrey Janssen. He is the chair of Nuclear Medicine Division at Mayo Clinic, and he will present the latest updates in PSMA prostate imaging. He is an incredible expert in his field, and right after his talk, the Q&A session with Dr. Moyad will begin, and you don't want to miss that. Without further ado, welcome to the PCRI conference, Dr. Janssen.
Thank you, Alex. I'm looking forward to this. I'm going to give a talk today on PSMA PET scans, Theranostics. I'm going to talk about SPECT, and a glimpse of the road ahead in prostate cancer. So that's a whole bunch of things to cover. And a little bit about me, I'm a nuclear medicine physician and radiologist. So I think you guys know what a radiologist is. We do a CT scans, PET scans, SPECT scans, MRI, all the kinds of stuff. But nuclear medicine folks might be unfamiliar to you. And what we do is we deal with radioactive drugs. And we do it for both imaging purposes and for treatment. So we're going to talk about a bit of both of those things. But the main thing I want you to come out of from this talk is that we're all in this together. You know, I'm a technology guy. I love technology stuff. I like the cool gadgets. You know, I have a training from MIT in the background and a Ph.D. and all that good stuff. But at the end of the day, I'm a physician and I'm also a cancer survivor. My father, my father-in-law both have prostate cancer. So we're in this together and we'll get through it as a team. So I do have some disclosures here. I do get research funding from a number of different companies. I do consulting for a number of different companies in the radiopharmaceutical or radioactive drug space. I take all that money, I put it into research. I do hold patents, and Mayo holds patents. I have my own PSMA targeted imaging and therapy technologies we're developing. And I am going to talk a little bit about things that aren't FDA approved, just to give you a hint of what's coming in the future. And I'm also a founder of several companies, including Nucleus Labs, which is in the production of radiopharmaceuticals for imaging and therapy. So where are we in the field and historically, and where are we going? So historically, we did a lot of work with what we call conventional prostate cancer imaging. So bone scans, which is a nuclear medicine scan you may be familiar with. We give a radio tracer into the body. It goes to places where the bone is injured and shows us where cancer might be. And you see the bone scan here of a patient's bones. CT and MRI are standard or conventional imaging by comparison to what I'm going to talk about later. A CT scan, as you see here, is an image of a patient with an X-ray shooting through them. And it's a shadow of the X-rays, and it shows you dense things like bones. These are the patient's pelvic bones, and here's the bladder, and down below that would be the prostate. Whereas an MRI, I think of as pretty advanced, but we still call it conventional by comparison to PET scans, are really good at looking at soft tissues. And here we're looking at echoes of magnetic resonance bouncing out of the body. It's pretty cool stuff. But you can see right there on the bottom, this is the prostate gland right here. And in this image, we might be looking for an early prostate cancer. So what's a PET CT? Well, I like to describe it as two halves of a bagel. You got the scanner on the left, you lie down on it. It looks like any other scanner you've got, but it's really two scanners in one. And they're two halves of a bagel put together. One half is a CT scanner, just like we saw before, where the X-rays are shooting through you and it creates shadows, and we can see the anatomy, we can see structures, we can see tumors. A PET scan is different. And we'll get into that in a little more detail. But a PET scan is the back half of the scanner. And that's the part where the magic of what I do really comes in, where we're looking to see where a drug we injected in you went to find your cancer. So as I mentioned before, my father's a prostate cancer survivor. He's also a Vietnam vet. And so when I'm trying to describe this stuff to him, he says, okay, you said you're injecting a radio tracer. And he's like, is that like a tracer round in the military? As you can see here, they're shooting off flammable bullets that light up the sky to show you where the bullet's going. And in a way, that is kind of what a radio tracer is. It's kind of the wrong concept because the bullet actually hits somebody and hurts somebody, whereas the radio tracer is almost harmless that we're using for the PET scanning. But a similar concept in that we're tracking where it goes in the body because it's giving off signal to us in the form of radioactivity, not light, but a different kind of invisible radioactivity. So what is a radio tracer? Well, it's radioactive. That's the first half of the word. It's trace, meaning a very, very small amount that we're injecting. So a small amount of dose. And we can image or bind it to a very, very small amount of a target. So even if there are very few cancer cells, we can often see them. The word trace has a double meaning. It also means find by investigation, which is where the tracer round comes in. But if you look at, how much are we injecting? Some people get nervous about radioactivity. You're injecting me with radioactivity. Well, it's a very, very tiny amount. And the kind of radioactivity is very harmless or near harmless. If you look at this finger here, they are granular particles of sugar. If you cut one of those 1,000 times, that's how much drug we're injecting, 1,000th of 1 grain of sugar. And the radioactive component of what we're injecting is 1/2,000,000th of that. So most of what we're injecting is just the part of the drug that gets it to the cancer and sticks to it. The radioactive part is really tiny. So what do? We inject a radioactive drug or radiopharmaceutical into a vein. As you can see here, it goes throughout the body. It's designed to stick to cancer. And what doesn't stick, we want it to get out of there. We want it to get out of your body immediately. And mostly it comes out in your urine. So here's an example, kind of diagram of that. If you have a cell of cancer, on the surface of the cell, there's a molecule there that we're targeting that the cancer cell has all over it, but the other cells in your body don't. And so we design a molecule that sticks to that fits perfectly and binds to that surface. That's called the ligand. And this is the PSMA part, which we'll talk about later. Then there's a little bit of a linker, and there's a special thing to hold on to a radioactive atom. In this case, gallium is what we're using here, gallium-68, which gives off a signal to our PET scanner. The cool thing is the second part of the talk I'm going to talk about is once we've identified that you as a prostate cancer patient have cancer that we can see with this kind of imaging, then we know whether or not we can treat it. So we can actually take that gallium radioactive atom here and replace it with a different radioactive atom to try to kill the cancer. And that's really the cool part of this technology. So what does the word emission mean? Well, when this radio tracer goes into the body, so that those little red blobs are supposed to be a molecule of this drug that we've injected in. At some point in time, it's like a ticking time bomb. It just gives off a positron. That positron is, I know that I'm a dork with science stuff, but it's antimatter. It's literally the opposite of matter in every way, especially the charge. That then hits an electron within a millimeter or so of where the radio tracer is, and it gives off these beautiful 2 photons. So they convert the positron and electron into pure energy. They shoot through the body without interacting with the body much. And those 2 photons fly out on a straight line, okay? So I haven't lost you yet. I'll get you to the end here in a minute. If this is a person inside a scanner, these are the detectors around the patient, okay? Those 2 photons fly out and hit the detectors, and it knows that somewhere along that line, that radioactive drug is in the body. But now, the scanners and the technology are so fast that at the speed of light that these photons are flying through the body, it can detect which one hit first. And it can mathematically, we can figure out, okay, not only did it come along somewhere along that line in the body, but it actually came in that little 2-3 centimeter area, and we can really more accurately pinpoint exactly where the drug is in your body. So what does that give us? Well, it gives us a scan. So PET stands for positron. That's that thing our radioactive drug gives off. Emission, which is the light that shoots out of the body, the light that we can't see, irradiation. And tomography, that's the T in PET. Tomography comes from tomos and grapho, slicing and imaging. So I like to think of these as like slices of bread. So I'm going to show you some images in a minute. And as we scroll through the images, think of it like going through slices of bread, but the bread instead is your body, okay? So this is a PET CT. It has a CT and a PET combined. We use the CT and the PET image together. So we get a CT image. This is a patient standing up. You can see their head at the top and their arms. You can see their heart right here and their lungs. This is the PET scan sliced vertically, what we call coronal view. You can see their brain here. This happens to be a glucose radiotracer, and the brain consumes a lot of glucose. It lights up. So this image is created. We then take the CT to make the PET scan better. So because those photons are flying out of the body, sometimes they hit bones and things and they don't come out. So we have to adjust the scan. We have to correct it, attenuation correct it, to get this beautiful map of all of the drug in the body, the radiopharmaceutical or the radio tracer. The image is actually our best guess at how much radioactive tracer is in each part of the body. That's what it is. That's what the image is. Whereas a CT scan is our best guess at how dense each part of the body is. So bone is more dense. Then we put the two together. We actually take this black and white image of the PET scan, we turn it into color. And the reason we do that is because we're going to put it on a black and white CT and we want to be able to see the two of them. So we choose to have a rainbow color. Some people use red or green or other colors, but you can see the colors on top of the CT scan, and that's your PET CT. So when we do them together, it lets us co-localize. What does that mean? It means that if I'm looking at this image, this is actually a three-dimensional image of exactly where a radio tracer is in a patient's body. And that thing where their arrow is on a tumor. It's not supposed to be there. That's not normal. But where in the body is it? How do I tell the surgeon or somebody else to go in after it? Well, now I've got an image of a patient. Imagine their feet are coming out toward me. This is cut right through this slice of the body. You can see the PET scan here in that slice. You can see that focus right there. This is the CT co-localized. I can see this is the clavicle bone here. This is the spine. These are ribs. That's the shoulder. You can see, well, that radioactive drug, that radio tracer is right behind the clavicle, and it's right inside this little piece of density. That's a lymph node right there. And I can tell the surgeon and the radiation oncologist exactly where it is. There it is. Okay. And then we measure an SUV, which is it's a measure of how much drug we think is there. And the SUV is very high, which means a lot of it went to that tumor. So here we have what I actually look at when I'm sitting in the reading room and I'm looking at a scan and I'm saying, okay, I've got Mr. Smith. He's got 65-year-old. He's got prostate cancer in the past. And I'm trying to find where it is. Okay. And here is this tiny little ditzel down here. I see, well, maybe that's of concern. Well, what about these little things here and here as I'm kind of scrolling through? Okay, well, there's his bladder. I can see his bladder, and right below the bladder should be the prostate. So I scroll down there and I'm like, okay, the prostate's gone. In fact, I can see all these little surgical clips. Okay, you see them on the CT scan here. Surgeon's been in there. There's been radiation done. All I'm seeing here is urine. The radio tracer that doesn't stick to the tumor, we want to get it out of the body. And most of it comes out in the urine. And so you see all this activity in the urine that's normal. You can actually see it flowing from the kidneys to the bladder in the ureters here. So the kidneys are clearing it out. They've got a lot of activity. As I scroll through here, I'm looking, I see, okay, there's the spleen, there's the liver, that's normal. I start looking at different ways to look at the CT and any lung nodules. Basically, I'm looking through this whole scan and I'm thinking there's nothing there except for that one little ditzel I showed you before. It turns out that's a red herring. That's a little nerve bundle that people sometimes get confused on. So in this PET scan, we're pretty sure the patient's cancer has come back, but we don't see anything. So that sometimes happens. So I'm showing you this first. I'm going to actually open up this image and show you what a three-dimensional image looks like. So this is a scan of the patient. I'm going to rotate it around. And if I make it really dark, you can see the outline of the patient. You can see their arms, can see their legs, okay? This is what a PSMA PET scan looks like. This radiotracer is designed to stick to prostate cancer. I normally see the glands that make the tears, the salivary glands, these are the parotid. I see the liver, the spleen, the kidneys, some of the bowel, it's all normal, and then the ureters, and there's the bladder. That's all normal. I'm not actually finding any cancer in this patient, okay? Now I'm gonna flip to a patient who has active cancer on the scan, so you can see the difference. All right, so as we scroll through this, now you're seeing all these dots, all these hot spots that weren't there before, okay? We're seeing them in lymph nodes in the posterior of the belly along the spine. This is the aorta that brings blood from your heart to your body. Those are all sites of cancer. All of these spots, like this one here, those in the bone are abnormal. And you can see on the CT scan right there, see how it's whiter right there? That's sclerosis. So if the cancer has been there long enough, most prostate cancer becomes sclerotic. So we can actually see some of these cancers on the CT scan, but I can't tell on the CT scan if the cancer is alive or dead. You know, maybe a prior therapy treated it and that's just been sitting there and there's no cancer cells there and that's just healed, dead sclerosis. No, it isn't, not in this patient, because the radiotracer is sticking to the cancer cells. It tells me that the cancer is alive in that location. And as we scroll through, you can see in this patient, there are even an unusual situation. I'm going to change the window level so you can kind of see it better. They have metastases in the liver right there. Now, if I try to see that on the CT scan, I can't see anything there. There's nothing there. So the PET scan is letting me see things I can't see on a regular CT scan. I'd have to do special things like add contrast or do an MRI to pick that out. Okay. And if I bring up the MIP image, like I showed you before, the three-dimensional rotating image. So I bring up the MIP image, and now you can see all of those tiny little lesions. And I'm going to bring this patient scan up again several times so you can see, and later on in the exam, in the lecture, you can see all these little dots. These are bone metastases, lymph node metastases, and liver metastases. So this patient, I look at them and I say, this patient might be a great candidate to use a different version of this drug for therapy. So as was mentioned before, we can then put lutetium in the same compound, and then it's lutetium PSMA 617 or Pluvicto therapy. And that second patient might have been a great candidate for that therapy. I'm going to step back in history a little bit. You guys have seen lectures on the same program from Eugene Kwan, great friend of mine, a collaborator. Val Lowe, who works in radiology, works with me. The two of them brought forward C11 choline, which was a radiotracer designed for imaging prostate cancer. We've been doing this since 2005 here, together with Dr. Joseph Hung, who's a nuclear pharmacist, and Mark Jacobson, a PET radiochemist, brought that through the FDA, got it approved so that we could find cancer hiding in people's bodies. And here's an example case. This is a patient who had prostate cancer. It was surgically resected and it came back. PSA was just ticking up to kind of 0.5. And you can see this tiny little lesion here, 5 millimeter lymph node tucked in near the lumbar spine, near the muscles that make the legs move, the iliopsoas, right near the blood vessels, that tiny little ditzel. You'd never pick that out on the CT, and that was the only metastasis in the patient. But now we're moving on to PSMA imaging, and so that's what we're going to talk about next. There are two different drugs that are new in imaging prostate cancer and PET, gallium PSMA 11 and F18 PSMA DCF-PYL. It goes by the trade name Polarify. At the end, I'm going to talk a little bit about these two. These ones are all historic. I mentioned, you can use glucose, you can do a bone scan, you can use choline, and then there's another one called fluciclovine or oxamin that you can use to try to find prostate cancer. But the most excitement is around PSMA, and PSMA is the only one that can be converted to a therapy. So here are some scans. Now, I showed you PET CT before, but we can also do PET MRI. We've had quite a lot of fun with this. It's very popular, especially patients who are early on in their disease where we're trying to see it in the low pelvis. We can see little ditzels like this diffusion-weighted bright spot or ADC dark spot that looks concerning. And then, oh yeah, it's also got PSMA activity. The radiotracer went there. And oh, by the way, that little tiny lymph node that looks totally normal in the MRI, it's glowing hot. on the PET scan. And so now when the surgeon goes in, they're not just going to remove the prostate, they're going to go after that lymph node. Here's another example. This is a patient who had surgery and radiation before. Their PSA starts going back up. We're like, where is it? What are we going to do? And on PET MRI, we can see a tiny little lymph node here and a lesion in the bone. The bone looks different on MRI. I don't know if those are alive or dead based on the MRI. They look kind of concerning. They're showing some enhancement, but here they're clearly glowing on PSMA. They're alive tumors. And those were the only metastasis in that patient. They went ahead and irradiated that patient to control their cancer. So what is PSMA? PSMA is prostate-specific membrane antigen. That's the name it got back when they were studying it in the lab, okay? But it's not exactly 100% prostate-specific. It is a membrane antigen, meaning it's on the surface of the cells. That's what membrane antigen means. So this is a cartoon drawing of what it looks like. If this is the edge of the cell membrane, the edge of the cell, this is the part sticking out into the tissue fluid and blood where the PSMA drug would stick to it. It's got a bunch of names in the literature, but the key part here is that it gets upregulated. What the heck does that mean? That means that when the prostate cell becomes cancer, most of the time it upregulates or expresses or has a lot more of this on its surface. So yes, the prostate cells themselves have PSMA on their surface, but the cancers tend to have 100 to 1,000 times more of it on their surface, which makes it great as a target to try to find the cancer. And as we discussed before, this is what a normal scan looks like. We see these normal structures. I showed you one nervous glia, a nervous cluster of nerves down the pelvis that could fake someone out into thinking there was prostate cancer. There's also some things where we see some other kinds of tumors. Some kinds of tumors, when they grow their own blood vessels inside them, and those blood vessels can express PSMA. So when we read these, it's not so simple. I can't just say that has activity, that's cancer. Or that is bright, that's cancer. We have to think about what are the other imaging, what's the MRI look like, what's like the CT look like, is that truly a cancer that we're looking at? So I'll give you some examples. PSMA expression, so in other words, as the amount of drug, radioactive tracer goes to the tumor, the brightness goes up on the image. The higher it is, the worse prognosis or the worse kind of cancer the patient has. And it can vary between patients and even within a patient, they can have tumors that are PSMA expressors and PSMA negative. So there's a lot that we're learning as we go through all of this. One of the nice things is as the tumors express more PSMA, our therapy works better too, because we get more therapy drug to the tumors. So I'm going to skip that one. I'm going to show you some cases here. This is our first patient case. And you can see here that this patient has one focus of activity right there in the seminal vesicles. These are the glands that make the semen. And unfortunately, that's where it regrew. And we can see that spot very clearly. Okay, can't see it on the CT. Here's another patient. See this really, really tiny spot right in front of the spine down there. I look at the CT, I can't even see anything there. Now, you have to recognize we do the CT first, then the PET scan. Sometimes the patient moves a little between the two. So if I scroll up a little, there's a lesion. That thing is 2 to 3 millimeters in size. I mean, we're talking about like less than 1/10 of an inch that we're able to pick up with this technique and say that that's an active site of cancer. Here's another one, a really tiny lymph node there of about 4 millimeters in size. Here's one that's not so hot. It's, mildly avid, as we would say. It's not glowing as brightly. There's less drug getting to it. Some cancers don't express as much, but that's also a site of cancer. Here's a patient with little tiny mets all over their body, all over their bones. And this patient had a negative CT scan and a negative bone scan, just to show you how much we can miss when we're looking at patients with our conventional imaging compared to this advanced PET scanning. Here's a patient with a lymph node up in the neck of prostate cancer, okay? There it is, tiny little lymph node. That was the only site of cancer we found in that patient. So sometimes it's really far away from what we're used to looking at, but that was the only site of cancer. And you might say, well, what's that little ditzel over there? I see a little hot spot on the other side, okay? I can see it there on the slice through the patient again. And what is that? Okay, there's our metastasis, and there's that smaller, less bright lesion. Oh, there's one on the other side. Those are ganglia. Those are normal structures. So we see those, they have some PSMA expression. They're just normal nerve cells. And the people reading the scan have to know how to read these to not confuse these things. You can see them again as we scroll. And there's a patient who has, these are all little ganglia going right down the spine. So as the nerves come out, these little nerve root clusters can light up on the scan, and you don't want to have your physician confused by that. Here's another one. This is a patient who has a tumor in the spleen. This is an organ that kind of cleans out red blood cells that are dying and keeps the blood clean. Prostate cancer really doesn't like to go to the spleen. It would be very rare. So we see this and we're already thinking that doesn't make sense for prostate cancer. And then we looked back at old scans, and this lesion has been there for a long time. It's not changing. We could see it on an MRI scan 5 years ago. This is what we call a hemangioma. It's a benign tumor. And this goes back to what I said before about sometimes the vessels, the neovasculature or the endothelium along the blood vessels in some tumors can express PSMA, and it's not prostate cancer. Here's a similar lesion. This is a benign lesion in the bone that looks kind of concerning on the PET scan, but it's fibrous dysplasia. It's a benign lesion that's not going to change. It'll be there forever, and it was on this patient in imaging going back a long time. So we can ignore that. Then you've got a lesion like this. You've got this tiny lesion up in the lung. This is the only lesion we saw on this patient. You look on the CT scan, which was part of the PET CT. I don't see anything there. We then brought them over to a regular diagnostic CT scanner. A diagnostic CT scanner is a better scanner than the CT you get with your PET scan. And there you can see just this really, really tiny little ditzel there. They surgically went in and took that out. That was the only site of prostate cancer in this patient. It was that tiny. Okay, so I showed you a bunch of imaging. I give you a hint that we can use this therapy to this imaging to direct which kind of therapy we're going to choose. I also said we can use this imaging to select a patient for Pluvicto or PSMA targeted therapy. But what about using the amount of activity at the initial time of diagnosis? In other words, we have a patient coming in, Mr. Jones, he's got concerning prostate cancer on a biopsy, and we're concerned that it may have spread beyond the prostate. We want to know whether we should just go ahead and do surgery or whether we need to image him with a PSMA PET scan. And so there are certain classifications. We can go ahead and do a PSMA PET scan on a patient who has not had any therapy yet to identify whether they need something more than just regular surgery or radiation or ablation. We select those patients, and when we get the scan back, one of the things I do is I describe how much activity is in the tumor, because that then also helps people figure out how aggressive to be. And so we have this thing called the PSMA expression score. There are a number of different ways we can describe a PSMA PET scan to try to convey, how much of the drug went to the tumor. And the PSMA score is probably the simplest one, and that's what we've adopted here at Mayo. So if you compare a tumor to the normal structures in the body that have PSMA activity, then you get a scale, 0, 1, 2, or 3, 3 being the highest. The parotid glands, or the salivary glands that make saliva, they have some PSMA expressed on their cells. They're the hottest structure in the normal body. So if the tumors are hotter than that, have a higher SUV than that, we call it a 3. Those are the patients who have usually higher grade tumor that we're more concerned about. They also, if they're going on to therapy, are the ones we think will have the best response to a PSMA targeted therapy. But for the purposes of dealing with surgery, right at the beginning of dealing with prostate cancer, this score says I'm more concerned about the patients having the cancer come back after surgery if the PSMA score is 3 rather than 1. So the liver is another cutoff, and the blood pooled background. So I'll show you some examples. Here is a patient. This is their MIP image. There's no metastatic disease. On the CT scan, this is the prostate right here. You can see that there's just a blush of activity in the prostate. This is the PET scan here. Okay, this happens to be the rectum back here. These are the pelvic bones around it. So that's a low level of activity. That suggests that the patient has a low risk of having recurrence at a later date. Okay, it's less hot than liver, more hot than blood. Here's a second patient example. This is a patient, again, we've got the prostate right here. We've got a little tiny focus right there that's pretty hot, okay? This has a PSMA score of 2, which means it's hotter than blood and hotter than liver as an internal comparison. There it is on the MIP image. You can see it below the bladder, which is the bright thing here. And there's the liver for comparison. It's hotter than liver, but it's not as hot as the salivary glands. So it's in that PSMA score 2. PSMA score of 3 is the hottest category, the highest. And here you see a patient. Here's the prostate. This is the bladder kind of peeking in here. That's just urine. Don't worry about that. But this is a very, very avid or bright tumor with a lot of PSMA radiotracer in it. And if I rotate the MIP, you can't really see it because it's behind the bladder. So if I rotate the MIP, now you're looking at the patient from the side, you can see this elongated tumor in the prostate gland back there. Okay, that's hotter than liver, hotter than salivary glands. This is the hottest. This is the patient we're most worried about recurrence. Luckily, the PET scan didn't show any metastases in that patient. Okay, so hopefully that makes sense about a PSMA score, because you'll see that on your PET scans if you're getting them. So there are 2 drugs, as I mentioned, and they're roughly equivalent. I'm going to show you some images here. So on the left side, we've got a MIP image, we've got a CT, a PET, and a fused image. In this case, the color scale is red. On the right, we've got a kind of a side view of the patient. So a sagittal view. You can see down the spine. You can see all these little mets. There's the PET, there's the fused PET CT, and there's the MIP. One of these happens to be one version of the radio tracer. The other is a different one. And I got to tell you, I can't tell the difference. If I'm looking at the images, I can't tell which radio tracer was used unless you tell me. This one happens to be the F18 one. This happens to be the gallium PSMA 11 one, okay? And this one and this one are both FDA approved. One difference is right now, because the therapy trials used this one to select patients, the PSMA 11, to select patients for therapy, some insurance companies require that you get this version of the scan prior to your therapy, which is an interesting one we can talk about. But they're both equivalent, and we're hoping that that will go away and you can use either one interchangeably. In fact, a whole group of societies got together and basically said, there's no evidence there's any difference between these 2 radio tracers. The PET scans are equivalent, and insurance companies should view them as completely interchangeable. And we hope that that will be the case coming forward. If you look at the structure of them, they both have the exact same site of binding. So in other words, you can't, for those of you who aren't chemists, can't tell, but this structure and this structure are identical. In other words, the binding site of how it sticks to the cancer is identical between the 2. So over the last couple of years, these have gotten approved. A big shout out to UCSF and UCLA, like Mayo did back in 2011 when we got choline FDA approved. They went out as an academic institution, both of them, and got PSMA imaging approved. Then 2 different companies, Telex and then Novartis, came forward with kits that allow other places to make it. And then the PSMA DCF PYL, otherwise known as Polarify, that's made by a company called Lantheus. So for your purposes as a patient, do you care which one you got? I would suggest to you, you do not. It shouldn't matter. And if you got your insurance company to pay for it, go get the scan, go get what you need. And the details are between the 2 are minuscule. Okay, I'm going to talk a little bit about how we make the radio tracer, because I think you may find this interesting. So we get this box. We actually make this PSMA 11 at Mayo. And we get this little box that comes into our PET radiochemistry lab that's called a generator. It has a radioactive precursor, and we just kind of pull gallium off it. That gallium kind of spills off it, and we wash it off. Every few hours, we can get another batch. We put that gallium into the PSMA drug, and then we can inject patients with it. We came up with at Mayo a different way to make gallium, which is the radioactive atom, with what's called a target. We patented this, we've licensed it, and there are other versions of this coming. but basically a different way to make gallium where we don't have to use or worry about the supply and how much availability there is of generators, because the generators, there's a limited supply, which is causing problems in terms of people getting PET scans. So we put that onto a cyclotron, which is this machine, and we have several of them here. So high-tech stuff here. I love this stuff. I hope I don't lose you guys. We spin subatomic particles up to 1/3 the speed of light in a circular manner, and then we slam them into that little target, and we create new atoms of radioactive gallium in this case. And then we use that into a lab. This is one of our labs here. We got all these fancy shielded areas where we can work with large quantities of this stuff, get it down to a really tiny amount that's purified, FDA inspected, everything you can think of as a drug manufacturer. And that comes from a lab like this into the patient for the scans. Okay, so in prostate cancer, if we go back to 2013, we already had a radiopharmaceutical therapy, a drug that was radioactive we could use to treat prostate cancer. We still use it. It has some limitations. It was approved in 2013. It's called Radium, or Xofigo is the trade name. Does it work? Yes, it does. What's the problem? It only treats patients who have prostate cancer in their bone. If the prostate cancer has left the bone to lymph nodes or liver, like I showed you before, if it's still in the prostate, it will not treat them. It actually binds to the bone where the bone is injured and then radiates the prostate cancer cells nearby. So it's effective, but has some limitations in its use. If you look at, what kind of therapies are there for radiopharmaceuticals? Well, we've got ones for thyroid cancer. We've got ones for lymphoma. We've got ones for liver disease that we inject into the arteries and they stick in the blood vessels. We've got ones for neuroendocrine tumors like pancreas cancer. But the biggest area of growth is in prostate cancer. And the biggest target that people are excited about is PSMA, like we're talking about. So these are some of the ones we're working on at Mayo. I crossed this out because that trial closed. It didn't work very well. And if we look and say, okay, who does this kind of therapy? I'm a nuclear medicine physician at Mayo Clinic in Rochester, Minnesota. I'm the one, and my colleagues are the ones who give the therapy, but we work as a team. We work as a team with our medical oncologists, our urologists, our radiation oncologists to decide what the best therapy is for any given patient. Because, we know a lot about radiopharmaceutical therapy, but we know less about other therapies that are good options, and we work as a team. At some institutions, the nuclear medicine physicians aren't the ones giving the therapy, such as PSMA targeted therapy. Sometimes it's the radiation oncologists who do it. Sometimes it's medical oncologists. Sometimes it's urologists. Rarely it would be an interventional radiologist. So they all, in different institutions, may be giving the therapy. And it does make it interesting. Our group has worked really hard to get this cohesive team behind each of our patients to come up with the best plan. Other groups haven't quite figured all that out yet. And now that this therapy is becoming so popular, they're trying to figure it out. And I think they'll get there, but there is some learning going on. It's definitely an opportunity for developing a multidisciplinary center of excellence. And the Society of Nuclear Medicine came out with some guidance and some accreditation this year, actually. And we were very happy. Dr. Tuba Kendi in our group is under me as the chair of the division. She's the lead of our therapy practice in nuclear medicine. And we submitted and got the highest level of therapy center of excellence called the Comprehensive Therapy Center of Excellence. And some of the things that they want is an integrated team. They want to know that you've got research trials going on, that you know how to do that, and you have sufficient resources. For example, we have 23 rooms, both research, inpatient, and outpatient, where we can do these therapies. Okay, I'm going to pause for a second and talk about terminology. I want you guys to understand that the language around this kind of PSMA therapy is extremely confusing. So what are some of these terms? Theranostics is a term you'll hear. That's the concept of diagnostic imaging and therapy as a pair. So theranostics. So PSMA for imaging, PSMA for therapy would be a perfect example of a theranostic approach to treating cancer. Some people will call it radionuclide therapy. Targeted radiotherapy, that's actually a term that radiation oncologists often use, which we then joke in nuke med saying, well, isn't your external beam radiation targeted? But in reality, what it is an abbreviation for molecular targeted radiotherapy. And then there's targeted alpha therapy, which is kind of a next generation with an alpha emitter, which if we have time, we'll have a moment to talk about. Radioimmunotherapy, or RIT, that's specific to antibodies. If we use an antibody to stick to the cancer and make that radioactive, then radioimmunotherapy is a term that applies. And an example is one of these ones we have to target lymphoma called Zevalin, which is an antibody. It's basically taking the immune cells' ability to stick things to the cancer and putting radioactivity on it. Peptide receptor radiotherapy, or PRRT, is another term that people use. A lot of people will use that just to talk about this particular drug, but that's another term you can use. Radioligand therapy is a term commonly used by a number of different drug companies like Novartis. Same concept. And radiopharmaceutical therapy is another term. So all of these things are basically the same concept. Radiopharmaceutical therapy is what the NIH likes, or the FDA likes. They think that term makes more sense. So I apologize for all of the terminology out there, but there you go. Now you can say, I know all the different terms. So you look at prostate cancer going forward, this slide is very busy. And I'm not going to apologize for it. I'm going to tell you that this is actually really exciting. Each of these listings is either a diagnostic imaging agent or a therapeutic that a drug company or organization is bringing through clinical trials, hoping that will help us with prostate cancer. And so you can see all of these things. You can see the investment and the excitement that we're not only going to do well with the drugs we have, but we have a lot of things in the pipeline coming down the road. Okay, talk a little bit about the logistics. So let's say you as a patient, you have prostate cancer. Your prostate cancer lights up on the PET scan. We all discuss you and decide you're an excellent candidate for PSMA targeted therapy or lutetium PSMA 617 Pluvicto therapy, and you agree. What happens next? Well, the lutetium comes from a nuclear reactor. A company called ITM provides that in Europe, gives that to Novartis. Then Novartis takes that and they do chemistry and validation that they can link it to their PSMA radiopharmaceutical. That work gets done actually in Italy or New Jersey, hopefully in the future, Indiana. Then it gets shipped, okay? It's received early in the morning at the hospital, sometimes the day before. It flies in, because these things are only live for a short period of time before we have to throw them out. They're short-lived. When they arrive, we have basically 24 hours to use it or throw it away, okay? And then we do up to 6 cycles of the therapy, kind of like chemo. So we'll give you a dose of lutetium PSMA therapy. We'll see how you're doing. We'll have you come back again later. We'll give you the next dose, and we'll keep going, and we'll monitor you until at least 4 doses, probably 6 if it looks like we need a few more. So how well does it work? Well, here are some examples. Here you have a PET scan in this box up on the left. This one on the left of each of these boxes is a patient before therapy, and on the right is the same patient after therapy. And what the authors did in this is they labeled on the MIP images of the PSMA PET in red all the prostate cancer lesions that they think are real and have activity. And you can see this first patient had a great response. After the course of PSMA therapy, there's no prostate cancer there. These numbers down here are the PSA in the blood. So the PSA was 15, now it's undetectable. So a complete response, best case scenario. Most patients don't get that. Obviously, we hope for that. And most patients who do get a complete response, the cancer eventually comes back. Here's an example where a patient had a lot of disease, a very dramatic response. The imaging shows no cancer detectable, but the PSA isn't completely gone. Here are some other examples you can see. So these are all examples of a really good response. These are best case scenarios. So there were 2 critical trials that drove to the FDA approval of this therapy earlier this year. One was the Therapy trial in Australia, led by Dr. Hoffman. And the next one was the Vision trial sponsored by Novartis, phase 3, of which we were a site of 80 sites. We actually enrolled the most patients in that trial. So if we focus on the Vision trial, this is probably more details than you want, but a couple things to pull out. It was actually 84 centers and 831 patients in total. And what they're comparing is they're saying, look, these are patients who have failed everything. They failed hormone therapy. They may have had surgery. They had to have had chemo. They've basically, they're at the end of the line. And what are our options? Well, the standard of care option is to kind of give them more of the same that didn't quite work, which is what we call standard of care. Hormone therapies, chemotherapies, or they can get that and we can add the lutetium PSMA radiopharmaceutical, okay? And so what did we find? Well, these are the two groups. This is how long they went before we saw their cancer grow, okay? We call that progression-free survival. So how long did we keep the cancer from growing? And the difference between the two is the benefit. And you can see that the patients who got the PSMA therapy went many more months than those in the standard group on average. Some of these patients had a much better response than what you're seeing here. And then we looked at overall survival. How many patients, how long did the patients survive? And again, these are very late stage patients. They've gone through everything. And what we saw was that they lived 4 months longer. That might not sound like a lot, but that is a great result in this patient population. And we're hoping, obviously, with better therapies and using these therapies in patients earlier in treatment, that we can improve upon that. Some of the other nice things from the trial said that the pain relief was significant. It improved their quality of life, and it improved their ability to do the activities of daily living, how to getting around, making their meals, going to the bathroom. The side effects were very well tolerated. The key things here were fatigue, dry mouth, because that does go to the salivary glands, so they can get a little bit of a dry mouth, anemia, which is red blood cells going down, some pain, and thrombocytopenia, which are your platelets going down. Most of those things were self-limited, and the patients did very well. Okay. So because of that, the FDA approved PSMA therapy, and they called it Pluvicto, okay? And this is the actual FDA language. They basically said, in a patient who has failed everything, including advanced hormonal therapy and chemotherapy, who has a PSMA PET scan that shows a PSMA score of 2 or 3, so they have to be hotter than liver, they can go on and get this therapy. Okay. So what do we do in our side? Our workflow is somebody says this patient might be eligible. Well, we go in and we dig into the record, we go through all their scans, and we decide, do we need to discuss this as a group, or is this a straightforward patient where everything looks great, we just move to therapy? If it's not, then we'll discuss it at our tumor board, and we'll discuss that patient and make sure we're all in agreement that this is the right choice, and then make the recommendation and talk with the patient. One of the things we're looking for is not only do we want to see that the radiopharmaceutical goes to their tumors, we want to see that there are no tumors in the body that are alive and growing where the drug didn't go to the tumors, okay? Because those patients, those tumors are not going to be treated. So we're going to be very careful in looking through all of that. And then we'll meet with them, we'll talk about the safety. And I don't have time today to talk about it, but we'll talk about radiation safety. How do you make sure when you're taking a radioactive therapy, all the people around you are safe? And the key thing is, don't let anyone drink your urine, okay? If you can remember that, most of the rest of the safety things are pretty easy and of less of a concern. I'm going to talk about supply chain shortage, okay? So you guys may know, because you've got friends and you know about this stuff, you guys are so well educated. If there were friends of yours or you are trying to get PSMA therapy, you might not have been able to get it yet. You might be perfect candidate for it, but Novartis had some supply chain issues, and I'm not going to go into the details. These are good people. I mean, people in Novartis invested, $8+ billion in radiopharmaceuticals, more than half of which went to prostate cancer. They're really investing in trying to move this field forward, but they've had some supply chain issues. So we had a supply chain issue, and our pharmacy group sent me a note saying, well, we need to have a plan for how to deal with this. And they said, how much Lutathera, which is another drug, and Pluvicto, the prostate cancer, do we have in stock? Which we thought was hilarious because, as I showed you before, these things last for a day. So we have none in stock. So because of the way these drugs are made and the way they're used, they live for a few days and then they're not useful anymore. So when we have supply chain issues, it's a big disruption. We have an example of a patient came all the way from Alaska to Minnesota for their therapy, and then they get here and we find out that there was a failure of production. So we work really hard to try to make sure that we've got all that lined up. That stuff is getting better, but that is an issue. Okay, so how do we improve efficacy? What are we doing going forward? Well, some people are thinking, well, geez, we could even inject into the arteries, go right down where the prostate is and deliver the therapy prior to surgery. There's all kinds of crazy ideas out there. Combining the PSMA therapy with other therapies is also a really great idea. So we've got trials where we're combining PSMA therapy with hormonal therapy, combining it with chemotherapy, combining it with immunotherapy, where the PSMA therapy stimulates the immune response even better. Whether we combining with external radiation. So in other words, you might say, well, why would you use a drug that's radioactive and external beam radiation at the same time? Well, the reason is you can hit the tumor twice. You can get twice the therapy to the tumor, but the external beam radiation, it's injuring the tissue around the tumor. The radiopharmaceutical therapy that we do with PSMA, if it's going to injure anything, it's injuring those other organs and things where you see the drug on the imaging. So it's the side effect profile is different, and you can double hit the tumor. So we're very excited about that. We're also excited about bringing cocktails of different drugs that are all radioactive, that are slightly different in terms of what they're targeting and what kind of radiation they're bringing. Okay, so how do we follow up the scan? Okay, so you've got your PSMA therapy. We want to know, how's it going? Is your cancer progressing? Well, we can image with a CT scan or an MRI or a bone scan. But as I showed you before, they're not that great. There's a lot of cancer we can't see very well. We can follow your PSA on your blood tests and other kinds of advanced blood tests, but we can't really figure out how best to use that information in every patient. So people are starting to use PSMA imaging, such as PET scans or other ones, which I'll show you in a minute, to follow up the patients, suggesting that if the PSMA drug is not going to the cancer anymore, the cancer is probably dead. Okay, so one thing that we and others have thought about, and we at Mayo and a group at Stanford and a few other places are soon following, are using a brand new technology called SPECT CT. This is different than PET. SPECT is single photon emission computed tomography. A PET scan, remember, has 2 photons. SPECT has 1. It's actually an older technology. But the cool thing about it is, with the newer digital versions of this scanner type, we can scan fast enough and accurate enough to make it worthwhile. And more importantly, instead of imaging the PET radiotracer, we inject the therapy drug and we actually image the therapy itself. So after you get the therapy, we image and prove that the actual therapy, radiopharmaceutical, went to your tumors exactly as planned and see how they're responding. So it's different than the old type of detectors. It's digital, high-tech stuff, super thin, super small. And one of the cool things about it is, as the number of photons coming out of a tumor from the therapy goes up with CZT, this new crystal, we have an almost perfect line with the amount of drug or radiopharmaceutical in the cancer. Whereas the older technology, if you have a lot of something in the target, your data just drops off. So in other words, it's better. It's just a better way to quantify how much of the therapy went to the tumors or to organs. The scans look basically the same. One of these is digital, one of them isn't. Inside the scanner, it's completely different. So the system here has the digital detector system with CZT, and it's much, much smaller. You can see how much smaller it is than the standard system. You need all this stuff to create an image out of the old system. That allows us to design scanners that focus in right on the patient. So it literally has these arms that come in. See these little things? It's really funky. So after every cycle, every injection of PSMA therapy that we do, a patient goes on this new kind of CZT digital SPECT scanner These little arms come in and we verify that the therapy went exactly to their tumors. We get a sense of how much went to their tumors and to their organs and whether the tumors are responding. And there's 2 different companies making these. We installed the 3rd one in the world with Spectrum Dynamics, a company out of Israel that we've been working on for a couple of years now, and we're scanning our patients now. Next month, we're installing one made by GE. Similar technology, has some pros and cons, and we're working with them as well. So I'm going to skip that in the interest of time. I'm going to skip down a little bit and show you how this works. Okay, so if you go to an institution and get your PSMA PET scan, like you see here, and then get your PSMA therapy, they might send you out the door with no imaging to confirm where it went, or they might use the older scanners to just get a single, kind of like a plain, like a 2-dimensional photograph. And you can say, okay, on this 2-dimensional photograph or planar image, I can see each of these sites of cancer that were in the PET scan. Yeah, it kind of looks like the therapy drug went to each of those sites. It looks like we got them all, okay? But you can't really look and measure how much went in there. By comparison, this is what we're doing. This is a patient you saw before who's got metastatic disease on their PET scan MIP. You can see it's in their lymph nodes here, it's in the liver, it's in the bone. This patient then got their first dose of PSMA therapy. And then after the therapy, they got that funky SPECT scanner I was showing you before. And in this patient, it's beautiful. We can see each of those sites on the SPECT CT and confirm that the therapy drug went to each of those tumors, and a lot of it went to each of those tumors. And you might look at this and say, okay, well, if that's always the case, why do you do it? Well, it's because it's not always the case. Sometimes the differences between the imaging and the therapy drug make a difference. Sometimes the patient's tumor has responded to a therapy, or something else has changed between the PET scan and the therapy dose, which we make the SPECT scan out of. And then those things make a difference in how we plan the therapy. Okay, this is kind of a blow up of that same image. And this is that same patient. Now we've got, this is their PET scan before therapy. This is their SPECT scan where we're imaging the therapy itself after they got their cycle 1. And here's after cycle 2. And this is exactly what we're looking for. This is great. I see the salivary glands, the tear glands, the lacrimal glands, all of that stuff looks the same. It hasn't been hurt by the therapy. But each of these hot spots of actual tumors, they're all getting less bright or less dark on this image. There's less therapy going to them because more of the cancer cells are dying. And so that's exactly what we're looking for in these scans. So what's in the pipeline coming down the road that's going to be even better than the therapies we have? What are the concepts around that? Well, one of them is target binding. In other words, can we get more of the radiopharmaceutical therapy to the tumor? Another one is, can we use the imaging to predict how much therapy we need? In other words, we've got all this great imaging. We can actually calculate how much radiopharmaceutical went to the tumors. We can calculate how much radiation it deposited in the tumor. And so if we take that information, and maybe Mr. Smith and Mr. Jones don't need the same injected dose of therapy. Maybe Mr. Smith needs more than Mr. Jones does. And why would we put a patient at risk and give them more than they needed? Or why would we not give them enough? So that's an area of a lot of excitement. It's called dosimetry. In other words, calculating the dose specific for the patient. The other one is, can we just bring a bigger hammer? So I got this picture of a hammer here. So in other words, right now we're using lutetium as the hammer. That's what's bringing the radioactivity to kill the cancer. Well, can we just have something other than lutetium that's a bigger hammer? And yes, we can. And there's a lot of excitement about it. Can we design drugs or therapies that have lower toxicity? That's another key aspect here. Okay. Another thought here is, can we use the drug we already have? And can we use it in a different group of patients? So we have lutetium PSMA 617 or Pluvicto, and we can march it back in the continuum of care. So right now, as I said before, we're using it in patients who are at end of all their care options. They've failed everything, but it has low toxicity. In other words, people do really well. They don't have a lot of side effects. So why don't we move it earlier? So we've got the PSMA-4 trial, which is now closed for accrual, where they're trying to use it before chemotherapy. after hormonal therapy. In other words, maybe we don't need patients to fail chemotherapy to try this new exciting therapy. PSMA addition is to say, well, before chemo and now actually at the same time we're giving hormonal therapy. Before they've even failed hormonal therapy, we want to give the PSMA therapy. There's even a group out in Germany that are doing what they call the lutectomy trial, which is cool. They're using PSMA therapy prior to surgery. And they're saying just an initial trial to say, hey, does this work? You know, is there any evidence that this is worth doing? But to say, let's kill as many cancer cells as we can and then do surgery to see if it reduces the chance of the cancer coming back, which would be a very cool thing if that was true. Now, I've talked about how great PSMA therapy is, but it's not perfect. In general, we're not curing patients. And so I think there are some people out there, they look at the imaging that I just showed where you have a complete response and they think, doc, this is going to do it for me. This is going to get rid of my prostate cancer. And I got to tell you, I'm hoping it does, but it probably is not going to. And what can we do? Well, we can do different things to modify it like I talked about, but I wouldn't expect it to cure you. Okay. Maybe, however, if we used it early in the course of care, like I said, prior to surgery even, we could cure somebody. That's possible. Another hope is that can we use it chronically? In other words, how many cycles of this can we give? Right now, we're limited to 6, and we're not getting insurance companies and Medicare to pay for more than that. But there's good evidence to suggest that if the tumor responded before and it comes back and it's still showing PSMA activity on our PET scan, that we can treat you again and expect a good response. So we're hoping that data will come out that we can convince people to pay for it. But we could potentially treat for many, many more cycles and keep kicking the cancer back and keep kicking it back and keep kicking it back. All right. So now I'm going to talk a little bit about the bigger hammer. And I want to talk specifically about alphas. And this is kind of close to the end of the talk. What is an alpha radionuclide? Okay, lutetium is actually a beta radionuclide. It's different. An alpha is basically a bigger hammer. Okay, here are 2 examples of alpha emitters that are in phase 1 trials. One is actinium PSMA 617. So it's exactly the same as the therapy we now have, but instead of lutetium, it has actinium as its radioactive atom that gives off an alpha. Another example is a completely different structure, but it targets the same PSMA receptor on the cell surface. And here it's bringing thorium in, and that's a drug being developed by Bayer. So when this image came forth in 2016 by a group out in Germany, the whole field just got so excited, okay? I showed you before patients with lutetium PSMA showing complete responses, but not all of them do. So here you have a patient, this was in Germany during old testing before FDA approval here in the US. Back in June of 2015, their PSA was 294. This is a PET scan. You see this is cancer, cancer, cancer. There's tons of cancer in this poor patient. They did 2 cycles of lutetium PSMA, the one that we now have FDA approved. And unfortunately, their cancer progressed. You can see it's bigger. It's all in new places. It's grown on the image here. And the PSA has also gone up. So either we didn't give them enough of the therapy, maybe we needed to give them more, but we gave them, or they gave them the standard amount of the therapy that we currently give. They then switched to an alpha emitter, actinium, and after 2 cycles, the cancer is almost completely gone. 1 more cycle, it's undetectable. So this is just one case example, but you can see at least how excited people in the field are that these alpha emitters are more powerful. Unfortunately, if you look at this patient, you can see also their salivary glands. See how their salivary glands don't have activity anymore? They were nice and robust here, and now they're not. This particular therapy, as effective as it is, causes severe dry mouth that's permanent. And so as we're trying to figure out how to use these, we got to make them effective, but we also have to make them tolerable. And so there's a lot of work going on trying to figure out how to get the right balance there. So what's the difference between an alpha and a beta? an alpha therapy is bigger and more powerful and more precise, okay? Some people would say if you put it all together, it's 5 times better. But the clinical data suggests that it's even more than that. It's probably doing things that we don't even fully understand and how it's killing. And so one of the things we know that it's doing is it's overcoming any resistance. In other words, a beta therapy like lutetium PSMA, some cancers are resistant to it. Their genetics of the cancer, their mutations, their environment, they have protected themselves against that kind of radiation. An alpha kills them all, okay? So what are the difference? Again, on the left here is beta, on the right is alpha. Technically speaking, a beta is an electron shooting off of the radiopharmaceutical and killing the cancer. It goes, for lutetium, a couple millimeters. So it shoots across several thousand cells and kind of injuring them all a little bit. So you need a lot of them to kill a cancer. Whereas the alpha is more than 1,000 times more massive. It is actually the nucleus of a helium atom. So it's 2 protons and 2 neutrons. It's going to go a much shorter distance, just 2 or 3 cell diameters. So basically, it's going to annihilate the cell it's on and just a couple cells around it, okay? It's going to kill even tiny tumors where there's only a few cells of cancer floating around, where the electrons, the beta therapies like lutetium, little tiny tumors, we just don't have a very good way to kill because the drug is shooting its electrons all over the place in the tissue around it rather than focused right on the cell it's bound to. And it overcomes resistance. And there you go. That's how you get this amazing response. So the last couple things I'm going to show you here is, one of the things we get to talk about is when you're traveling, okay? If you're getting lutetium therapies, lutetium PSMA, Pluvicto therapy, you're going to set off bomb detectors. They're going to think that you are messing around with stuff you shouldn't be messing around with, making radioactive bombs. Now, luckily, as more and more patients get this therapy, they get more used to it. Now, they know about the therapies we've done for years. We've been giving therapies to patients for thyroid cancer for years. Their detectors pick those up. They know what they are. We give every patient a little card or a piece of paper that says, I got this therapy. Please don't slow me down. Let me get on my airplane. Let me go, across the border. Let me get on the train. But because lutetium PSMA is rather new, some of these guys get pretty worked up and excited about this, and they pull our patients aside. So this here is the milliwave detector, where you put your arms up and it scans you, and this is a metal detector. Those are not the detectors that detect the prostate cancer therapy in your body, okay? It's the guys like this walking around in security with these little handheld devices, and they'll go off, and they'll be walking around, and they'll detect that somewhere in the room, somebody has radioactivity on or in them. And they'll be walking around. And I remember talking to one patient. He was like, yeah, doc, I'm sitting there, I'm going on a flight to Europe. And all of a sudden these guys start walking around in packs, and I can hear them. They're all excited. They're talking, and they start converging slowly around me. And so I just raised my hand and said, guys, I'm your guy. I'm the one who's setting it off. They warned me about this, right? And so they brought him aside. And they talked to him. I said, have you been messing with plutonium? Have you been messing with uranium? He goes, no, I had this therapy. And you get to give him this get out of jail free card. So hopefully, when you go out golfing, you can talk to your buddies about this great story you had, and hopefully it doesn't delay you, but you should plan some extra time. Okay, what else is exciting going on? This is really exciting. There's one slide on this topic. There's a huge leap forward in PET scanning coming forward. This month, we're installing the first in North America of this scanner called the Quadra by Siemens. It is a longer scanner with really high-tech stuff in it. It is 10 times better than our best PET scanner. 10 times, 1,000%. We're going to be able to see prostate cancer hiding in little tiny spots. There's another company called United Imaging Healthcare that has a similar scanner. They've got one in UC, University of California, Davis, that they're using for R&D, and they've got one up in Michigan. So these technologies are coming forward. We're going to be able to see cancer hiding in teeny little tiny spots. We can do a scan in 2 minutes of the same quality as our current, half an hour PET scans with this scanner if we wanted to. Okay, these are the last few slides. I've talked to you about PSMA. Now I want to talk to you about other targets on cancer cells, bombesin and FAPI. Here's an example of a MIP image with a drug. This happens to be a copper radionuclide for PET imaging. Bombesin is the name of the binding motif to stick to the cancer. And these little tiny dots are all prostate cancer all around here. Beautiful image, very low binding to anything else, very exciting. And this is something that we can use in multiple kinds of cancers. It's not just prostate cancer. Here's another one we're excited about. We're doing quite a few trials. I actually I'm a co-author on an NIH grant looking at this one. This is called FAPI, or fibroblast activated protein inhibitor. It's also a pan-cancer, although it has multiple cancers. This is a prostate cancer patient. All these little dots are radiotracer going to the tumors. The interesting thing about this one is that it doesn't bind to the cancer cells itself. It binds to the body's cells responding to the cancer. So all the scar tissue the body makes around the cancer cells, trying to wall them off, is what it's sticking to. And it lets us see cancers we otherwise can't see. So with that, thank you so much for your time. I'm delighted to be part of this. Again, to all the prostate cancer patients out there, we are in this together. And I hope this clarified and explained some things for you as you figure out what your next steps are.
Anything before we start that you want to say about Dr. Kwan? Would you like to comment on his lack of athletic ability in general, or would you like to say anything semi-nice about him?
Eugene Kwan is a remarkable person. He is the best patient advocate that you could possibly have. In other words, that guy's calling me all the time. What about this? What about this? Can we get this patient in? What is this guy? But at the same time, you're like, if I had, as I mentioned, my father and I both have prostate cancer. If their cancer progressed to the point that they need someone like Eugene Kwan, he'd be the first on my list. There are lots of other great people out there, but he's funny and he's dedicated. He remembers his patients. But yeah, he'll keep pestering you. If he's not happy, he'll keep poking at you. I need this, I need that. That's not good enough, but you need that on your team. You need someone who's going to go to bat for you.
That's well said. I mean, a guy calls me at 6:30 in the morning, which I know is 5:30. I'm going, does this guy have no life? I mean, what is, I don't want to.
No, he has no life. He has no life. No, he has no life at all. I mean, they can tell he doesn't have time to cut his hair. That's why it's so long.
That is a good one. I love it. Hey, I'm not just, we kid him because, you kid the people you adore, but he always looks like he's running from room to room, but he always tells me that you guys are always running from room to room. So do you have any comment on, before we just kind of hang out in the prostate world, do you have any comment in your field about, is there another place besides prostate right now people should be getting really excited about what's going on, whether it's PET CTs, whether it's radioligand therapy? I know there's a lot going on in neuroendocrine. You showed one quick slide of, is there one category that you're kind of leaning into besides prostate going, hey, that's pretty interesting? Because I looked at all your papers that you've done. I always do that in an interview. Mm-hmm. You showed something with hepatocellular carcinoma. Right. And so can you comment on that, your excitement outside of prostate?
Well, I think there are a lot of cancers that we can go after with this technology. It's easier said than done. Like, you have to have the right ligand. It has to stick to the cancer and get out of the body. If it's not stuck, you want it out because it's just going to be giving off its radiation. So it's a different mindset than a regular chemotherapy. But we need so few molecules of the drug to stick to the cancer to be effective that it opens up all kinds of doors. So, we've got grants going in on pancreatic adenocarcinoma. We got one actually on that. We've got a grant going in on HCC, hepatocellular carcinoma, that you just talked about. I'm not the PI or the principal investigator on that, so I don't want to get into too much of the details, but using radiopharmaceuticals to try to image and kill hepatocellular carcinoma. And these are tough cancers to get your hands around. They've been resistant to so many different things. And, if we can get an alpha emitter to a cancer cell, I think we can kill it. I think that's where the promise is. So it's like, if you can just figure out how to get it there and how to not have it stick anywhere else, causing side effects, you may have a winner. And I think a lot of people are saying the same thing. I mean, that's why there's a lot of investment in this field. There are new companies coming out every week, some new companies sprouting up saying, we've got some new technology, we've got this new thing. It's going to settle out. Some of them are going to fail, but the excitement is there. And in particular, the supply chain of these things are being worked out. It took that kind of investment and effort to get us to where we are now. And that's a big part of it. So if you go back 10 years ago, 20 years ago, the field tried to launch some therapies and they worked okay. They didn't have a good business model. They didn't have a good supply chain. They failed to kind of become a big thing. And it put a damper on the whole field, but that is completely changed. It's going gangbusters right now.
That's really cool. That's really interesting. I want to just dial back before we just spend the rest of our time on the PSMA stuff. I just want to dial back with this. So in the past few years, the patients are being inundated with the PET-CT idea.
Yep.
And so do you mind, I want to walk through these and just off the top of your head, just some commentary. It doesn't have to be anything deep. It's just, I want to start with choline because, we now, I don't know, we're now 10 years or so since Mayo got approval, right?
Yep.
So pros and cons of choline in terms of its use today, because I'm assuming you still use it at Mayo somewhat, right?
Oh,
so
yeah.
Can you walk me through sort of pros and cons of choline in today's world? Even if that just means Mayo Clinic, that's fine.
Yeah, I mean, choline is hard to make. It's hard to ship. So it was not something that could easily become usable across the country. But it's very effective, and we know what we're doing. We do about 4,000 to 5,000 of them a year of those PET scans in prostate cancer patients. So we know what it's like. We know that it's kind of a metabolic agent. So in other words, almost every prostate cancer that you can think of is going to take it up if the cancer is big enough. And so it still has a role to play. We also know that if the cancer is dying from whatever therapy you're giving, the cancer doesn't light up with choline anymore. So it's a great measure of response in the way we use it in our practice. Fluciclovine, quite frankly, is very similar. In my mind, I think of the two as interchangeable.
Really?
There was a study years ago saying fluciclovine might be a little bit better, but I would caution that study was done with an incorrect protocol for the choline. It was done with a European style in Europe, where that's how they use choline, and we use 3 times more of it with each of our scans here. So obviously the scan ends up being a better quality. Okay. So in general, they're equivalent, but PSMA, we just see things we couldn't see before. Just really tiny little lesions, things that are hiding that you can't see on either choline or fluciclovine in a lot of patients. And some patients, it doesn't matter. Let's say I can see 10 sites of cancer with one scan, I can see 20 with the other. Maybe that doesn't matter, but you don't have to go very long before seeing the cancer in more locations, and seeing it earlier and smaller matters.
Okay.
Yeah.
So before we go back to PSMA, and that's interesting. I mean, you're still doing these, and it doesn't sound like you're going to be getting rid of these anytime soon. It sounds like they're gonna play some role, because you must have cases where you don't see something on the choline scan, then you do a PSMA and you see something. And is there a vice versa there? I mean, there is. Can you tell me about that?
Yeah. So if you look at one classic example, and we've got a study that's showing up at RSNA, the Radiology Society of North America, coming in November, where we looked at about 200 patients who had both choline and PSMA. And one of the things we saw was the urine in the bladder. As I showed in the images, the urine, that's how you're getting rid of PSMA, right? Your body is putting it out, your kidneys into your bladder. And so that urine has so much activity at the time we take the scan. I mean, it goes away later, like you pee it out, right? It doesn't stay there forever. But an hour after we inject the PSMA is when we do our imaging. And so where's the prostate, or where's the prostate bed? In other words, where the prostate used to be before surgery. It's right up next to to the bladder.
Hmm,
So
right.
all that bladder activity clouds our ability to see some of the cancer, especially if it's in the bladder wall, like it grew up into the bladder itself. We can't see that. Those we'll see on choline, because we image with choline. We literally put the patient on the table, we inject them, and we scan them right away. It gets to the tumor so fast, and they suck it right up. So we see the cancer in that area before the kidneys even start getting rid of it, before it even gets into the bladder. So those are examples where choline is better. If you look and said, okay, about 10% of patients who have prostate cancer, live prostate cancer, have a negative PSMA PET scan. Now, some of that is because the cancer is too small, little tiny bits we can just beyond our resolution to see. But some of those are patients who actually have prostate cancer that just doesn't express PSMA.
Right.
Okay. And we know that both populations, that we have examples of that. So if the tumor is big enough but not expressing PSMA, and we look at it on a PSMA PET scan, we might see the tumor on the CT, we might not, but it's PSMA negative. We're like, is that alive or dead? Right? Is it alive? Right? So one of the studies that Hoffman did in the therapy trial and some other trials, he led it. It was a whole group in Australia, was to look and say, okay, they don't have choline that they're using so much. They used FDG, or glucose, which is also on your list. Okay.
Right.
And say, to me, they're both metabolic agents. So they said, look, if the tumor shows FDG activity, glucose, it's taking up sugar, it's consuming energy, it's alive, right?
Right.
We see it on that PET scan, but we don't see the PSMA radiotracer going to it. Then we know it's alive, and we're not going to be able to give it, the therapy's not going to go there, right? So that's another way in which I envision people will use choline and oxymin, is to say, okay, I not only want to know that the patient has tumors that have PSMA activity that the cancer therapy is going to go to, I also want to know if all of the big tumors that I expect to be able to see are lighting up with PSMA, right? So one cool thing, you asked about what's cool, with these new PET scanners that, meter long, 10 times better than anything we had before, we're developing technology, other people are as well, where we can image with 2 radiotracers at the same time. So I envision a potential future where we say, okay, we give you PSMA, you come onto the scanner, and while you're sitting there, we add choline, and we say, okay, now not only do we see the tumors that are PSMA avid, but we can pick out if a patient has a live tumor that's PSMA negative, and really decide, what's the best therapy, how do we combine therapies to get to where we want to go. So those are different exciting things about how to bring them together. I mean, choline and oxymin may have other purposes with other tumors as well, which kind of goes beyond prostate cancers. They're not going away. But I do think that most people say PSMA is a better scan for most patients, maybe 90% of them.
Yeah.
But, there's also a really big role for choline and oxymin.
There's a rumor out there that still, I talked to Eugene about this, Dr. Kwan about this. We always talk about this on the side, that is there still sort of trying to figure out the lay of the land with insurance and getting these things covered, or is that not a problem, or is this just still,
oh my God, yes.
Is this still a mini nightmare?
It is still a mini nightmare. So, so I'll tell you what we did. So when there's different answers to that question, and everything, I've probably got 10 stories to share on that. But so when PSMA therapy got FDA approved back in March, we were all blessed with this new information that said, oh, by the way, you can only select a patient as eligible for therapy if they had the PSMA 11 radiotracer for their PET scan, not the F18 version, the PYL or Polarify, right? Mm-hmm. And then you look across the country and you say, okay, well, how many sites that are doing PSMA PET scans are using Polarify? And it's like 90%. That's a guess, but it's somewhere in that range. So out comes this report saying you can't use that scan to select a patient for the PSMA therapy, even though all the societies and like the thing I showed in the slide, they all got together, so they're equivalent, right? Now, hopefully that message is getting there, but we get insurance companies saying this patient had a Polarify F18 PSMA PET scan, and that's not the right scan. We're not paying for the therapy. So, and we also didn't know what Medicare was going to do, because Medicare doesn't tell you. They're like, oh, just submit it and do it according to the rules and we'll pay you. And if it's not according to the rules, we won't pay you, but you won't know until later. Right. So it's, you're like, great, thanks. So what we did was say, okay, we have the technology to make our own gallium PSMA 11. Okay, we can make the gallium, we can make the PSMA, do it ourselves. We already had an agreement with the government. I had a trial running where we imaged like 200 patients early on before the PYL became available, the Polarify. And so we just extended that and said, you know what? We're just going to do it for free. You know, you come into Mayo, you want to get onto the PSMA Pluvicto therapy, and you maybe had a prior PET scan that was the quote wrong kind. We're just going to do the scan for free. We'll just do it in our research center. We'll make the radiotracer, we'll read the scan, and we'll eat the cost to get you through. And we've probably brought about 250 patients through that. Actually, that's an exaggeration. About 150 patients through that expanded access trial. Technically, it's not expanded access because we're not even billing for it. But you know, hopefully that'll go away as time goes on. But you know, there are a lot of places where they're doing everything right. A lot of institutions, hospitals, do everything right, and you know, the insurance companies are just they don't have the paperwork done. They haven't made their plan yet. They're denying based on these silly differences in radiotracer. And to give the FDA a little credit, when they came out with that, they said basically, I'm putting words in their mouth, which is dangerous, but they basically looked and said the VISION trial used PSMA 11, the gallium PSMA 11 PET scan, to select all the patients for the therapy. So it is well within their purview to say, that's what the trial said. I don't, you got to prove to me that the other PET scan is equivalent. We say, look at it, it's equivalent, but it's kind of back on us as the medical community or on Novartis or other companies to prove that it's equivalent. So, we'll get there.
Man, that is a migraine in the making. So
Yep.
that's it. But it's sort of a call to arms. It'll be interesting because with all the advocacy groups getting stronger and stronger in prostate, maybe they can have a sort of a quiet movement and sort of helping move these things to help them get approved. We'll see.
I think we'll get there. I'm not particularly worried about it. We're seeing progress in that regard, and to give credit to the societies and, I remember Tom Hope out at UCSF making, quite a bit of grandstanding on this and other people trying to get the message out. I think we're getting there.
Okay. But it's really interesting because when you definitely paint a picture where these all still stay in play.
Yep.
They might be able to be combined. You might move from one to another. And then that makes me immediately think and give this some thought, because I've talked to a lot of radiation folks over the years, and I still don't know what the best answer is, because we get a million of these questions. Am I being exposed to too much radiation? So now let me answer this for you. Let me tell you what the standard PC answer is, okay?
Okay.
And it makes me a little wacky. The standard PC answer is, well, it's about the same amount as you get background environmentally, or it's the same amount you fly from Detroit to LA. And I'm going, that's fine, but that really doesn't tell me, should I be worried or not? That's the question. So the question is, from what I've seen from a public health standpoint, the bigger concern of radiation exposure, this is my novice answer, has been at younger ages. But when you start to go to middle age and older, these become less of a concern. Tissues are differentiated. So tell me if I'm wrong or right. And can you elucidate on that? Can you give a little bit better explanation than I'm giving?
Well, so the principle is ALARA, as low as reasonably achievable, right? So and I would say, on the grand spectrum of things, we as a community worldwide are more nervous about radiation in terms of imaging than we should be. And my view, and this is, just me speaking personally, is I want to know exactly where a patient's cancer is so we can make a good decision, so we can do exactly what they need. And the chances of them getting a secondary cancer, which is the concern, right?
Yeah.
From the radiation of the scan is, as some physicists would say, undifferentiatable from zero, right? This is their language, right? So I can't tell the difference between your risk of getting a secondary cancer in your lifetime, having had these scans versus not, right? And we do push down the radiation, but I think a lot of people push it down inappropriately so, where you can see a difference in the quality of the imaging. And you know, okay, if we, so a lot of times they'll do these kind of studies. They'll say, okay, we're going to compare this kind of scan versus this kind of scan and show that in 100 patients, no differences in clinical decision were made, right? Fine. But then you start saying, okay, but we know that that's an improvement in imaging quality. Like we can see the images are better, right? I can just tell you they are. But you start adding those up and you have improvement after improvement after improvement. All of a sudden, there's no way to compare. I mean, you look 10 years ago, 20 years ago, what a CT scan or a PET scan looked like compared to today. It's just mind-boggling how much better they are. Luckily, we're also reducing the radiation exposure to the patient at the same time. So, you know, when you look at that new PET scanner I showed you, the Quadra, the meter-long one, you know, we can either get a much, much better PET scan, a much faster PET scan, or lower radiation. And in other words, inject less of the radio tracer to make the same quality image, or a combination of the three. So, but the problem is that kind of scanner is super expensive, right? So you got to balance all of these things as you're going forward. And at a site like ours, where we do 120 PET scans a day, fine. You put in a scanner that can scan that well and that fast, and we figure out how to do it. The cost comes down. Eventually, it goes to everybody. But to cut back to the chase, if you're a middle-aged to elderly man with prostate cancer, don't worry about that. That is not, the radiation exposure and the secondary risk of cancer is not something you should be being worried about. You know, I guess you'd have to trust the medical community that we're not inappropriately radiating somebody, but, you know, have the conversation with your doctors and go for it.
That's really well put, because I just don't know. It's not Nuke Med. I don't know who it is. Just the way they've tried to mollify, the way they've tried to say, don't worry about it. It's just not registering with me, you know? And then when you try the flip side where you say, well, this scan is 1,000 chest x-rays, and you go, 1,000.
Yeah.
So, I mean, it's just, it's somebody's got to come up with a better wheel on that one, because it seems to me too, that we are being overly concerned about it, but we're not explaining it well.
Another way to say is, you know, we're going to use the same kind of radiopharmaceutical, same kind of drug to treat the cancer where we want it to injure the cancer cells, right?
Yeah.
So, you know, it's where the benefit is clear, right? You see the cancer melting away in some of those patients. You know that their quality of life is better. You know they're living longer. You know that's radiation. That's the benefit of it. And so you got to balance all of those things. I mean, if you were to try and bring sugar, I went in one of the courses I had in college. I was in the kind of biomedical business school. I was learning this stuff, and they're like, okay, write a paper to try to get sugar through the FDA, right? Or like write a proposal. The sugar, let's imagine it's not natural. You just invented it. And they pointed out how it's absolutely impossible, because what does it do? It flavors your food, and it has a little bit of energy it gives you. It's got no nutritional value beyond that. It causes diabetes, obesity, you know, boom, boom, boom down the list of all these horrible things. It's, in some people's opinion, addictive, huge problem, right? But we're not talking about sugar in the same way we talk about radiation, where we've got here a drug that actually is FDA approvable, that actually cures cancer, but I take that back, doesn't cure, but fights against cancer effectively. Yeah. And, you know, so that's really, it's an interesting conundrum. The real worry is that radiation makes things beep, right? It makes beep, 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 beep. And that beeping is like the worst thing we ever did in the field of radiology and field of nuclear medicine, because that beeping is scary, right? Yes, and that's the beeping that drives people nuts. If you did chemotherapy in a patient and you could actually measure the chemotherapy coming out in their urine and other things like that, you would recognize that those things are also at risk to the environment. Radiation, radioactive drugs, they go away, right? Yeah. So the best thing about this is, you know, it's going to be gone within days to weeks. It's not going to be hurting anyone anywhere. These are really short half-life radiopharmaceuticals. You know, they're very limited. They're very safe. So hopefully I gave you something.
You might have a new job as a spokesperson for the Radiation Exposure Foundation of America, whatever.
There you go.
That's it. That's very interesting. So,
no bias, of course, because that, you know, but granted, I'm on a salary, right? So I can say, whether I treat more people or not, it doesn't affect my salary. You know, I
Yeah.
want to help people.
Yeah. No, but I can tell you from a public health standpoint, that's my background. I wanted to join the rest of the group and go, you're overexposing people. And then when I really dug deep into it and all the little papers and all the little investigations, I thought, wait a second, this is not as bad as I thought. And
Right.
maybe it's not explained well.
Yeah.
Because I was falling for all those same things. You know, this is 10,000 chest x-rays and I'm going, oh my Lord. And so I really appreciate that. Well, that also brings up the concept of a lot of docs are running around saying, this technology is so great with PET CT that basically it's making bone scans obsolete. Do you agree with that?
If I had the choice, well, our PET scans went live in 2007-ish. Okay, we got FDA approval. The laws changed and we had to get FDA approval. They were like, either cease and desist all of the stuff you're doing or submit for an FDA approval. And we went, okay. So got it approved in 2012. As that expanded, our bone scan practice went way down. Because, you know, the bone scan is, again, PET in general is better than SPECT any day of the week, just as a technology, because we can see smaller things. We can see it more accurately. But the bone scan just shows you where the bone is healing, where it's been injured. You know, it could have been injured by cancer. It could have been injured by getting smacked in the head, right?
Yeah.
So, and you're not seeing anything outside the bones with any clarity. You're not going to see the lymph nodes. You're not going to see the liver mets. You're not going to see the lung mets. You're not going to see all that other stuff I was showing you. So, you know, if you were to say, okay, here's a patient who has cancer in their bones that we can see on a bone scan, well, it works really well. Fine, right? The other thing that makes bone scans not so good is that when the body is healing after you kill the cancer, actually the tumors get brighter, right? Because what are you looking at? You're looking at the healing of the bone. And so if you kill the cancer, the activity in the tumors go up, right? Mm. So it's really bad at trying to get a quick response and say, I gave you this therapy, is it working? You have to wait months before the body starts healing enough that it starts to go down. You say, oh, that did work. Mm-hmm. That's garbage. You know, like if you go and say, at the PET scan, if you're using choline or even PSMA, although people are still studying whether you can trust a PSMA PET scan or FDG, the glucose one, if the cancer is dead, you can image it and the radioactivity, the brightness of that tumor on the PET scan is gone. It goes way down really quickly. So you can image way before the tumor shrinks on an MRI, way before it shrinks on a CT scan. And the bone scan, you have to wait, you know, maybe months before the body heals enough that activity went down. You can say, oh yeah, that was effective. That makes all of our trial design difficult in terms of prostate cancer. So anyway, I'm pro PET scans. There are problems with them, you know, where we have to kind of read around, you know, how accurate is the change in the activity. I would say if the activity's gone, the cancer, and you saw it before, the cancer is probably dead. And that's probably enough right there to say it's worth doing the scan.
Okay, that's really interesting. What happens to, before I finish off with Pluvicto and those last few questions,
yep.
What's happening with MRI? I've talked to some people in the nuke med world and radiology that say, you know, we're going to fuse these. They're going to end up doing PET CT MRIs, and they're talking about all these great Star Trek-y kind of things. But what's the truth about MRI? Where's MRI going to be with this or not?
So MRI is a great tool for looking at the prostate and the prostate bed itself. It is difficult to use MRI for systemic scanning. Like a CT scan. It just takes too long and to get really high quality images. So it's really a great tool for saying, okay, there's a lesion right there in your hip or right there in your shoulder. You know, what is it? You know, is it alive? Is it progressive? Those kind of things. It's really good at helping us to differentiate. Okay, let's say you got something on a PET scan that lights up. You don't know what it is. You're like, I don't think that's prostate cancer. MRI is often really helpful to differentiate those things. So it has all of these different roles. Now, if you said, what about MRI in a PET MRI where you're doing both at the same time? Okay. Right. And so that's something I've actually spent quite a bit of time with. So back in 2015, we launched our PET MRI practice, and they decided to put me in charge of launching that at Mayo. And a lot of people were involved, right? But it was a big new technology, expensive new technology. So what is it? It's a PET scanner inside of an MRI scanner. So unlike I mentioned, the PET CT is kind of like two halves of a bagel.
Yeah.
PET MRI is a PET scanner with an MRI wrapped around it. So one of the key differences is you can actually image the MRI and the PET scan simultaneously. Whereas a PET CT is you slide through, zip, you get your CT, you slide back out, and then you march your way through as the PET scanner is detecting the photons coming out from the radiopharmaceutical. So it's a CT is sequential, the PET CT. PET MRI is simultaneous. And so if you've got it, we really like PSMA PET MRI. It's gorgeous because what happens is when you're sitting, you scan the whole body, you get a okay MRI and a nice PET scan, similar very much to what a PET CT. We've worked out the details of how to do that, right?
Yeah.
But then you go back to the pelvis, maybe, if that's your area of interest, and you do a full diagnostic, multi-phase MRI with contrast, all the good stuff you need to do a good MRI. And the whole time you're scanning the PET scanner. So you're just collecting more and more and more data, and it's perfectly co-localized. It's all matched up. So as a result, you end up with, at the time, the best PET scan of the pelvis you'd ever seen. Now with these new long-bore PET CTs, they're challenging that directly. But so there are differences in how that technology works. There are PET MRI scanners that are different technologies as well, launched by different companies. We happen to have the one by GE, which has a digital kind of state-of-the-art PET scanner within the MRI. So what I'm saying is, I think for PSMA, for prostate cancer patients, PET MRI is a great tool, especially for patients who are haven't had surgery but are at high risk, intermediate to high risk, where they can get a PSMA PET scan reimbursed. If they have a recurrent disease where there's a high likelihood of having some disease in the pelvis, PET MRI is a great tool. We would do more of them if we had more PET MRI scanner availability. It's probably the most popular use of a PET MRI scanner in Europe is to PSMA PET.
Your name came up on a paper. I don't know if you have a comment on this, and you can. This is a great paper. It was called "Frequency and Characteristics of Nodal and Deltoid FDG and C11 choline Uptake on PET Performed After COVID-19 Vaccination." This is really well known outside of prostate, and your name was on here. And the concept was, like, of course, I love the vaccine technology. I think it's incredible. We had to handle a lot of the public health and vaccine information for prostate cancer patients for advocacy, but I don't think a lot of people realize what this means, in terms of, do you want to comment on this, that for a short period of time after you get a vaccination, like a COVID vaccination, you can get some lymph node reactivity? I'll let you go on, but this is a beautiful paper that I don't think there's an awareness in prostate, but should there be? And the floor is yours on that.
So for FDG or glucose PET scans, it became known rather quickly after the COVID vaccine came out that we were seeing things light up. In other words, the immune response to these new, there are several of them, Moderna and Pfizer vaccines, was pretty robust. And, historically you go back and we would see, okay, patient got a tetanus vaccine. Okay. You'd see a little dot in their deltoid where it was inflamed and injured, right? And the white blood cells would be going in there healing, and they'd soak up some of the glucose radiotracer as they're doing their work, and there'd be a little glowing dot. And maybe there'd be some lymph nodes kind of in the axilla here in the neck that would get bigger and light up, right? Because they're responding to the immune reaction. They're basically getting ready to fight, an infection. So, we knew that from years ago, but when the COVID vaccinations came, it was shocking how much there was. And so, like, if you had a patient who had breast cancer, right? And they come in and they're like, "Oh, doc, give me the vaccine too. I just got diagnosed with breast cancer." And then we get a PET scan, and all of a sudden we've got these lymph nodes all lit up, right next to where their breast cancer was. And we're like, Jesus, I don't know if that's cancer or not. Right. So we actually changed our whole workflow, and we said, every patient who comes in gets a standardized question from our team and says, have you had a vaccine recently? Which side did you get it on? And some other information. And that actually goes automatically into our reports, just to make sure it's not missed and someone is not going to make a wrong call or overreact to that. So, and usually it's pretty clear. You can see a little dot in their deltoid and the lymph nodes. Sometimes the deltoid injection site will actually heal up and look okay, and you still see the lymph nodes. And that's where you get worried that you're going to make a mistake. And we looked and said, well, okay, we've got all this data. We've got other people are reporting this because everyone's excited about anything COVID, right? It's all new, right? So we said, well, let's look at other radio tracers. And we found out, yeah, you see it with choline to a lesser degree, but it's there. You don't want to be fooled by that. Prostate cancer rarely goes to the axilla, kind of the armpit. So if you saw something and that's the only thing you saw, you'd be like, I don't really think that's likely to be prostate cancer. So you're less likely to get fooled, but it's there. So we like, okay, let's put it out there, make sure people know about it.
It's fascinating. I was just concerned that, there had been a couple of cases outside of prostate that showed cervical, some cervical nodes. And I thought, oh my gosh, how are they going to differentiate that? But like you said, I think the key is, letting your practitioner know how long ago you had your vaccine and when you had your vaccine, and just making sure they know that you had it. Because these are temporary reactions, right? They don't last that long. Temporary.
We've only seen a couple patients who were a month out who had a spot on the scan. Most of them, it's gone in 2 weeks.
I saw you give a lecture to a lot of docs, and it was really good, and you touched upon it, but this does not get much attention for awareness in the advocacy world.
Okay.
It's this concept of SUV, and what you were saying in one of your papers and your lectures is that to really believe that you have prostate cancer, you needed to reach a certain number. I mean, that I'm kind of paraphrasing. You needed a SUV. I don't know if you threw out 15. I forgot what the number was.
Right.
And so you talked about this, but then I thought to myself, we have so many people lecture on SUV, but to me, SUV, unless you explain it, is basically a type of car, right?
Yeah.
So can you just talk about the importance of SUV? Because as patients request more and more of their reports, they are seeing SUV on their report.
Yep. Again, going into controversy, back in the day, people argued about this, and some people called it a silly, useless value. So that there are all kind of names for it. But when you cut to the chase, what is it? It is a arbitrary scale of how much of the radiopharmaceutical is in a voxel, right? And maybe if I step back for a second, I think I mentioned this in the lecture, but if you look at a CT scan, okay, what is a CT scan? A CT scan is our best guess at how dense the tissue is in each voxel. Now, a voxel is like a pixel, but in 3 dimensions, right? And the whole 3-dimensional image of the body is our best guess at the density. So as the density goes up, bone is more dense than liver, right? So it's brighter. So we create, and we call those Hounsfield units based on a guy named Hounsfield, who was this famous guy who helped develop a CT scan, right? And so they just kind of make a scale, and they have the Hounsfield units, and then you kind of look at that and it's standardized. The same thing with the PET scan. So with a PET scan, we're not asking how dense is the tissue in each voxel like you are in a CT scan. What we're asking is, what's our best guess with all of our math, all of our physics, as to how much of the radiopharmaceutical is in that voxel? So it's a map of the whole body. Where did the drug go, right? So if you were to say, take a ball of water and you injected a radioactive radio tracer into it, you knew exactly what you injected, you knew the weight of the ball, you knew when you injected it, you knew how fast it kind of gave off its activity, which we call decay, and you mixed it completely perfectly, then the SUV in every voxel would be 1. Okay. So when we're testing our scanners, we actually do that. We have these things called phantoms, and we put them in there. We want to make sure that the SUV is as close to 1 and evenly matched in every area that the scanner is scanning, make sure it's doing high quality imaging. So you put in a patient and you say, well, if the SUV is, well, we injected in the blood, so it's higher, more concentrated in the blood, right? So it's higher than an SUV of 1 in the blood, even after an hour. A lot of it's going out in the urine. We don't even account for that. So if you're looking at a tumor, as the SUV goes up above kind of what's free floating around in the blood, you're getting into SUVs of 2, 3, 4, 5. You know that the radiotherapy or the radiopharmaceutical is accumulating, it's sticking there, okay? So if you said, okay, that tells me that the radiopharmaceutical went there. That means, so the higher the SUV goes, the more of what we injected went to that spot. That's what it is. So if you said, okay, well, Jeff, Dr. J, you showed me all of these things that that had different levels of PSMA activity, different SUVs. And as you're suggesting, Mark, as the amount of SUV gets higher, my confidence that that's truly prostate cancer goes up. And that's in general true. That's in general true. But, years of training and all the other imaging and all the clinical knowledge, all that stuff comes in to kind of say, do I actually believe that that's definitely a prostate cancer metastasis that's alive? Do I think it could be something else? Do we need to stick a needle in it? Do we need to get a tissue and look under the microscope and confirm it before we make our next move? And we'll look at things that are not very PSMA avid, and we'll say, that's prostate cancer. In this patient, it's just their tumor isn't expressing a lot of PSMA. So we gotta work through all that as a group.
So that's interesting. So when they see that value, because when you're not around, and I'm talking to other people, the devil's advocate side of the nuke medicine folks, is this something I really need to worry about? I mean, do you want to put this in perspective? I read so many papers on this, the false positives. We're just figuring out false positives, false negatives. I looked at a couple papers of isolated, like rib lesions. They turned out to almost all be false in this one series, right? And I'm going, holy SHIP, holy shit. Like I used to say to my parents when I was upset so they wouldn't get me in trouble. Have we figured this out? Is there really a lot? I read a paper from a very notable person the other day that said after someone's radiated, even though the cancer may be dead, it might throw out some PSMA. We still haven't figured out this whole false positive rate. So I give you the floor. Do you have comment on this? Have we figured this out, or we got a long way to go to figure out, false positives, false negatives?
So what you're talking about is something that has been around since we started imaging of any kind. Nuclear medicine, radiology, you name it. We see something. There are artifacts and there are pitfalls. An artifact is something that, the technology didn't work correctly. It created something that's not there, right?
Right.
A pitfall is something that looks like something you're worried about, but isn't. You just talked about one before, COVID, COVID vaccination.
Yeah.
So those lymph nodes will light up. If I read the scan and say there's a bunch of lymph nodes that have a bunch of radiotracer in them in the armpit, the axilla, the patient reports having a recent vaccination, that's almost certainly what they are. Is that a false positive? No, that's just a description of what we think it is. Now, I think what you have to realize is the technology doesn't just do what we want it. It's not like you can say to AI, hey, find all the cancer, right? So you have to go in there and say, okay, the radio tracer is going wherever it's going to go. And it's going to stick to the stuff that it sticks to. And it's on us to figure out, what to do with that. And as you scan thousands of patients and you start to see these cases and you start discussing them, that's what we're doing with all of our trainees, the residents and the fellows. We have, 5 fellows each year in nuclear radiology, specifically trying to get advanced training in PET, and therapy and such. And they're coming through, they're trying to get to that higher level of being really good at that. In some ways it's job protection. If it was just, where are all the hot spots, tell me where they are, then it would be one thing. But, you got people who say, well, you can't tell if it's cancer or not based on the SUV, right? So maybe PET isn't that great, right? In other words, I just want to cut off, if you got a hot spot and if it's hotter than this, it's cancer. If it's lower than that, it isn't. And it's say, well, you can't do that either with an MRI or a CT scan. You can't just say, oh, it's more dense in that spot. It's the whole picture. It's the whole scan. It's the patient history. It's all of that, and working as a team. But we're much better off with the scan than we are without it in terms of helping people figure this out. So we will continue to invent new things, and we'll continue to find patients who throw they throw curveballs at us. We're learning from our patients all the time. They're the ones coming in the door, proving to be interesting and difficult because not they're difficult, but their situation is difficult. How do we figure out how to do it better? And how do we learn from that and teach everybody? So, it's always there. And, if you go and say, okay, well, here's a scan, we're going to hand it to the community physicians who don't do very much of it. They're going to start doing it. How much are they going to screw it up? Well, it's on us to teach them as well. and to try to work together and make sure that that information's out there, make sure when they go take their boards exams, they have to know enough to be safe. But this is an ongoing challenge, and this is why you want a highly educated medical field working together as a team. This is why you want to have people on the team who can go through all this stuff.
As PET-CT takes over in prostate, do you see the day where it's similar to what we have in pathology? It's not unusual to get a second pathologist to do a reading.
Oh, yeah.
Do you see the day where Mayo or other places of excellence, you're going to get a bunch of scans that were done somewhere else and go, can you comment on that? Is that a false positive? Do you get that now, or do you see that coming?
We get that now.
You get
we
now.
Probably get, I don't know, 50 a week of PET scans.
Really?
Yeah. And so if you go and say, there's different versions of this. So if a patient is coming to a quaternary care center, or tertiary care center, so a place where they deal with more complicated and more advanced care where you have to travel to get there, usually not a regional or smaller hospital, they're often going to ask their pathologist, the radiologist to take a peek at things, right? And so, what do I see? I see that people are learning. I see their reports. They're learning. They're sometimes making mistakes that we'll correct. Sometimes we look at the scan and we're like, that's not a good scan. That's a 20-year-old PET scanner. That scanner isn't going to, I can look at the images and tell you what's there, but I know I'm missing stuff. And you don't feel good about it. But at the same time, then you ask yourself the question, well, is that patient going to be comfortable traveling somewhere else? Can that institution afford a better PET scanner? So there's all these things that we got to balance. But, we deal with that. And, we are reviewing those images on our tumor boards when we're talking, discussing difficult cases and saying, here's the imaging, here's what they had before, here's what they have now. Do we need to repeat it? Can we get it paid for? All those questions.
Wow, 50. So here's the problem as we finish up today, and this is not a bad problem to have. People are going to see you. They're going to see me with you. They're going to see Eugene Kwan, who everybody loves. Blah, blah, blah. Everyone loves Eugene Kwan. He just kind of dominates this guy. He's a problem. I mean, he just gets all the greatest views. We're all trying to strive to be Eugene Kwan. So they're going to see it and go, I'm going to go see Dr. J for my Pluvicto. Can you just give us an update as to, can you guys handle the volume? Or are you still dealing with the shortage issues? If someone goes to Mayo and after they see this and wants to be treated with lutetium, is there enough to go around right now, or what's your status on that?
So we are putting everything we can into this. So, it was probably 5 years ago or more that it became a strategic priority for nuclear medicine and Mayo Clinic to get ready for PSMA therapy. We saw this tsunami coming, as did a lot of places, but we were lucky in the sense that the leadership above me, who I go and ask for money from, right? They looked at what we were telling them and they said, okay, yeah, we agree. And so we actually moved into a new therapy center 2 weeks ago. We have a brand new therapy center. So we have the facilities to do the therapy. We have, we have these scanners to do these post-therapy scans. We've got a second one coming next month. But we're dealing with limitations that are beyond what I can control in nuclear medicine. So Novartis can make only so much of the therapy right now. They're ramping up. These are very difficult therapies to make according to the FDA guidelines, which are really designed for non-radioactive drugs, and getting them all here. So right now, we have the ability to treat more patients than we have access to therapy. And that is true, I would say, across most centers in the US right now. Having said that, we're working through all of that and trying to get it up and running. And I think there are 60 centers in the US that have at least given one dose to a patient. Many of them are smaller, and those groups some of them are new to this and they're figuring it out. So hopefully we're going to get there. But it is an issue right now. And the other issue is, physicians to see them. So I'm the second line. I'm a doctor's doctor, right?
Right.
Doctors call me when they say, I've got a prostate cancer patient. What do you think about the imaging? What do you think about the therapy? Let's put our heads together and see if they're right for a referral to our group. And we've got 12 people in Nuke Med who do this kind of therapy in our group. We've actually got 27 Nuke Med physicians here, a big group. So they're going to want to see Eugene Kwan. They're going to want to see one of our new hires, Dan Childs, or Jake Orm, who's coming behind him. They're going to want to see someone in Rad Onc, who then can refer them to us in our practice. So, they may have trouble getting in the door to see the physician because they're overbooked. And even if they get in, we may have trouble getting the therapy. But, we're all working together. I hope that will continue to improve. We are a big practice. So the number that I was quoted recently was that of Pluvicto doses that have been given so far, we're 30%. So it's a big practice, and we don't have enough to meet the demand of the people coming in.
But you give a heads up. If I'm calling and I want to come to Rochester, I mean, it's up front, right? Well, yeah, we can get you in on this date. It's a possible, right?
Yep. Yeah. So yeah, we're, right now in the world that I'm envisioning, you come to Mayo Clinic, which is what we're famous for. And by the 3 to 5 days, we've got a plan and we've actually started it.
Yeah.
We can't do that yet with this therapy because there's a delay between when we've selected you and say you're a perfect candidate for this therapy. It's the right choice for you. We order the therapy, we start the prior authorization with insurance, all that stuff takes time. And so it does become a little difficult. I'd rather they come and get the imaging here, the PET scan here, because I like what we do, but you might have a great place nearby who can do great imaging. We can have the conversation, to some degree, and then get you in the door to see somebody. You're not going to come for therapy until we know the drug is coming, right? So you're not going to fly in.
Yeah, exactly.
Having said that, sometimes, with pilot shortages and stuff, the drug is circling around Chicago somewhere, and then it expires before we can get it. And we'll go to bat for you on that. But, those issues are still happening.
Okay, now we're down to about 30, 60 seconds. Any quick comment on? Okay, so here's one of the catches of Pluvicto, and that's great. That's fine. Xerostomia, it's Greek, zero dry and stoma mouth or opening, right? And if you read papers, if you talk to some certain subset, whether they're in Germany or other places, some people will use ice bags. Some people will say they don't help. What's Mayo doing with this side effect? Are they do you think they're just mostly grade 1, they're self-limiting, or is there a plan to try to prevent this side effect?
So mostly grade 1, mostly self-limited with Pluvicto. If you look at the alpha therapies, it's a problem.
Yeah.
It's a real problem. So, and people debate about that as well. I mean, so your mouth is dry, but I beat the bejesus out of your cancer. That might be a trade-off that's worth considering, but you want to know it going in. You want to know, what you're up against, because having a really dry mouth for permanently is not an easy thing to deal with. And so, I think when you look at Pluvicto, it's been relatively well tolerated. You go and say, okay, you got chemotherapy, you got all these other therapies that people are going on and all their side effects. These therapies have side effects. Yes, they can have dry mouth. Most of the time, doesn't bother them enough, goes away, gets better to the point that they don't notice it. So I think we're good there.
But this is the question. We get a ton of questions on, if you guys are so excited and gals are so excited about Pluvicto, we're hearing that this may be the next biggest thing, this actinium. What's the status of this? Is there a phase 3? Do you see this coming to Mayo in the next 5 years, 2 years, never, 4? How do you answer the question on where actinium is and where it's going?
So there are a lot of PSMA targeted alpha emitting therapies coming down the pike, and actinium PSMA 617 is one of them. Right? There are ones with lead-212. There are ones with astatine. There are ones with thorium. There are ones with these other radionuclides, other binding motifs, hoping potentially to have less toxicity in the salivary glands. And so, we're hoping that as we go forward, we can do something about it. I mean, I think, one thing that we always recommend is any of these therapies, you just drink a lot of fluid, because whatever doesn't stick to the tumor, you want to get it out of there. You want to pee it out, right? And if you're well hydrated and you're salivating, you're moving that radiotracer out of the salivary glands. But I don't have any proof that that works. And there certainly isn't anything that I think the community thinks is proof that doing this, that, or the other thing, everyone agrees prevents dry mouth. So that, I think, is an open discussion that hasn't been resolved yet.
So let me put it to you this way, to kind of corner you a little bit. Do you think there's a greater chance in the next year or two of your career, next 3 years, that there'll be another indication for Pluvicto in a different stage and situation? Or do you think another one of these agents, radioligands, will come along? Which one's more likely?
I think they're both likely. And I think the first one that'll happen is that what you described second. I think we'll probably get to expand our therapeutic use of PSMA 617. But those are crystal ball,
I like it.
You don't know, because you don't know. I mean, there are therapies. We had a neuroendocrine tumor therapy people were very excited about, turned out to have bone marrow toxicity no one could have predicted, and it's a total failure. So you don't know until you get there. That's why you got to do the study and do it carefully.
No, but I like those chance answers. I like, that's a very optimistic answer. It makes me think of a question I always ask Eugene. When you've been working with lutetium, have you seen, just a quick answer, or I'm sure you have you seen a couple of responses where you just sat back in your chair and went, wait a second, that's a little bit more than I expected?
Yeah.
Or have you had that already?
Yeah, we got patients coming back, and because we're doing the post-therapy scans or the therapy monitoring scans. Yeah. So we're seeing the change in the therapy drug getting the tumors. And it's surprising how effective it can be. And the problem is this: you look at a patient, you say, okay, here's a patient who's got every tumor I can see lights up with the drug, right? On the PET scan. And I think, okay, this guy's perfect. And let's say you got two of them, right? They're basically the same history. They've tried everything. They've failed everything. All their tumors are lighting up like a Christmas tree. You think that they're great candidates for the therapy. And one of them has this beautiful response where their tumors melt away and their PSA in the blood is gone. And the other guy, nothing. It's like he didn't even, maybe he slowed it down a little, right? And so we know that our ability to say whether the drug gets to the tumor is critical. It's important, right? And there's data coming out to say, as that SUV goes up, as we know more of the radiopharmaceuticals getting to the tumor, our chances of a good response go up. But it is clearly not the only thing. And so, what's going on? Is it genetics of the tumor? Are they turning on defenses to radiation? Have they, what is it that they've done? And there's a lot of exploration going on there. And so I think there's a lot more questions than answers as we get further in the development of these new therapies.
Do you still see yourself using Xofigo, radium in the future? Or I know this is going to be a hell of a competition, but do you still use it at Mayo?
We do.
You do.
We do. It's just a smaller group of patients for who it's applicable. Yeah. And it is a fairly well tolerated drug therapy, radiopharmaceutical therapy. It is something that was the first radiopharmaceutical therapy to show an extension of people's lives, which is a pretty high benchmark. We've got some trials where we're using it in combination with external beam radiation and other things like that are going on, but we are still using it clinically. And sometimes it's the best option for a patient. You say, okay, you've done these other things, right? All your tumors are in your bone. Let's give it a shot.
I'm not going to ask you anymore because I've gone 30 minutes more because it was entertaining. You made me think of a lot of questions I didn't even write on. So my last sign is, since I gave you a new endearing nickname, which I bet your patients will start calling you in the future, Dr. J, a total slam dunk. That's what I put. Thanks for being you. I want to thanks to Quan too, because Quan kept telling me, you got to get Johnson on. I said, I'm trying to get Johnson on. He goes, no, I'm going to call him and get him on earlier. I'm going, well, I don't want to be known as the guy who harasses people. You can do that. So of course, thanks to Dr. Quan for harassing you to the point where he nudged you here that you had to do it sooner rather than later. But
Yeah.
I really appreciate your talk. I appreciate the time. I appreciate the fact that we brought you in. We were going to have you next year, but there were too many requests to bring you in now. And then you not only came in at the last second, you kind of took over and handled this gigantic spot, this confusing topic. And it's just brilliant. So I just really appreciate your time and your dedication. Thank you.
Well, Mark, I appreciate that. And to all of the people trying to educate our patients, I really wish you the best of luck. And I hope this next conference is a great success.
Thank you. I appreciate it. We'll see you again soon. Thank you.
All right. Bye-bye.
Thank you, Dr. Johnson, and thank you, Dr. Moyad. That was very helpful. I want to remind everybody to visit our exhibit hall on our conference webpage, where you can find valuable resources, information about treatments, payment assistance programs, and much more. Our next speaker is Dr. Geoff Brady. He is an expert urologist with Advent Health Medical Group, and I'm excited to have him here today to give us updates on the latest developments in erectile dysfunction and incontinence. So thank you so much, Dr. Brady. We welcome you here.
Thank you very much for allowing me to speak. It's always an honor to do this and help out. It's something I'm pretty passionate about. So we're going to talk now about function, stress incontinence, and more. So I have no disclosures for this meeting. There's no industry funding for this particular meeting. So I'm a urologist in Orlando, Florida. Like many other urologists, I did a residency in general urology, then did a 2-year fellowship in reconstructive urology, and joined a group here in Orlando in 2000. I've been in the same group since that time. I did a lot of work in regular general urology, did a lot of prostate cancer surgery. We were one of the first papers on focal therapy for cryotherapy. We did kidney transplants. During all that, I did urologic reconstruction, and over the years became chairman of the department in our hospital system here. Near and dear to my heart has always been prostate cancer, and I ran the American Cancer Society Prostate Cancer Support Group from 2000 until American Cancer Society disbanded that a few years ago. Currently I do mainly reconstructive urology. Again, that's what my fellowship is in, and now probably 80 to 90% of all of my work is reconstructive urology. So a lot of that is taking care of men who have gone through some of the side effects of prostate cancer, as well as some other things. We're considered a center of excellence here in Florida. These are the things that we treat, but we're going to focus really on things that are related to prostate cancer. Today, I'm going to cover things on erectile dysfunction, just general population information. We're going to talk about those things that are specific to prostate cancer patients and some of the restorative therapies. We'll talk about Peyronie's disease and, what's this about penile length loss. We'll talk about stress incontinence and foreplay incontinence and climacturia. Hope we educate you on some of the new things that are out there. So let's talk about erectile dysfunction. So it's the inability to achieve and maintain an erection to complete intercourse. It's estimated that up to 30 million men in the United States suffer from erectile dysfunction. Prior to Viagra coming out, only about 10 to 20% of men saw treatment. And now that's very different and much easier to talk about. So what is an erection? So on the screen there on your left-hand side is a soft or flaccid penis, which is not filled with blood at all. So the penis involves 3 chambers. The 2 top ones there are the main erectile bodies, and the bottom, the corpus spongiosum, really holds the urethra in the center. But that also fills with blood with an erection, and that's connected to the head of the penis. When an erection occurs, which you can see on the slide here, is that blood will flow in through the arteries. So the arteries are right here, the cavernosal arteries and the dorsal arteries of the penis, and they fill those chambers. And that's really, the penis is really a big blood vessel. And so when the smooth muscle relaxes, blood flows in. And then what you'll notice is these little veins, the blue vessels on the images there. When the erectile bodies fill, you'll have compression of those veins. So blood goes in, no blood comes out. That's how you generate a pressure and you get an erection. And so these are the veins when we talk about venous leak. They don't close and blood leaks out, you don't get an erection. So that's the anatomy of what we're talking about when you look at what is an erection. So interesting study, Massachusetts male aging study, looked at men, a lot of different conditions, but one they looked at was erectile dysfunction. was surprising to me when I turned 40 to know that 40% of 40-year-olds have erectile dysfunction, and whatever decade of life you're in is about the incidence of erectile dysfunction. So it seems to be a normal consequence of aging. It's not to say that everybody gets erectile dysfunction, but is much more common than we think. And this is just men who have not had prostate cancer. It's just all men coming in saying, do you have erectile dysfunction? We have some men who are in their 20s have erectile dysfunction. Obviously, that's much less of a percentile. But again, overall, if you look at men in the 40 to 70 age group, about 50% of all those men have erectile dysfunction. So it's very common out there. So what are the causes of erectile dysfunction? Really, the four major risk factors: smoking, diabetes, hypertension, and elevated cholesterol. Those are the main risk factors for coronary artery disease. So anything that is good for your heart is probably good for your penis and your erections. So if you can control your smoking and obviously eliminate that, control diabetes, control hypertension, your cholesterol, those are all going to be very helpful helping your erectile function going forward. We look at pelvic surgery in our group. We're talking here, radical prostatectomy would count. That's a very common cause of erectile dysfunction, which we'll talk over. A lot of other things, hormone abnormalities, other types of conditions can also affect erections and create issues. One of the very, very interesting things about erectile dysfunction, it's a warning sign for coronary artery disease. So the way this slide reads, if you look at the arteries in the middle of the screen there, you'll see that the penile arteries on our far left, and it's really smaller artery, about 1 to 2 millimeters size. And then there's the coronary artery that goes to the heart, carotid artery, then femoral artery. And what you see is they all have a big lumen there, so blood can flow through easily. At the very bottom of the slide there, you see what happens when you occlude the lumen by a certain percentage. And what you'll see is that the penile arteries become the narrowest most quickly because they're the smallest artery. So when you have narrowed arteries to the penis, you'll have less blood flow to the penis. You'll have more likely to have erectile dysfunction. So what we find is that men who are young, 40s, 50s, and have erectile dysfunction, that may be a warning sign that, your coronary arteries are probably also narrowed. And with a little more narrowing, you may get things that would lead to heart attacks and strokes. So here's what coronary arteries look like. You see, these are critical lesions. This LAD there, that's the widowmaker. That gets narrowed, and sometimes that supplies most of the heart. But these are just showing how those arteries can narrow over time, and you may not know that's happening. And erectile dysfunction can be a warning sign. So this is an interesting study showing from the prostate cancer prevention trial study. They took men who they followed over time, had questionnaires, validated questionnaires. And as they started, these men do not have erectile dysfunction. And as they went through the study, they then developed erectile dysfunction, and then they followed them over time. And what they found is that over 5 to 7 year period, these men, once they had erectile dysfunction, they found that in a 5 year period, 11% of those men, 1 in 10, are going to have a coronary event or a stroke. And so it just tells us that if you develop erectile dysfunction, you have about a 10% incidence of having a cardiac or a cardiovascular event in the next 5 years. So again, if you have erectile dysfunction, it's worthwhile being evaluated for coronary artery disease and vascular disease overall. All right, let's get back to erectile dysfunction. So what do we have for ED? These are all the different treatment options. So it's not all about just pills or surgery, but we have a lot of different options. And so we want to go through these so you know what's out there. Again, talking about non-pharmacologic options, again, things you can do for your general health are going to help your erectile function as well as your general health. So again, no smoking, reduce fat and cholesterol in your diet, limit alcohol consumption, regular exercise, and weight loss are all very helpful. Speaking specifically to weight loss, very interesting study done early 2000s, placebo-controlled trial looking at men that were overweight. And one group ended up getting counseling and educated on how to lose weight. The other group did not. They followed them over time. What they found is that those men who lost 20% of their BMI, their body mass index, had a statistical improvement in their erectile scores, in their inflammatory markers, and those endothelial cell function markers that they were able to track, showing that if you can lose weight and improve your overall health, you'll have improvement of your erections as well. So obviously diet can also help. So anything you can do to improve your diet is helpful. Better than go getting a bag of chips, snack on fruits, nuts and berries. And these are all just some listed here to tell you what are some of the good foods that we use and would recommend. And so in our practice, we have a sheet that we give to patients. So, if they want to make some dietary changes, we tell them like these are the healthy snacks to do. And that little bit of education can go a long way. All right, let's get to what are the specific treatments we have. So we all know about the standard pills that are out there. Viagra, Levitra, Cialis, Staxin, and Stendra are the current pills we have available in the United States. They work by improving blood flow to the penis. They do it really throughout the body, but the focus, the receptors are more concentrated in the genital area. And they don't replace anything. They just make your processes work better. So and I will show you how that works. So in Florida here, we have a lot of engineers in the Space Coast, and they like to know how do things work. So this is how it happens. So when you look here on the upper part of the slide here, it says endothelial cells and neurons. Those are the nerves. So when you talk about your prostate cancer surgery, this is what they are sparing when they do that surgery. So when those nerves get stimulated by whatever it is that excites you, it goes down the nitric oxide pathway. It goes down here, and what you'll get more of this green box here, the cyclic GMP. What that does, it changes the calcium concentration in the smooth muscle cells and decreases that so that they relax and they open up so blood can flow into the penis. So more of this cyclic GMP means you have more of an erection. So that's the normal process of having an erection. The way we don't walk around with an erection all day long is this little purple circle here, PDE5, is an enzyme that breaks down cyclic GMP into a non-cyclic form. And what that then does, that makes the erection go away. So how do our medicines work? Viagra, Cialis, and the like? They block that enzyme. So when that enzyme is blocked, that cyclic GMP can accumulate in a higher amount for a longer period of time. So it's a better erection that lasts longer. And that's how the pills work. They don't replace anything. They just stop the breakdown of your normal signals that generate an erection. This is another kind of pathway just to show it. And so if you can see my arrow, we're really looking at this very bottom left-hand side of the screen. That's that, and that purple there's that cyclic GMP. That's the way that works to create the erection. All right, let's talk about the pills just in general. So this is a pharmacokinetic curve showing you how it works. Sometimes this helps make it more understandable. But at time 0 on X here is when you take the medicine, and then this is on the Y-axis is the concentration in your blood. And what you'll see is that at about 1 hour you get a peak level. So that's when you're going to get your best response with Viagra, and then over time it goes down, and by out here 6 to 8 hours it's almost out of your system altogether. But that's the drug absorption curve for Viagra or sildenafil. Here it is for Levitra, about the same, peak at 1 hour. And then Cialis is different. So Cialis, when you take that pill at time 0, it takes you almost 3 to 4 hours to get to a peak level. So we find a lot of men who come in trying Cialis say that stuff doesn't work. Well, if you take it and try 15, 20 minutes later, way down here, you're at the bottom of the drug absorption curve, and you're not going to get the same response you will as if you try it 3 to 4 hours. So, and then in terms of elimination, it takes longer to have that eliminated by the body. And what you'll see is still in your system, you're about 16 to 24 hours later, you've still got significant levels. That's why they call it the weekend pill in Europe, because this lasts for a long time. Okay, so this is a chart, part of a handout that we have in our office. We've got a handout that we use for erectile dysfunction. And again, this is to help men understand how to make the medicines work best for them. So, we got the name of the drug on the far left. The dosages are there. We put in bold the maximum dose, so you're making sure you're taking the highest dose possible, and then time to peak. So when do you get your best response? So again, helps them to know when they should expect to have their best response. Duration is there, like how long is in your system, and then food interaction. Good to know that Viagra and Levitra, if you have heavy fatty food or alcohol, will decrease the absorption so you don't get as good a response. And then listed are the side effects there. Those are mainly side effects of dilated blood vessels. That's what a headache is. So some men will get a headache. Some people will get stuffy nose. Some people get facial congestion. Those are all the things that we'll notice with these medications, and it's really a class effect. The way I built this chart was in the very top is when you take it on demand, like tonight's the night. So you just take it that day. The very bottom there is tadalafil or Cialis, which is a daily dosing of this. And you'll see 5 milligrams is the maximum dose. You take that, and then in 3 to 5 days, you'll have a steady state level where you'll get a response. We oftentimes use that for rehab because it may be helpful to have that in your system all of the time. And then we'll sometimes use boost where you take an additional dose when necessary. But just to give you an idea how those work. I think it's helpful, especially here in Florida. Grapefruit juice helps to increase the bioavailability of all these drugs. What they do is the grapefruit juice will bind to and inhibit the protein that breaks down the drugs, so you'll get a higher level. Just have to be careful if you're taking cholesterol medicines and the like, because they may have a similar effect. So who cannot take these medicines? It's those who have coronary artery disease. If you carry nitroglycerin or you use any nitrate containing blood pressure medicines, those really are the big no-nos. And the reason for that is that Viagra was initially developed for coronary artery disease to help dilate blood vessels. They found it didn't work very well at the heart, but worked better somewhere else. But it still has an effect there somewhat. And when you take Viagra and you have a cardiac event, say you take it, you have the ability to have relations and you have a stress test that you fail and you get chest pain, and then you take nitroglycerin, you now have 2 medicines you've taken. They don't really act additively, they act sort of by a multiplying effect. You get this dramatic drop in blood pressure, and people have had strokes, heart attack, dysrhythmias from that, and that's where we've had death. So cannot use those together. If you do take these medicines and you have any chest pain, we recommend an aspirin. Obviously call 911, and the ER can use different medicines to help you control your chest pain. Okay, so here is one of my favorite slides. So we had a lot of men in my practice. A lot of my patients are sent from urologists saying, look, this stuff didn't work. Go see Brady, he'll do surgery on you. We take a step back and say, let's make sure you're using everything the right way. So this is to make sure you're using all the pills the right way. So number one, stimulation is important. We still have men who come in, they take say a Viagra, and then they're looking down saying, okay, maybe I'll have an erection. And that doesn't work. You need to be stimulated. You need those nerves to be stimulated to help the whole pathway start. So you got to figure out what gets you excited to have these medicines work best. Timing of taking the medication. Again, knowing that you need to take the medicine, whether it's Viagra or Levitra, about an hour ahead of time, Cialis, say 2 to 3 or 4 hours ahead of time, you will get a better response if you do it at the right time. Dietary concerns, again, if you're going out and be romantic, it's your anniversary and you're going to have wine and heavy fatty food, a nice meal, your Viagra may not work as well. And Cialis may be a better option, but know that those medicines can affect how your medicines work. Number 4 is it requires multiple trials. The first few times you try the medicine, most men, they used to get a sample, they go home, they take a pill, and they've got their wife or their girlfriend or partner saying, okay, let's go. Now they got pressure for see how it's going to work. They may be worried, are they going to go blind? Are they going to have some horrible reaction? So all that stress works against having an erection. So what we find is that if you take medicines multiple times, you'll tend to do better. You kind of compare over 6 to 8 trials of the medicine. First 3 or 4 times, you don't have as good a response to do those last, say 4 to 5 times. And there you tend to get a better response. So try it more than once. One time would not mean that it's a failure. Number 5 is maximize dosing. Again, you want to make sure that you're at the highest dose possible that's safe for you. There are some off-label uses at higher doses than are FDA approved. More common outside the United States where we're not as litigious, but you can consider those as options as well. Number 6, again, grapefruit, we touch base on that, maybe improve your, how the medicines work. And then you may want to have your testosterone checked if it's not working well. Testosterone replacement can help if your levels are low. So what a good thing to check if you're not getting a good response. Okay, so let's shift gears. That's how the medicines work. We're here to talk now about prostate cancer. These are the treatment options for prostate cancer, starting up here with active surveillance, and then you have surgical or radical prostatectomy, you have radiation therapy, cryotherapy, and HIFU. So we'll kind of go through a little bit of this. So just to give you anatomically how we do things, again, hopefully you can see my arrow here, but this drawing shows the bladder here, up above, which is the prostate here sitting at the base of the bladder. And then here's the urethra that goes out to the penis. And again, what we have here is the nerve, the neurovascular bundle. So when you have your nerve spared, that's what your urologist is trying to do to keep that intact so you have function. But when we do a radical prostatectomy, whether it's open, whether it's a robot, perineally, however it's done, you are removing the prostate here, which is again at the base of the bladder. We remove the seminal vesicles. And over here on the right side of the slide, what we do is that gap, which is where the prostate used to sit, we then stitch that together. So we bring the bladder down to the urethra and suture it, and that's the anastomosis, or the connection. We put a catheter in there to allow that to heal, but that's structurally how we do that. Show you some of the other treatments for prostate cancer. This is brachytherapy, which is where we put little seeds or pellets into the prostate. And on the right side here is sort of the old-fashioned external beam radiation therapy. That's how it used to be done. You lay it on a table and a radiation came from above and went back, through your body and just hit kind of in one plane. And that's the old-fashioned external beam radiation therapy. Just a picture of how we do the seeds. It almost looks like, if you remember a battleship, is you got a little grid and you're putting the needles in there and they'll deposit these little pellets. And those pellets stay in the prostate. They're there for the rest of your life, but they'll emit radiation over the course of the next few months. So you don't have to go into the office, the radiation oncologist office every day. And if you had an x-ray, this is what it would look like. So you see those pellets in the drawing on the left, and then you can see the outline of the prostate. And you'll see the center. They try to spare the urethra so you don't have as much of a radiation effect there. But that's brachytherapy, if you haven't seen that. This is IMRT. So what you'll see, which is different relative to the old external beam radiation therapy, you'll see you have different planes that radiation therapy will come to hit the prostate. So that will eliminate or minimize that, I should say, the scatter through around the prostate. If you just came from the front to the back, the rectum sits behind the prostate, and that would get a lot of dose of radiation, would have a lot of side effects of that. This kind of distributes that scatter effect through a broader range of tissue to hopefully limit toxicity that may occur with intensity modulated radiation. But this is how we used to do it. I used to do it. Again, people are asleep in the operating room. We put little probes that go into the prostate. There's little ice balls at the end of the probes, and that would then ablate or destroy the tissue. Very effective. Again, it is very technique driven. And HIFU, somewhat similarly, it's a probe goes in to the rectum, and that sends a signal to the prostate to destroy the cells that are there, hopefully treating obviously the cancer cells. And that's HIFU. So that's kind of just a walk down what are the different treatments for those who are looking for prostate cancer management. So the great thing about our treatments is all of them work very well. And so it's trying to figure out what's the best for you. So with a high likelihood of cure, you use side effects as a guide to say, what are things that you would be most comfortable using. And I would say the side effects are obviously more common with surgery, surgical interventions. It's an immediate effect that we see. So survivorship now is about improving your quality of life. And, how do we do that? And it's one, we want you to be cancer-free. We want you to be potent. That means to still have erections. And we want you to be continent. We don't want you to be leaking urine. And so that's the trifecta when you look at what are the good outcomes for prostate cancer management. And then again, we don't want to have post-op complications, and we want you to have negative surgical margins when you're taking out the prostate. And that's sort of the pentafecta, those 5 things you're looking for when you're having prostate surgery. So when we look at those as your kind of your guide, those are the top 5 things you're trying to get when you have your treatment. These are some of the other things you ought to consider. And these are things we are learning as urologists as we go forward, following patients and you telling us what are the problems that you have. So we're going to talk about Peyronie's disease, the length of the penis, and some things that are related to leaking urine at times when we're being sexually active. So let's touch on erectile dysfunction first. So what I did here is I put surgery on one side, radiation therapy on the other. We're going to talk about each of these side effects because surgery and radiation therapy are the most common treatments we have. So with surgical, whether it's robotic or open, when you remove the prostate, the erectile dysfunction is an immediate effect. Like you will know that right after the surgery's happened. It is very much age dependent. It will be dependent also on what's your erectile function prior to having your surgery. Like if you have great erections beforehand, you have a better chance of having reasonable erections later. If your erections are very poor before surgery, surgery is not going to help. It's just going to make it worse, and you will have a harder time getting back likely to your baseline. The surgeon's ability also will have an effect on your outcome if you receive any additional radiation therapy later on. And then if you work with a rehab program, all those things can help, have a better chance to have erectile function down the road. Radiation therapy, again, delayed effect, does not happen right away. Happens to be with surgery, kind of a drop off right away. Radiation therapy, you do well for a while, and then you start to have issues with erectile function later, and then those curves kind of cross, where usually about 3 to 5 years later, the erectile function is about the same for both categories. But again, surgery will have something that's more dramatic. So looking at ejaculation, so radical prostatectomy, the prostate is what makes the fluid. It nourishes the sperm. When you have your prostate removed, you will not have fluid come out afterwards. You may have a small amount of pre-ejacular fluid, is usually from urethral glands, but you won't have the same amount of fluid that came out before. Orgasm should still happen. You should still feel that, and it is separate from erections. So you can have an orgasm or a sensation of ejaculation and be completely flaccid or soft. Most of the time they do occur together, but they do not have to. Interestingly, 10% of men say that ejaculation is more pleasurable after the prostate surgery. Not sure why that is. Now, looking at radiation therapy, prostate's still present, so you likely will still have some seminal fluid come out. But as the radiation has effect, and usually you have the dose, and then over time the radiation will start to destroy cells. You'll have less viable cells that are in the prostate making that, and usually within 3 to 5 years, many men do not produce semen, so that may decrease over time. Fertility issues, radiation therapy, you have to be careful. If you have radiation therapy, childbearing age, you can have radiation effects on the sperm, so we recommend not getting pregnant for a year. And there's little data per se, specifically on orgasm as it relates to ejaculation. So let's talk about prostate cancer and Peyronie's disease. So when you look at men who have had radical prostatectomy, they have a higher incidence of Peyronie's disease than the general population. So if you've had your prostate removed, 15.9% of men in one study had Peyronie's disease versus up to 9% in general population. The average amount of degree of curvature was 31 degrees. So, that straight line, 30 degrees would be bent whichever direction that is. Radiation therapy, you don't have any data on Peyronie's disease and radiation therapy, so I've not seen that. So this is a photograph of a dorsal Peyronie's disease or upward curvature, something right lateral curvature, left lateral can be downward, we call that ventral. And then some has some just narrowing, we call it hourglass deformity, where again, you have a band of scar tissue. And what happens with this is, if you look here, there's a cross section of the penis and you're kind of looking on end. And what you'll see is you develop a plaque. It's a bad term. It has nothing to do with plaque in the arteries of the heart or plaque on your teeth, but that's the name that people have used. It's really fibrosis, and that's probably a better name. What fibrosis does, it creates a tethering effect. And the way we describe Peyronie's disease, if you can imagine a cylindrical balloon, and then you put a piece of Scotch tape along the length of the balloon and then blew the balloon up. Where that tape is that same fibrosis, and that tape won't allow the balloon to expand. The other side has no restrictions. You have a functional longer side and a shorter side, so the balloon will curve on the side with the tape. Same thing happens with our erections with Peyronie's disease. And that's really what we see with Peyronie's disease. So again, out of Memorial Sloan Kettering, John Mulhall did a study looking at a group of patients, and again, they had about a 16% incidence of Peyronie's disease versus we see in general population 9%. And interestingly, erectile dysfunction or function do not really play a role. So just having a catheter, just having procedures done can put you at risk for Peyronie's disease. Do have some treatments for that. Xiaflex is the only FDA treatment option for that. It's a collagenase enzyme that breaks down that scar tissue. And it's FDA approved for those who have 30 degrees of curvature, stable disease, and a palpable plaque. And again, I'm in the sexual medicine side, and there are those throughout the country who treat this, and I think those are the best people to probably at least talk to who have this as an issue. And again, we do this, and usually we'll give you a block to numb up the area and just showing it's an injection right into that scar tissue to try to break down the fibrosis. And rarely do we do surgery specifically for Peyronie's disease. We usually treat it with medicines, but some, we still do surgeries on a fair number of it. All right, so let's go then to penile length. What's the story on that? So what we have found is that 70% of men will complain and say that they have lost penile length after their prostate surgery. As urologists, we used to say that, that's not accurate. That can't happen. We take out the prostate, we put everything back together, and the length should be the same. What we've noticed is that you do have loss of length over time. That's now been shown. Do not see that in radiation therapy. We think it's related to loss of erections. And so first study that I saw looking at this is 1993, looked at 100 men after radical prostatectomy. This is before the robot. It was the open prostatectomy. And what they found is that men had a reduction in penile length of 9% and an overall reduction of penile volume of 22%. And then looking at, this is a prospective randomized study by one of my old mentors at the University of Miami, Mark Soloway, and looked and saw that in almost all parameters, men, the penis was smaller. And overall, what it found is that you likely have atrophy of the penile tissue as you're not having erections. And so, and again, they found that sparing of the nerves did not seem to be protective of that. So it is likely a bigger process. And again, likely not having blood filling the penis, stretching it out, keeping that tissue healthy is likely what's happening there. So how can we prevent that? So it is really being engaged in a rehab program or a prehab program or doing something to get those erections. Erections are good for erections. So as you lose your erections after, say, prostate surgery or anytime you lose your erections, you will likely have some loss of your function as time goes on. So men will have erections when you're younger. You have erections 5 to 6, maybe 8 times a night. You have erections easily when you're 18 years old, even when you don't want them to happen. And that's probably something that helps keep that tissue healthy as you have oxygenated blood that goes into the space, fills the space up, and keeps that endothelium and that lining of the erectile bodies healthy. So we don't completely understand what's happening, but it is that highly oxygenated blood and stretching probably helps to keep everything functioning optimally. And that's what we want to replicate in any kind of post-surgery rehab program. So, again, overall, penile length loss, Peyronie's disease, we do see it in prostate cancer. Good news is that if you do rehab and you're able to follow that over time, we find that men do get their penile length back. If you don't do anything, you tend to lose that. Oftentimes, that'll be length that's lost. So we want to do that fairly early. Last is foreplay incontinence and climacturia. And I'd say that we've not seen that in radiation therapy described with radical prostatectomy. We have seen, again, foreplay incontinence is the loss of urine with just simple arousal with your partner. Climacturia is loss of urine with climax when you actually have that orgasmic sensation. So let's go to some other things. So these are just other concerns that, again, in our handouts that we give patients, these are things we talk about. So just talking about recurrence. So if you have prostatectomy and then you have recurrence, you can then do additional radiation therapy. I would say as a reconstructive urologist who takes care of patients down the line, those patients are less problematic for me managing them for things like incontinence and ED and the like, because they still do well. When you take men who have had radiation first, and then they have recurrence of their prostate cancer, and then you add what we call salvage radical prostatectomy, remove the prostate afterwards, or cryotherapy or HIFU, those patients have much more in the way of severe complications. They tend to be harder for us to treat, and we actually do our surgeries to help with incontinence. We have a special pathway for them because we know that they have a higher complication rate, so we treat them differently. And really, it's just that for some men, they're going to get both therapies. If you got really, say, more aggressive disease and you have a high chance of having both, and I don't push people one way or the other. I'm a surgeon. I used to do a lot of prostatectomies, and I tell patients now, look, they both have pretty equal outcomes. You have to figure out what makes the most sense for you. For those who have high-risk disease and have a chance to have both therapies, my recommendation would be to consider the surgery first and then add radiation therapy if you need afterwards. The people tend to heal better in that sort of sequence rather than radiation first and then surgery. And that was really the only that I really sort of tend to push people towards surgery because, again, I don't want to have people have problems down the road. So now looking at other issues we see down the road in recovery. So radiation therapy tends to have more so in the past, but still has increased risk of secondary cancers. So the bladder has an exposure to radiation therapy, as does the rectum. And so, there are some studies that show a higher percentage of those in follow-up as you go down the road. We do see dystrophic calcifications, not infrequently in men who have had radiation therapy. We almost never see them in surgery, and that's where the prostate becomes calcified, and sometimes it creates obstruction or blockage, and it's something we have to deal with later. We do see occasionally bleeding or hemorrhagic cystitis. And unfortunately, that happens sometimes 3, 5, 10, 15 years after they've had radiation therapy. And again, I will tell you as a urologist, we see that very uncommon with surgery, but more common with radiation therapy. And then fistulas, very rare with surgery, more common with radiation or combination of surgery and radiation. But again, fortunately, they're rare. We do see anastomotic strictures or bladder neck contractures or vesical anastomosis contractions. That's where the prostate and the bladder, bladder are put back together. You will occasionally see strictures there. I think less common now with how surgeries are being done. You can see it also with radiation therapy. They tend to be in the bulbar urethra and membranous urethra. But again, fairly similar there. I would say with radical prostatectomy, we see more lymphoceles, which is they remove the lymph nodes in the pelvis, and those lymphoceles can grow. Rarely do they have to have anything be done, but if you do have symptoms, they can be drained. We do not see lymphoceles with radiation therapy. But again, these are good lists just to say, okay, talk with your urologist or radiation oncologist. They tell me a little bit about your experience of these and what they have. So 2 words again, or a few words just on radiation therapy. Again, radiation therapy side effects are delayed. You don't see them until down the road. And it's usually years. And I think radiation oncologists are great and they offer great service. But I will tell you that it's really the urologists who are dealing with these problems down the road. So, radiation oncologists, probably medical oncologists sometimes don't even know that these things happen, but because they're not managing, it's us who are kind of treating these problems down the road. So they do happen. I'd also say that radiation disasters are the worst disasters. So if somebody has a problem with radiation therapy, it's a lifelong problem. And rarely do I tell people to have a diversion, but I just told 2 in the last 2 weeks, and there are radiation therapy complication issues from years past. But again, I think most of the time this is not a problem. Surgery and radiation therapy often go very, very well. All right, so that's just kind of a little bit of overview on prostate cancer and what you should be thinking about as you're making your decisions. Now let's talk about what are we going to do to help our erections get better after treatment. So if you've chosen to have a radical prostatectomy, can you do any therapy beforehand? So what we recommend is to get a vacuum erection device before you have your surgery. Try to do some stretching beforehand without a band. Just get comfortable using the device and see how it works. We oftentimes will encourage men to start with the phosphodiesterase inhibitors like Viagra, Cialis beforehand, just again, get used to the medicine and if you've never taken it before. And that's shown to be somewhat helpful. There was an interesting animal study done looking at pelvic nerve crush injuries where they took sildenafil and they gave dosing along with a crush injury. What they did is they gave it to 3 days prior to the injury, an hour beforehand, and 3 days later. And what they found is that those that had the dosing 3 days beforehand had the best response. So they had a higher intercorporal pressures and the mean pressures in the penis. They were much better, and they had lower sort of apoptotic markers or cell death markers than the other group. So again, it is probably helpful to prime your erections prior to getting your prostatectomy, and so we would recommend that in those who can take those medicines. All right, let's go through a little bit about how do we do surgery. So this is kind of a schematic or a drawing. The far right side is labeled the bladder. You see the prostate in the middle, purple, and then the urethra is down to the left side. And what you'll see in yellow, those are the nerves, and that's what control the erections. So when you have your prostate surgery, you can do different things. And, you can ask, what does your urologist do to help protect the nerves? And so they'll do things like athermal nerve sparing, which is they don't cauterize on the nerve. Some people do a special graft where they take graft from the back of the leg and they can put it there. And then they'll also sometimes put a tissue that will help nerves to heal. But the things that will factor and to give you your best outcome for erections are if you're a younger patient, if you've got really good erections beforehand, and then if your surgeon is experienced and has a good track record, those are probably the three best things to say that you're more likely to have a better outcome with your erections. And so when you have your prostatectomy, you see here the prostate's now removed. You see the bladder is there and the urethra is there, and the nerves are now intact. They've not been cut, going out to the penis, which is just beyond the urethra there. And then when we stitch that urethra and bladder back together, we put a small catheter in there to drain the bladder. Again, those nerves have to recover. And what you'll see is we have to dissect the nerves off of the prostate. And so they'll have some effect from that. So the nerves tend to go to sleep from the manipulations, even if you spare them by kind of trimming the nerves to go onto the prostate and pushing the nerve away, you'll have kind of a neuropraxia where they will not function and work as well. So what should we do, or when should we start working on our erections? So this is an interesting study looking at how long after radical prostatectomy did we see venous leaks occur. So if you check for venous leaks 4 months after your prostate surgery, you've not done any rehab, 30% of men had venous leaks. If you checked at 8 months, then 30% had a venous leak. If you checked at a year, then 50% had a leak. And so what you're finding that as time goes, you're having more and more venous leak, and you're having progression in the damage to the penis that's occurring. So earlier is better. That's your window of opportunity. If you want to have good erections, then you should work on it right away. Because again, that's your time to prevent some of this damage that occurs from you stopping having erections and not having blood, fill the penis on a routine basis. So ED programs are out there. In the United States now, some studies show that up to 85% of people are recommending programs routinely, and so I think that's a good sign. And again, so how do we have, and looking at measurements of outcomes? So if we take men, and this is men who have had a radical prostatectomy, and then treat them with Viagra. And this is studied in the early 2000s. Again, this is not a robotic, but a radical prostatectomy. And men had excellent erections beforehand. They had a very good experienced surgeons from the Cleveland Clinic in Ohio. And then they looked at, if you gave men Viagra afterwards, what was the outcome? 80% had overall efficacy. If you then looked at the nerve sparing status, and so those nerves we show you, there's a right and there's a left. And we can spare both. And we sometimes decide, if your pathology is very favorable, you can spare both. Say you got bad cancer on one side, you may go wide on that side and take the nerve and not spare it, and just spare one side. So when they looked at their data, if you spared both nerves, you had an overall 71% response to Viagra. If you spared one nerve, it was really 50%. And then if you went widely and you took both nerves, you'd say, that probably won't work at all. Even still, 15% of men had a response to Viagra. So again, if you've got good erections, good surgeon, and you use Viagra afterwards, you have a good chance of having response. And knowing, when you've had your surgery, ask your surgeon, how the nerve sparing go? Were you able to spare both, or one, or none? And that will help you to predict, is Viagra and that class of medicine going to work? That class of medicines requires the nerves to be there to be functional. So it tells you about your function. So again, erectile preservation. So intraoperatively, your surgeon will do some things to improve your outcomes. And then postoperatively, what are things you can do to help, again, get your erectile function back? So one is doing pharmacologic rehab, which are those are the medicines, doing vacuum erection device, and trying to work on the nerves to improve their response. So again, what you're going to do is beforehand, good to take any of those Viagra, Cialis combination. Consider starting to use a vacuum device. Intraoperatively, your surgeon is going to do that for you, and then postoperatively, you're going to work on these other options that are there. And so, what you want to do with your penile rehabilitation is you're trying to decrease the ischemia or lack of oxygen in that tissue, which then may lead to fibrosis. And then fibrosis leads to the issues that you have. So again, The PDE5 inhibitors, you're going to use those. They require the nerves to be effective. So early on, Viagra, Cialis may not be as responsive. Now they're much more affordable now. In the past, I would tell people, look, if you can't afford it, don't worry about it early on. But now these medicines are much more affordable. I would highly recommend being on them if it's safe for you to do that, because I think it'll make a big difference. The vacuum erection device, I think, is helpful, and we're going to talk about Muse as well. So medicated urethral suppository, they used to say that it's good for maybe you'll see an erection, but really it's a medicated urethral suppository for erections. It's a prostaglandin pill, which is a compound that is a vasodilator. You place that into the urethra. It's usually refrigerated. It then melts. It's then absorbed through the urethra to go to the 3 erectile chambers to promote blood flow. So this is a little cartoon of how it's done. You can see the applicator, a little pellet about the size of a grain of rice. And what that'll do is that medicine is concentrated, and that diffuses into the erectile bodies to give you your response. Just a word on that. About, say, 10, 15% of men will notice significant burning with that medication. So it's good to try that out, see if that's an issue for you. If it's not, I think it's a really great medicine to consider trying. The vacuum erection device, for those who have not seen that before, it's an external cylinder that goes over the penis. There's a battery and hand-operated pumps. The hand-operated pumps, you usually get higher pressure, so I tend to recommend those, but they both work well. To use it for erections, you put a band on the base of the cylinder of the device. You pump it up, you get an erection. Then what you do is just slip the band off of the cylinder, and that would be on the base of the penis. And that's for using after you've had, if you do have erectile dysfunction. Beforehand and for rehab, I really recommend it more for just stretching. I want blood to kind of come in and come out. And so we have a protocol for that, which we go through if you're in the office. And here's just a picture. This is actually a patient who's having surgery, brought in his device. I said, bring in, let's see what you did. And what he did to prevent or get back some of the loss of length, we measured. We encouraged him to do this. So you'll see there, kind of the left side of the slide, penis. That's the opening of the penis. We go in there, and that first marker is a little Sharpie marker where he marked where the penis was when he first started doing the vacuum. And then he did it routinely. What he saw is he kept getting some improved length over time. And so some men will get sometimes an inch or two of length back that they didn't have. So when we're doing a prosthesis, I really believe that is a better stretch. We can maybe put in a bit longer of a device. So we really encourage that before surgery. But again, good to help try to get some function back. So injection therapy, intracavernosal injection or penile injection therapy is injecting a medicine directly into those erectile bodies. So usually with these medicines, if you want to have an erection, you take the medicine from the refrigerator, inject it right into the side of the penis. We have to do one injection. The chambers are all connected, and that will promote blood flow to the penis. It's our best medicine for erections. You say, what if I want to get somebody erection? How can I do it? This is medicine that's most likely to do it. Obviously, the delivery system is not ideal. Using a needle into the penis is uncomfortable. I would say men describe this, that do it. They say it's like pulling the hair out of the back of your hand. That's what it would feel like. So it's a little bit of a mild discomfort. You hold pressure afterwards to minimize some bruising. And then, blood goes into the penis. Usually it happens in about 5 minutes. It's like I said, it's a pretty reliable treatment. In fact, our biggest risk is something called priapism, which is an erection that lasts too long. After, say, 3 to 4 hours, your body starts to use up all the oxygen in that blood, and then it starts to hurt because you're now having ischemia. At that point, it's what we call a compartment syndrome, and you have to decompress the system, or you'll have long-term issues. So to learn how to do this, we usually have you come to the office. We do a low dose in the office. Sometimes we measure the blood flow with an ultrasound. I don't do that often, but some urologists may, and they're just checking to see how everything works. But again, you can then affect your dosing based on that to get the best response possible. Goal is to have an erection for about an hour. Again, this just shows you a cartoon how we do this. So it's an injection on the side of the penis here, and then that medicine, the connection between the two main erectile bodies. There's a septum, which is incomplete, so blood flows in between both chambers. They'll both expand, so you don't have to inject both sides. And the way we go back to this little pathway of getting erections. So again, the bottom left is how do the pills work? On the right-hand side is how do these injections work? And so they work by it's phentolamine, papaverine, prostadil, and they work through the cyclic AMP pathway, again, to create dilation. So you have different pathways to get a similar effect, which is improved blood flow to the penis. This is just interesting. This is an advertisement from our local newspaper. The patient brought in for me and said, do you do this? And we, just a word about shot clinics, and they're everywhere in the country. It's a big business. Basically what they do is you'll come into the office and say, do you want to know why you don't have erections? You say, yes, I want to know why. They'll give you an injection, they'll do an ultrasound, they'll measure blood flow, they'll tell you you've got a venous leak or arterial issues, and hey, this shot worked, do you want to buy it? And you'll say, yeah, I want to try this, this looks good, I haven't had an erection in years. So they'll say, great, and then they'll say, well, if you buy a 6 month, it's going to cost this much, and you get a discount if you do a year. I've seen people leave these clinics with a bill of sometimes $2,000 to $4,000. They mark these medicines up at a tremendous price. They'll assume you're not going to shop around and see what else is out there. For urologists who treat this, we don't sell it. We're not compounding pharmacists, but what we do is we give you a prescription. We send you to a compounding pharmacist. They'll send you the vial. It's usually about $90 to $100, and that vial lasts 3 to 4 months. And so, know that your urologist does this. If you see in the paper, these companies usually don't have anything that your urologist doesn't have. So, again, I would call your 24-hour hotline and see if you can, connect with somebody there. All right, so penile rehabilitation. So again, the pills are very helpful. This is what we recommend, this is I'm gonna pause for a second. I'll go back to the slide. You can just fix this one. But this is a study by Raina's group looking at following post-radical prostatectomy penile rehabilitation. Again, they took men who had good erections. They used the PD5s afterwards, like Viagra, Cialis. They started that right after the catheter was removed. They did vacuum erection device and they didn't use. And they did a protocol. What they found is that about 75% of men were able to have intercourse at 6 months, spontaneously without using all these medications. So again, good evidence that this can help. So this is sort of a version of our protocol, which changes over time, based on, how things are for individuals. But prior to surgery, 2 weeks beforehand, we really encourage prehab. And so again, using things like Cialis, 5 milligrams daily to promote blood flow and health to that tissue, trying to bathe the endothelium and highly oxygenated blood is helpful. Vacuum erection devices where you can do some stretching and trying to help with filling that space. Even if it's not oxygenated blood, it's really about half of what we see with normal arterial erection. There's probably some health to having that tissue stretched. And then maybe try a muse ahead of time. Muse sometimes hard to get. Recently has been a challenge. We have some compounding pharmacies that can sell a gel compound, which works similarly. And again, you can assess to see, do you get burning? Is it comfortable? So at least so that now you're ready for when the time is right that you can do therapy. So once you've had your surgery, immediately afterwards, I think it's a good time to start. So, if you're done well from surgery, not having issues, again, we consider still using the medications like the Cialis. Once the catheter comes out, look at using the vacuum erection device and the muse to see if we can get some response. The vacuum device really just have you stretching the tissue out. Really not using the bands per se early on, but just again filling that space with blood. So down the road, looking about a month or so after the surgery, our goal ultimately is to get 3 to 4 erections every week. And the vacuum device doesn't really count. We want you to have blood coming in from medicines or one of the different ways that we can stimulate a standard arterial erection. So obviously, you're going to check your blood work, check your PSA over time. Testosterone may be helpful to do. Using the Cialis routinely, using the vacuum device, and then using the prostadil and compound gel. We'd like you to try to get those erections and potentially use them. 3 months after surgery is really a time when we really start to push and try to get a better response. So if you're on your daily Cialis, you talk with your urologist. Sometimes we'll add a boost dose, which is an additional dose at the right time. or changing different medicines using some Cialis and Viagra and see what kind of response you get. Again, same with the vacuum device and the Muse. And what we'll do is oftentimes we'll then start to consider if people are not getting a response using the injection therapy to see if they get a response. And then we continue to follow this over time. So many times your urologist will do this, if they're robotic surgeons and their goal is for them to have the best outcomes possible, they will be implementing these programs with you. Or find a urologist like in the Sexual Medicine Society who can help. There's those of us who want to help. Okay, so if none of this works, you've tried all the medicines and say you've waited, you've gone through therapy, you're now a year or 2 years out, and you still say, you know what, I am not getting erections and I want to have erections. This is an inflatable penile prosthesis, the 3-piece prosthesis. And so this is the surgical correction of erectile dysfunction. And so the way this works, you have a pump that goes in the scrotum. It's all done by a small incision, but the pump is in the scrotum. There's a reservoir, which is behind the abdominal wall. And then there are 2 cylinders in the penis. They count as one. So those are your three pieces. And when you want to have erection, you pump the pump, which is in your scrotum. A fluid it's a normal saline, goes through the pump, goes into the cylinders so that you then have an erection like this. You have the erection as long as you want. You have an hour, a day, a week. There's no problem with that. When you're done, you press the button, it goes back, the fluid gets transferred back into the reservoir, and the penis goes back to being soft or flaccid. And so, it would look like this. And this is what it looks like when you can't see anything. That pump is completely invisible. It's hidden under the scrotal skin. So here is somebody pumping up to get erection, and then when they're done, you press it and it goes back down, so you go to be flaccid. So again, other looks of how things look. So again, that person there on the left, if you're at the YMCA and have a shower, you never know this person has a device in it. These are completely invisible. Nobody knows they're there. So when you look and say, where are these being placed? So this is, again, a cross-section of the penis. You see our 3 erectile chambers. We're putting these cylinders in this space right there, the 2 corporal bodies. They're not just sitting under the skin. They're in a defined space in those erectile bodies, and that's where we're going to put them. So the surgery takes anywhere from 30 to 90 minutes. It's done by a small incision. For me, I do it in the scrotum. Some do it above the penis, but it's an outpatient procedure. They tend to go home the same day. And once you heal up, you'll have the ability to have an erection. So there are pros and cons to everything. So the upside of a penile prosthesis, it allows things to be spontaneous. Once you have a device in place and once you're able to learn how to use it, you'll have an erection in 30 to 60 seconds. So you don't have to wait and say, gosh, my medicine, I took it, I got to wait 3 hours for it to work. You can be spontaneous. It's reliable. It will work every time. So it is not as though you say, gosh, I had some heavy fatty food and maybe this won't work. You'll know it's going to be able to work. It's natural, and then it goes up and it goes down. You don't walk around like with the old-fashioned malleable prosthesis that's always rigid. This thing is soft. And we describe, again, it's invisible. Nobody knows that it's there. So it allows you to return to intimacy. Medicare covers this like they do for all procedures, the 80% they cover, and most private insurance as well. So again, we encourage men to preoperatively use the vacuum device, again, to combat the loss of the penile atrophy, loss of size that we see many men complain about. Because I would say that's one of the bigger complaints is after penile prosthesis, my penis is shorter than what it used to be. So we try to use this to help with that. Again, same thing you've seen before, we try to stretch that tissue out. So what are things to know about penile prosthesis? So one, outpatient procedure, I do through a small incision in the scrotum. We dilate the erectile bodies to create the space to put those cylinders. So we're not like removing any tissue, it's just a soft tissue where we place this. They come in multiple sizes, not one size fits all. They're small, medium, large, extra large, and super size, which we call the Moyad. And that is they're not called that, but I figured Mark would like that. But they do come in different size, and we size appropriately to each person's size. We place each component separately. That's how we get all those things in there through one small incision. We put one part at a time, then we make connections. We put a light pressure dressing, and then usually we use this in about 2 months. Our success rates or satisfaction rates are 90 to 95% for both patient and partners. So, people who ultimately get to this really do like these treatments. So we're in an orthopedic hospital. So here's our patients next door to somebody who just had their leg surgery, and you can recover really well. But post-operatively, what we do is we have a pathway. So much like your robotic surgeons who have a pathway for their surgery, those of us who do a lot of this type of surgery, we've got our pathways. And so we do specific things to try to make you as comfortable as possible afterwards. And so we use things like Tylenol and Neurontin, and we have a special local anesthetic called Exparel, which lasts for 3 days. So most men wake up and they don't even know they had surgery. So again, you want to work with people who have these sort of plans for you afterwards to help your surgery work out well. So what you expect after having penile prosthesis, I call the first couple of weeks the I hate Dr. Brady period. Once the local anesthetic wears off, you're going to sit there and go, why did I do this? And so men are uncomfortable. We put a penile prosthesis in, usually uncomfortable at the tip of the penis and in the scrotum, but that does get better with time. Some people take a little more time, but again, usually most people are able to use the device in 2 months. Again, penile shortening is the biggest complaint. So again, using the backing device and some of the models of prostheses and some of our protocols help to minimize that shortening afterwards. Now, what are the risks? We've already talked about the upside. So anytime you put any device or any kind of foreign body into the body, there's a risk of infection. So our standard infection rates used to be about 3%. Now they're down about 1 to 2%. And that's because these devices are coated with antibiotics to decrease the infection rates. The devices do have a certain lifespan. On average, they last about 9 to 10 years. 75% are still functioning at the 15-year mark, so they last better than most cars, but they may not last forever. And the way they would fail is if they develop a leak in the system and the saline leaks out, your body reabsorbs it, you won't feel it, but when you pump it up, it won't pump anymore. And that would be the typical fare that we see. Erosions are fairly uncommon, but used to be more common with a malleable device where they kind of wore through the tissue, but not common at this point. And the other thing to know is that penile prosthesis is really not reversible. So say, I'm going to try a prosthesis. You can't then say, well, wait a minute, now I want to go back and try the shots or try something else, because these cylinders sit where the erectile tissue is. So, I like men to at least consider all the other options, try all the other options. And if it doesn't work, this really is a great option for those where other things are not effective. Okay, so a lot of times, penile prostheses are good for life. So if you compare implants to other medical devices, such as like hip replacements, knee replacements, heart valves, these tend to last longer than all these other medical devices that are implanted. So, okay, these are just for some of our patients who, I've done these lectures for patients for years. So we kind of compiled some of the frequently asked questions that men have. How long do they last? And again, 9 to 10 years is the average, but some last much longer. When you looked at Steve Wilson, who's really the godfather of prosthetic urology, did over 2,000 implants. He said the 5-year survival rate for him, his series was 95%, and the 15-year rate ranged up to 60 up to 87%. So again, these tend to last a long time. Another question was, can you or your partner feel a prosthesis during intercourse and know the difference? I'd say again, your partner will not know that you have an implant in place. They can't feel it. They don't know the difference. They may become suspicious after a few hours, but for the most part, your partners will not know you have a device. What happens if it breaks down or leaks? Again, say you do have a leak in the system. Again, you probably won't perceive anything. Your body reabsorbs that saline, but the device will not work. Now, if you want to have a working, functioning device, we can remove the device and place a new one. So that'd be another procedure. If you say, like, I really don't care, I don't use this device anymore, you leave it in place. There's nothing that says that has to be removed if that occurs. It's not like a silicone breast implant where it's a problem. This is something that really is not that big a deal if you have a leak. Again, patients ask, do you have to remove anything? I've had people think we're going to take out a testicle or take out part of the penis to do this. We don't remove anything. We use your natural spaces to place all the device. Will this change the sensitivity of the penis? So this little cross section shows the very top, right up here, if my arrow shows it, you can see that those are the nerves that give sensation to the penis. So they're on the top side. So I'm doing my surgery on the bottom side. So again, I've not had anybody say with standard straightforward prosthesis surgery that there's any change in sensation of the penis. So you really don't expect that after this. Will this be like my normal erections? Again, I would say that the erections are not as long as they used to be. So you don't tend to have as much elongation as you used to have. And then the head of the penis, the glans cap, that doesn't fill like it did when you were younger. So these erections, we try to get them as best we can to the same size you were. But again, I would say it's usually like the best erection you have, just a centimeter or two shorter. Questions about, does it affect your ability to ejaculate? The answer is no. These are two separate processes. And very rarely are there any issues with ejaculation after a penile prosthesis, maybe 5%. We usually just have to teach you to do it the normal way, because again, ejaculation is a reflex. So you have to, just the fact you have an erection doesn't mean you have climax. You've got to be roused, stimulated to get down the pathway to have climax. And then does insurance pay for the prosthesis? Again, Medicare does, many carriers do. The code for this is 54405. So if you call the back of your insurance card and say, does my policy cover 54405? You don't have to tell them what it is. Just say that that's the number. They can look it up and tell you if it's covered. Oftentimes it's related to prostate cancer. It is covered. You just have to kind of ask for that. And then, will this be a problem for my wife or female partners return to sexual activity? Again, if you've not been sexually active for years, we want this to be a healthy thing for both partners. So sometimes your wife's or partner seeing their gynecologist, sometimes doing things to improve the lubrication of the vagina. Sometimes using lubricants can all be helpful, and you can adjust how rigid you are, but the goal is to make it be pleasurable for everybody. So in conclusion, for erectile dysfunction, you have wide-ranging options. You have, pills and injections, and whether it's an external pump or a penile prosthesis, all these things are reasonable options. Surgery is safe, and it really is minimally invasive. We have high satisfaction rates for both patients and partners with low risk, and it actually does cure the problem that you have, so you're not really relying on anything else. And that's the lecture there for erectile dysfunction. Dr. Moyad asked to go over some things about restorative therapies for erectile dysfunction. So these are kind of the newer things that are out there. So let's kind of review what's out there. So the low intensity shockwave therapy is stem cell therapy, stromal vascular fraction, and platelet rich plasma. So let's kind of go over these one at a time. So shockwave therapy. So we use shockwaves for treating kidney stones, but what we found is that by using shockwaves, some studies show that you'll get new blood vessels that get generated when you create this sort of micro trauma and micro stress in the local environment. And then you'll get some stem cells and growth factors that get released because of this micro trauma. So what urologists started doing is they started doing this shockwave therapy to the penile tissue. And what they saw is, again, you started getting neovascularity to hopefully get better erections. There are different types of delivery units. I would say, at least in my review, the radio wave therapies are different. They don't have as much penetration, and they don't have as much energy that gets delivered to the tissue, so you have less of the effect that you want. So tend not to be as responsive. So anything that has a call it radio wave or something wave, those tend to be the radial release of this, and you tend not to be as responsive. And this is what it looks like. So on the left side here is the focused waves that go through. They penetrate the tissue to up to 10 centimeters at a higher energy level, whereas the radial waves are more diffuse and not as deep, and not as much energy is released. So those are the different types of therapy that are given. It's expensive. It's not covered by insurance. A lot of these private practices and spas will charge you $500 up to $1,000 a session. And the patients I sometimes see will say they spent $5,000–6,000 to see if they're able to get a response. And those who ultimately see me really don't tend to get a response. So I may see a skewed version of that population, but that's usually what we'll see. So let's talk about platelet-rich plasma, PRP. So what happens to that is blood is drawn from you. It's then centrifuged or spun down to get the blood to separate into the cells and the supernatants. And what they do is they take the kind of center layer that has this platelet-rich layer, and that's extracted, and that's sort of processed with calcium, and then that's just injected. And it can be injected in different parts of the body. It is orthopedic surgeons really do a whole bunch of this. Will inject into almost joint or part of the body that hurts and can be somewhat responsive. Plastic surgeons are doing that. This one we've found was called the vampire facelift. where they had all these little micro injections throughout the face to kind of rejuvenate the face. And that's platelet-rich plasma. And so idea there is you're injecting that to create response and tissue recovery and done in the penis. And that's, again, being offered out there. Stem cell therapy, same idea. But like the idea of it sounds good on paper, where you are taking stem cells, injecting into this tissue as a building block to help replace diseased tissue. When you take these in aggregate, you look at these type of therapies. You can have where people are going to offer this, and some people will pay for it. Our Sexual Medicine Society and the American Urologic Society put out kind of a position statement saying what we should be doing with this. We think that the therapies are really interesting, and hopefully in the future would be something that can be offered. We have to figure out how to do it, how to make it work well, make sure it's safe. And so until these studies are done, the restorative therapy should be reserved for clinical trials and not offered in a routine practice. So if you go to somebody's office and they say, look, we'll do this injection therapy for you, or do the wave for you, we're going to charge you $1,000, I probably wouldn't go for that. But if you're at a center that's studying these things, say, look, you just enter into a study and we're going to track over time how you come. That's really a thing where I think I would look at and be interested in being a patient there. All right, so that's really this lecture, kind of focusing on erections and different things there. So I was going to pause there, leave it open for any questions, and if anybody can figure out where that traffic light is and what's wrong with it, you can kind of let us know what you find with that. A, what's wrong with it? And then B, where is it? What part of the country? And I'll leave it at that. All right, so they've asked us also to talk about stress urinary incontinence. So let's talk a little bit about that. So again, disclosures, no disclosures related to this talk. Again, a lot of different things that we treat in our clinic. We're going to focus on today really is stress urinary incontinence. So again, prostate cancer treatment, a lot of times you'll be cured. You have side effects from all these treatments, and we're going to try to improve your quality of life. And our focus here is going to be stress urinary incontinence. For those, I have an expanded version of this talk. If you use your phone, I go on this QR reader. You'll have a longer lecture if you want to get into more detail, but we're going to give you an overview of that right here. So lots of different types of urinary incontinence. This we're going to talk about is treating stress urinary incontinence or post-prostatectomy incontinence. And this is after you've had surgery, you have damage to the sphincter, you'll have urinary leakage. There's also urge incontinence, which is, I got to go to the bathroom quickly, it comes out before I get there. That's the most common type that's out there. We also have overflow incontinence and mixed urinary incontinence, but we're going to talk about stress urinary incontinence. And this is a cartoon showing like what are the different types of incontinence, what happens with those. But again, the stress incontinence at the far left, if you have something that stresses the bladder, you have increased pressure in the abdomen that creates a pressure effect, then urine's going to come out. That's what we're looking to treat. So how do we have normal continence and normal control? So a stable bladder is one that holds a certain volume, a certain amount of urine at a low pressure. And that's called a stable bladder. And then below the bladder is the urinary sphincter, which is right here, if you can see on the diagram, at the base where the prostate is. And it's a complex. It's made up of the bladder neck, which is the intrinsic or involuntary sphincter. And then it's the voluntary or the extrinsic sphincter is really right here, which, if you can see it, is that little layer below the prostate. And that's what wraps around the urethra and creates control. And so those are what keep us controlled. And when you have surgery, the intrinsic voluntary sphincter is oftentimes removed. And you depend on that extrinsic voluntary sphincter, and that's what we're looking at. So, and this shows you here where that arrow is, that membranous urethra. That's where the muscular, that sphincter urethra muscle is what creates that control for us after you've had your prostate removed. Because again, with radical prostatectomy, they're going to come in and they're going to remove, you can see the arrow here, right here in the bladder neck, this whole tissue here is removed. And then they'll take this segment right here and they'll reconnect it to the urethra right there. And this is the urethral length they talk about. They say, is your urethral length good? The longer that urethral length is, probably means you have a longer sphincter as well, to give you a better chance of being ultimately dry. That's kind of the anatomy we look at with urinary control. So What can you do preoperatively to try to improve your outcomes with control? So know your risk factors. So if you are older, so if I take groups of men, if I take a group of 40 and 50-year-olds and they have surgery by a surgeon, and then you take another group, say that are 70 and 80-year-olds and they're operated by the same surgeon, the younger guy is going to have better control without question. It's just their tissue tends to heal better and they have better long-term control. Body mass index, those who are not overweight. If your surgeon has to work hard and if he struggles in the operating room, struggle afterwards. So goal is if you can lose weight. So some people, if you're waiting to get to surgery, when I was doing prostate cancer support, I tell guys, look, your surgery's 2 months out, get an exercise program now. You can lose 10 pounds, 15 pounds. If you go into that surgery healthier, you have a better chance of having a better outcome across all parameters. So I really encourage that. And then if you have any other urinary issues beforehand, you're more likely to have those afterwards. So again, once you improve your diet, increase exercise, consider doing pelvic floor therapy, learn what that is beforehand so you're ready to get on that right afterwards. I think that's helpful. And then pick your urologist wisely. So again, like I said, if you, just like for me, I do a lot of this type of surgery. I don't do any robotic prostate surgery, but I do a lot of this type. You want to find somebody who's going to remove your prostate, somebody who's done a lot of these. And, there are different numbers of what makes them experienced. Some would say after done 100 or 200, they're probably, very good. But I think the more experience they have, the better off you're going to have in terms of your outcomes. And, what they're going to try to do is do everything anatomically. And if they can spare the nerves and they can spare the bladder neck and put everything back together anatomically, that's ultimately what you want and likely get your best chance at having good recovery. So again, other thing you could look at, as I mentioned about that membranous urethral length. What they found is that if you have had an MRI and they can evaluate, look at how long is your urethra, you'll find that if your urethra is longer than 12 millimeters or 1.2 centimeters, you tend to have a better control. And I can say from when I used to do prostatectomies open, I remember those patients where you could look down and you saw they've got a nice long urethra off the end of the prostate. It made the dissection for us easier. And those patients, you just kind of knew they were going to do better. And that still holds up today. So intraoperatively, so what can your surgeon do that can help make you have a better outcome afterwards? So one, nerve sparing. So prospective study looking at nerve sparing status. And what they found is that if you had both nerve spare, we talked about this before, where you can spare both nerves or just one nerve or no nerves. If you have both nerves that go to the erectile bodies and they are spared, men tend to have a better urinary control afterwards. So if you're from a cancer standpoint, you can have bilateral nerve sparing, I would go for that. Again, if you can have a bladder neck sparing approach where they really dissect out anatomically the bladder neck, so it comes down to a nice funnel. And then oftentimes they'll reconstruct the posterior part of the floor of the bladder to take tension off the anastomosis. And there are different names for it. Some people call it the Rocco stitch. But if you ask your surgeon, do you do a posterior reconstruction? If they look at you and say they've never heard of that before, you may want to at least ask questions of some other surgeons. And then blood loss. Blood loss is another predictor of outcome. So if you have less intraoperative blood loss, then you have a better chance at having immediate continence. If you have a lot of blood loss and you have bleeding as the case is done, that just means you don't have good anatomic control. You may put pressure as the anastomosis is there. If there's bleeding in that space, it may stretch out the anastomosis and create problems. So when we look at those things, the nerve sparing status, bladder neck sparing, and blood loss are important predictors of outcomes for having good urinary control afterwards. So again, talking about surgery and radiation therapy in what order. So again, for those patients who have high risk disease that you may need to have surgery and radiation therapy, what are we looking at? Again, those who had primary prostate surgery and then had radiation therapy added on afterwards, usually there's limited effect on urinary incontinence. And there may be some benefits to saying, when do you do that radiation therapy? So say you've had your prostate surgery and there's a question about positive margins. And your urologist and radiation oncologist wants to do radiation therapy. There likely is some benefit to waiting until you get the best control possible. Because say you're still leaking at the 2 to 3 month mark. If you can wait till you get control, maybe at 6 months or a year, and your PSA is still very low, and then add radiation therapy at that point, that may improve your urinary control long term. There may be an advantage to that. And then if we look at incontinence rates after surgery and then adjuvant radiation therapy, that's where we add radiation therapy after the surgery, we'll see incontinence rates are 15 to 20%. The erectile dysfunction rates are really 75 to 80%. So still 20% of men are getting erections after that. So there's some response there. If you do it the reverse, so say we take somebody who's got, high risk disease, they have radiation therapy first, and then they have recurrent cancer, and they need to have their prostate removed or ablated. Much more challenging situation. The surgery is much more difficult. Those who remove the prostate have a challenge. When you heal, we see you get these calcifications that form at the bladder neck and the anastomosis. Very often, these men have recurrent urinary tract infections, and these are the guys that are really tough for us to treat. They'll oftentimes have bladder neck contractures. Strictures will sometimes see fistulas. And when you compare the incontinence rate and the erectile dysfunction rate, it's really a different world. So those who had radiation first and then get a salvage prostatectomy, the incontinence rates are 75% and sometimes higher, and the erectile dysfunction rates 100%. All these men have problems afterwards with these other issues. But again, sometimes this is the way that we need to try to cure the disease. When we talk about how much or how does prostatectomy or post-prostatectomy incontinence affect someone's life, it is a significant impact on their life. When you compare incontinence after prostate surgery, it is 7 times more distressing than severe erectile dysfunction. So, patients in these interesting questionnaire, they look and said, how much would you be willing of your life survival to give up to get your control back, your urinary control? These men, I said, almost 2.5 years of their life they'd give up to be able to get their incontinence managed better, versus only 4 months where they give up for erectile function. So post-prostatectomy incontinence is really, it's a devastating problem. It's my favorite thing to treat because we really oftentimes can make life much, much better for you if we have a chance. So let's look at the instance of incontinence after robotic surgery. Looking at a high volume, these are high volume centers in the late 2000s, 2009, 8,000 patients, 1 year follow-up looking at stress incontinence. No pads at 1 year, 84% of patients. I mean, 60% were still incontinent at 1 year. And then, 0 to 1 pad incontinence at 1 year. So they actually were wearing a pad, that's 91%. So still 9% were incontinent if you use 2 pads as your marker for incontinence. So our rates of incontinence, at least in 2009 at high volume centers, was 9 to 16% at 1 year. Now you may get some improvement at time, but that's a number that was there from years ago. So 1 year following a radical prostatectomy, what's your likelihood of delayed recovery of erectile function and urinary function or urinary control? So if you have urinary control issues at 2 years, you've got a 30% likelihood of still getting some recovery of function. If you have it at 3 years, it's 49% of having still having issues, and if it's at 48 months, it's 59% issues. If we look at erectile function at 24 months, you'll still have erectile dysfunction 22% of the time. At 36 months, 32% of the time, and at 48 months, still having issues with erectile function at 40% of the time. All right, so let's look at stress urinary incontinence and skin excoriation. So this is a picture of a patient who came in, 1 week before his planned artificial urinary sphincter surgery. What we found is we had to cancel the surgery. He had a severe yeast infection and had this reaction around there. We had a secondary bacterial infection, so we had to treat his skin. And so we really have a program trying to minimize some of this before we go into surgery ahead of time. So what are our treatments for stress urinary incontinence? So we have everything from observation to clamps to bulking agents to balloons and slings and sphincters, and we'll go through these here. So after prostatectomy and you have incontinence, observation is reasonable, considering pelvic floor training is reasonable. And the American Urologic Society and the SUFU Society give a moderate recommendation saying that it's reasonable to do these and see if you can help. And so oftentimes we recommend that. Most of the time you'll get that from your robotic surgeons or your oncologic surgeons. We also recommend pads and clamps for this. These are other options. And this is what a penile clamp looks like. I still have men come to see me who've been incontinent for 10 years and never heard of a clamp. So I'm always happy if I can give a clamp to somebody or, show them that and they say, look, doc, that's all I need. My life is better. I'm good. I mean, my goal is not to do the most number of surgeries in the world. It's really to try to help somebody have a better outcome. And this is what the clamp looks like. This is a Cunningham clamp. You can get this on Amazon. They're very easy to use and try out. And I think it's worthwhile to consider using, even if you're early and after your prostate surgery, to use it, say, well, you're going to go to church, you're going to go out to dinner or something, so you have extra protection, so you're not worried about leaking. That can give you some a sense of security. All right, so say you have incontinence after your radical prostatectomy. When should you have a procedure to help? So the American Urologic Society and SUFU say that if stress incontinence does not improve by 12 months, then you should then at that point consider therapy. There's those of us who do this that if you have really severe incontinence, say 10, 12 pads a day, and it's 6 months after the surgery, we'll even talk about doing something sooner than that. And that's really just a discussion that you should have with your urologic surgeon. Now, I would say just to off the cuff, a lot of your oncology surgeons, the guys who do your robotic surgery, they're probably going to tell you keep waiting. It's going to get better, give it time. But I'm not biased in that I'm going to tell you, look, you fall into this category. It may be an advantage for you to think about it sooner to improve your quality of life if you wanted to do that. But there's nobody's died from incontinence, so you can wait. There's nothing that says you have to, but I think we have ways to make that better should you choose. All right, this is a bulking agent, just to show you how we do bulking agents. This is the way this is oriented. On the back of the screen is the bladder. The urethra is coming towards us, and that's a needle at 5 o'clock. And what we do is we inject this material under the tissue and the lining to create bulking and to close that. That's a bulking agent to create closure. And that works well in females. Like that picture is actually from a female, which I don't treat females anymore, but that was from about 15 years ago, and it can work well there. But we actually recommend against it in men who have had their prostate surgery. It really doesn't work very well. I can't think of anybody that ever did where they went, gosh, I am 100% better and happy. There's a chance of making it worse, and it may affect our surgeries when we go to repair that at a later date. So really, we recommend it against bulking agents at this time. PROACT, I don't have any experience with this yet. I'm interested to learn about it, but PROACT is you place these little balloons up the bladder neck. There's little injection ports that you can fill or decrease the volume to create compression of the bladder neck. So when you look at it, it's minimally invasive. You can adjust it afterwards, which is attractive. When you look at how dry were people after their procedures, only about 60% of patients were really dry, and the revision rates were at 22%, and even up to 70% at 4 years. And so right now, there's not any official recommendation for or against it, though I think it's something to consider and keep an eye on. That's the PROACT system. So let's talk about the sling system we have. So the current sling that we used most routinely is the Advanced XP sling, and this is a picture showing what this looks like. There's a moderate recommendation from the SUFU and the AUA for this, and what this is a mesh sling that is fixed to the urethra. We do this through a small incision below the scrotum, and then this mesh is fixed to the urethra, and then there's 2 small incisions on either side of the scrotum. We pull the mesh up to tighten it. And so the way this works shows you a little cartoon of how we put it in. So we have a little trocar that we pass along the side of the scrotum. And then the mesh looks like this. It's the same mesh that we see with the females that, the lawyers have the malpractice advertisements. But for us, we're putting it much deeper. We don't have the same issues that we have in females. So it is a safe product for men, but this is what it looks like. Here's an image showing what it looks like from the side. So the urethra here is in blue. The sling is in black. And what you can see is as we pull this thing up, we have a rotation of the urethra from where it sits, rotating up into a higher position, and we think a more anatomic position where we get better, more anatomic length of the sphincter. And so this is a drawing showing, again, if we blow this up from the side, you'll see when this mesh right here, if you can see my arrow, is pulled up, what that does is it rotates the urethra upward. And then here at the bladder neck, this is the length of the sphincter, which is relatively short. And then as we pull up on the sling, the functional sphincter length now is longer. And so again, we think it repositions the sphincter to work in a better way. And again, that's a similar thing here where you see that's the sling being tensioned up, and now we see the lengthening of that continence mechanism to give control. And that was the male sling. And so the artificial urinary sphincter is for more moderate or severe incontinence. It can also be used for more mild incontinence as well. But if someone has a higher volume of incontinence, then we think of the artificial urinary sphincter. And this really has been the gold standard. We compare things with this, what everything is compared about, the slings and other devices that are out there. You know, we try to see what we can do here. But when you look at outcomes, there was a recent trial done called the Masters trial, and it looked at, you know, sling versus the artificial sphincter. And when you compare the sling to the artificial sphincter, the sphincter had a greater improvement in the overall quality of life scores, had lower supported leakage, and a lower mean pad rate use. So this tends to be, I think, a really great treatment for those who have incontinence. So when we do an evaluation of incontinence, we do history and physical, we have you bring in your pads. Not everybody does that. We still find it helpful. We'll weigh those pads for you to see how much you leak in that period. We do a cystoscopy, which is a flexible scope to look in the urethra, and we're looking at the coaptation or the closure of the sphincter. We're looking for any scarring or contractures of the bladder neck. And then we do what's called a bedside urodynamics. We fill the bladder up, and then we have you bear down, cough, sneeze. We have to do certain maneuvers, and then we look and say, how bad is that leaking? And then that helps to put you in, have us put you in a category of what may be the best treatment for you. So here's just an image of a cystoscopy. Look in there, and you can see where that's the sphincter, which looks pale, and you can see a segment's missing. It's just not a healthy looking sphincter. And this little video of what is a coaptation of the urethra, and I'll show you this here, it'll play. Oh, but what happens is you'll see where the sphincter closes well, and it will, you'll see that you get a great closure with that, and that closure is what you want to have to tell us that, hey, your sphincter works well. So if we do a sling, that may be a reasonable choice for you. This one here shows where they contract down, and really it almost opens a little bit, and you'll sometimes see urine come out. And so we see that looks like a very poor contraction of a sphincter that, you know, we give a rating, a score out of 5. And the first one we would have given a 4 or 5. That last one we would have given a 1 or a 2. So again, that helps us to predict, are you going to be a better candidate for a sling versus an artificial sphincter? This is a patient who was set for surgery. So we were doing a cystoscopy. We saw this calcification at the bladder neck. They did not have radiation, so it wasn't a dystrophic calcification. We took him to the operating room to look and see what was going on. And as we manipulated, we found one of the clips from the prostate surgery had migrated into the anastomosis, so we removed that. Interestingly, this patient got better. I mean, I'm not sure why. Most men, even if you remove, they still have incontinence, but he got better. So we didn't have to do any other surgery on him, but we'll look for those things to see if we can make anything better. So with cystoscopy, again, we're looking for, you know, what type of anatomy, what type of look does that area. And we do a bedside urodynamics. For those who are a little bit, maybe have neurologic issues or something that doesn't sound right in the story, we'll do a standard or formal urodynamics, which is to look and see, does the bladder have changes in there that are not normal, that we may predict other issues that may need to be addressed. But sometimes you'll hear a urologist may do urodynamics, but it's not standard for us all the time. So we try to figure out who is the best sling candidate. So if I want a sling where I don't have to pump or do anything, sling candidates are those who have less leakage. So if you have, you know, less than 200 a day, and the less urine, the better. If you have a good looking and functional sphincter on cystoscopy and no defects in the sphincter, and if you've not had any prior urethral surgery or any bulking agents and no radiation therapy, that gives us a better chance at having control with a sling. And our success rates of that are really about 70 to 85% with the sling. And those who are poor sling candidates, therefore a better artificial sphincter candidate, are those who have the opposite. They've got more than, say, 400 cc's of leaking per day. They've got, bad looking sphincter, and they leak with minimal maneuvers. They've had radiation therapy. They're probably better candidates for an artificial urinary sphincter. And so we would go that route. And then to compare the two. So on the left side is sphincter, right side is male sling. Both are outpatient. Both have a Foley catheter, a drainage bag overnight. The artificial sphincter, you need to pump it to work it. The male sling, you don't need to pump anything. The sphincter is, we turn it on, or delayed activation, we turn it on in about 8 weeks. The sling works right away. So once that catheter comes out, you find out did it work or not. So you have that immediate gratification. The artificial sphincter is probably better for severe stress incontinence, and also you've had radiation therapy, and it's MRI compatible. Success rates for the artificial sphincter are about 80 to 90%. For the male sling, about 70 to 80%. With a sphincter, you got to be careful with a Foley catheter. If you ever go to the hospital again, they have to put a catheter and you have to have it deactivated, usually by us. For the male sling, there's not a big deal. That don't have to worry about that. We have some different things we've used to try to minimize risks of issues of catheterization. Those patients who have the artificial sphincter, we've used a temporary tattoo. That's worked well. That was one of the reps from many years ago. He's a very great guy. He came up with that temporary tattoo. In our system, we have an alert. So we put a diagnosis code in that says when you go to our hospital system or in our network, this comes up that says you have an artificial sphincter and cannot have a Foley catheter, because we have men who have this happen. They go to the hospital, they have a catheter put in, and they have an erosion of a good sphincter that worked well. And that's just an unfortunate thing. So we've now employed this. We've just gone to Epic. We're trying to get this put in the Epic system as well. So if one of my patients in Florida ends up, say, in Cleveland, Ohio, that warning would fire in their system as well, so that wherever they go, that's a warning for those healthcare workers too. So treatment options for stress incontinence, observation can do that, but won't get any better over time typically. Bulking agents, really less than 25% improvement. I think it's really lower than that. The bulbar sling is 70 to 80, up to 85% improvement. And the artificial sphincter, 80 to 90% improvement. And again, it's wide-ranging options. Treatment is oftentimes will help things. Rarely do they make anything worse. So again, it's relatively safe, and we have high satisfaction rates for both. Again, men love these. If anything goes wrong to them, they're calling us the next day saying, "Hey, can we get these fixed?" And that's the end of our lecture on stress incontinence. Take any questions if anybody has them.
I mean, that's a big wow, and wow spelled backwards. I don't know. We had you on like 6 months ago, and we did 1 million questions. So let me remind the audience that you can go look at our spring conference from 2022 to see all the questions I asked Dr. Brady. And so what I told him before the conference started is that you have so much information. I'm not going to let Moyad get in the way. Just do all of your presentations, and then at another time we can do an extended Q&A. But we're going to make our Q&A very short, maybe 10 or 15 minutes. So for those of you who wanted to get a lot of your questions in, we're going to collect those and do it at a separate time as sort of an after hours kind of thing, because I wanted to make sure that Jeff got all of his 1,248 slides in, because he had so much information to give. And I'm not going to comment on the Moyad, the supersize thing, because I'm going to stay Switzerland on that. And I'm not going to say whether or not I laughed really hard, but you can guess what happened there. And as a reminder, Jeff and Tom Brady rule, right? It's Jeff and Tom. Also, what I learned from his talk, also grapefruit juice is okay some of the time. Those are some of the subtle things I learned. And also what I want to share with you is I want to let you into my secret that you don't know this, but I was doing some of these exercises during your lecture. I'm sorry, I don't know if you noticed, but I was doing those. Just as a quick word on these exercises, you got to admit, over 20, 30 years, people say they're really important. They're not so. Do you find these important in your clinic?
Yeah. So I think that if you do them the right way, they may be helpful. And so oftentimes people are referred to physical therapists, learn biofeedback and make sure they're doing it correctly. So I think it's helpful. Do I think it's mandatory to go and, to have therapy all the time? Probably not. Again, I tend to see the patients who have failed. And so I'll tend to say, oh gosh, it really didn't work. And they'll say, should I go back and do more? I think if you go on to somebody who's, knows what they're doing, reputable, and it really hasn't worked, you've probably done your due diligence, don't have to do more. But I think if you do them right, it's helpful.
A quick word on something we didn't talk about this time. We talked a lot about it last time. Just your quick comment on it. This whole idea of the neurovascular bundles that used to be associated so much with, as you mentioned, with ED, now to be associated with incontinence. I don't even know what the question is, but do you want to comment at all about neurovascular bundles and sparing, not sparing, and the relationship between the two conditions, since you talked about ED and incontinence?
Sure. Yeah, it's good. It's a great question because, why would erectile nerves have anything to do with incontinence? I think it probably means that you've got a robotic surgeon who is very skilled and doing an anatomic dissection so that, they can see where the nerves are and they're going to be careful in the right plane. And if they respect the right plane, then they're sparing the nerves properly. If they are in that right plane, when we do surgery and you're in the right plane, tissue tends to separate into, more easily. When you're in the wrong plane, you got to cut and cauterize. But I think if these surgeons do it in the right plane and keep everything intact, and those nerves probably have some function that may help allow the sphincter muscle to work more effectively, because we don't understand how it all works. But if it's a good, clean dissection, done anatomically, and if those nerves are still intact and they supply some of the sphincter muscle so that it gets better contraction, that's probably why we get better urinary control.
When you talked about pre-op, I took a lot of notes. In fact, I felt like I was in high school again, trying to, talk to my friends during class. I took a lot of notes, going back and forth. So when you talked about your penile protocol or the pre-rehabilitation, or just, how you do rehab and do all these things before do it pre-op and then post-op, you talked about the vacuum erection, you talked about the prescription, the oral drugs like Viagra. You mentioned that as far as a prostatectomy. Do you feel that people should be doing all those things pre and post radiation too?
I think you should. Now, again, I think with radiation, you don't have like the acute injury right away. So I think, the way radiation, to my mind, and I'm not a radiation oncologist, but to my mind, you have the radiation delivery, and then those cells have in the cell itself have radiation changes. And so the effect of it is down the line. When the cells start dividing, that's when you go into cell death and you have the effect. That's why you have radiation. And the longer it takes for your PSA to go down, the better off it is. So the kind of slower the effect that you have, that you're going to get a better response. But, I think if you have some issues with erectile function, it's probably good to use those medicines to keep the tissue healthy. Because again, I've got a young scribe. He's like 23 years old. And, I joke with him when he's in the room with patients, and I'll say, look, Roshane gets, 8 erections a night, and, and the rest of us may not have that happen. Younger guys have those erections, and it probably helps to keep the tissue healthy. And so if we're not getting good erections, like say have radiation therapy and the erections are not as rigid, there's really not anything wrong in using things like Viagra and Cialis. It's not like you're going to become dependent on it. It's not like you're going to, something is going to atrophy. You're just helping it so that your erections are actually healthier. You're less likely to have trauma where you have buckling injuries. And so to me, there's not a downside. If you don't have side effects and you tolerate it well, it probably keeps your tissue, your erections, your penis safer using that than not. And so with radiation, I don't know that there's any studies that show that. It'd be interesting to do. I'd have to look and see. I'd like to know if that's out there, because it'd be an easy one to do and see, do people over years have less erectile dysfunction if they take, regular medicines. But I don't know that right now.
Hey, you know what I'm going to show you right now? This is happening in real time. This is crazy. You're going to love this. My wife left and my dog is crying. That my dog seems to think, he's like, wait, those two guys have prostates. And so, Brady gave me a good lecture on how, as I get older, I don't have to suffer from incontinence or ED. So I think the dog started climbing up on me during our Q&A. Sorry. So that was just a moment of spontaneity. All right, here's a couple other things I want to talk about. Venous leak. That comes up all the time. This is what I don't get. How do I know if I have venous leak?
So what is venous leak? So venous leak is, if you have a couple ways you can do it. One is by history. You tell me the story and we know what happens. And then two is you can have a Doppler ultrasound where they can measure flows. And so, so when you have a Doppler ultrasound, and I don't do very many because it doesn't change what I do. I think in academics, it's probably helpful if people are looking at things and trying to, figure out the basic science of what's happening. But so when you get erections, arterial inflow. And so when we measure it, we can get what's called a peak systolic velocity. And so we do a measurement with a flaccid or a soft penis, give an injection, and blood flows into the penis. You do the ultrasound and you can say, okay, you now have 45 cc's per second. That's actually good. So you got good inflow. And then we measure the end diastolic velocity, and that is the outflow of blood from the penis. And it should be 0. So if you've got no venous leak, you can demonstrate no flow out. So it should be a full rigid erection. And if you wanted to demonstrate that, you can identify it. Now, the problem is you have to get a fully rigid erection and make sure you're getting a response when you do the intracavernosal injection for that test. Because you get a partial response, you get partial filling, that means blood's going in and coming out. And so you may see and be fooled that you have a venous leak because you don't have a full erection. Wow. And that's in the kind of the testing setting. So you'd measure it by end diastolic velocity. In the real world, it's that you get an erection, but you may lose it. So say kind of you stand up or you move, so you kind of get it, but then the erection starts to go down. That means you're getting the erection that to get full to begin with. So you probably have good inflow, but you're having a leaking out so that you don't maintain the pressure. So if you get a real good erection, but then you start to lose it, not after you've climaxed. This is before you climax. It's when you don't mean to lose it, it starts to go down a little bit. That's really a history that suggests you may have a venous leak.
Wow, yeah, because that term comes up all the time. So I'm just thinking, how are they diagnosing this unless they're going to a specialist? It's like, and that's a really good point. Do you want to explain why you're wearing a Davidson top? By the way, you're wearing a Davidson college shirt. Do you want to explain why you're not wearing, a college shirt like Lemoyne where you went to college?
Yeah, now it's my kids. I told my daughter is at Davidson College, so we visited her last week. It was kind of neat. Steph Curry, he graduated, so he got his diploma. He had his jersey, was retired, and he got elected into their Hall of Fame. So we got to go visit, so it was fun. So I'll wear this for a little while.
Where Dr. Brady is the luckiest guy I've ever met. I played basketball in college. I've been playing basketball most of my life. He gets to meet Steph Curry, and he's a baseball player. You're a baseball player. There's something wrong about that. You mentioned shockwave therapy for ED, right? I thought it was really interesting. I don't know if you saw the AUA came out with this and said, that shockwave therapy looks interesting, basically what they said, but they said a lot of these other devices being offered on TV and other places don't have the same kind of evidence and isn't shockwave therapy. So what I don't know if there's a comment on your part, what they're basically saying is you need to ask if when you go to some clinic, are they actually giving you low intensity shockwave therapy, also known as LISWT, because they're saying there's a lot of copycats out there who are claiming they're giving it, but they're not. Do you have any comment on that? That kind of caught me off guard. And you mentioned it.
So again, there are different delivery systems for this. And so to get the effects that we're looking for, which is again, neogenesis or new blood vessels in the penis, it's got to be delivered a certain way. You have to be careful. I mean, we had a nurse who joined our practice a couple of years ago who came from another part of the country, and she was the tech who did the therapy. And that's what I kind of asked you about because I was interested. I'm ED guy said tell me because it's interesting, and I intellectually I'd love to have something you could do to make things better that's not surgery, to kind of cure the problems. That's what you think. The concept is you cure it by have the patient develop new blood vessels. what I was sort of not excited to hear is she got a bonus if she encouraged more guys to do it. And so, so she really incentivized, and she would then tell people, oh, we do it. So you have to be careful who you ask, because I think, some people are incentivized to say, yep, it works, because, these machines can be expensive. The radial systems, they're, I think, on the order of, I don't know, 20,000, and I haven't shopped for it, so I don't know the current prices, but I think it's $20,000. And then the more, the electrohydraulic and the piezoelectric, the other systems that are really better, they're like $50,000 to $60,000. So, the ones that really tend to work better are more expensive. And so you really have to be dedicated to do that. And then you're going to have to do a certain number, and there's business models of how do you recoup that expense. Really, at least I think the word is out, and are these things going to help you? Because I don't know that we got really any data that shows that. So my recommendation would be is, if you live near a university, see if your university is doing any studies. And like, I'm sure University of Michigan is. We don't have any in Orlando, but somebody at the University of Miami is doing studies, and they're looking at, and that's what you want to do, is get in a study where you're not paying for it. Right. You may get some benefit, and then you may actually help others. So down the road, we know what's the right way to do it.
Yeah, no, I just thought that was really, really interesting. One word on penile prosthesis. How long, because you do a lot of these, right? How long does it take on average? I know these are all really, these can't be generalized, but I have to generalize for the sake of time. If I'm going to get one done, what's the average time it takes to put one in? And then how quickly can I use it? I mean, what are we talking about? Does this take 30 minutes, couple hours? Do I have to wait a couple months? Can you just answer those two?
Yeah. So if you say you had surgery today, so say we're going to put in the Moyad size device, that may take a few hours, but the most standard regular size devices, if we're going to do something that's regular, it usually takes between a half hour and an hour. So it's an outpatient surgery. So, you go home and sleep in your own bed. You're not stuck in the hospital. And really, I think it's changed from what it used to be. It used to be, we did the surgery, we kept you in the hospital overnight, we had a pain pump. Really, I've learned from the anesthesiologist, and frankly, the nurses in the recovery room, they used to comment, I used to just give like 10 cc as a penile block alone. And the surgery center that I operated on, my patients come out sleeping and very comfortable, and some of the other urologist patients come out, they'd be screaming. They say, what do you do that's different? And I said, well, I give a penile block, which is a local anesthetic. And they were very comfortable. And so now, instead of just getting 10 cc's, I say, I see based on weight, what's the volume they can get. And then we administer that. We now use Exparel. So it's a liposomal Marcaine that is released over time so that you have it for a longer effect. So now patients are pretty comfortable, but the procedures usually say under an hour. You're in the hospital, say, for half the day. You go home same day. You will have some swelling of the scrotum, and the penis, you'll be sore for a couple weeks afterwards. So it's good to take a week or two off of work, just to lay low so you recover well. And then usually by 8 weeks, most men, we teach them how to use it. And then it's a little bit of a learning curve of how do you use it. Right now, there are pumps. In the future, there may be a remote control or an app where you just press it and that happens. Unfortunately, the wife gets that remote control, but that is probably a couple of years down the road. But they do have prototypes, and so we'll see what happens.
Okay, that's really interesting. Last but not least, I had a million other things to ask you, but I did this to you last time because I just wanted to cut to the chase on it. These are the 3 procedures we talk about. Just these, I know the 2 that you focus on. The quick Tom Brady, Jeff Brady synopsis of the ideal candidate for a sling in your clinic and the ideal candidate for when the sling's not going to do it, but I need a sphincter.
Right. So when we look like who is the right person for the sling, it's somebody who has had a radical prostatectomy. It could be a TURP as well for BPH, but prostate surgery. They've not had any radiation therapy. They don't leak a tremendous amount. So that's where the pad can put them in a category. So, say 2 to 3 pads a day is not bad. If they're coming in with 10, 12 pads a day and it's really saturated, probably not a great candidate. if they've not had a bulking agents like coaptite or Durasphere or macroplastique, because those things really kind of get in the way of how the sling may work. And if on cystoscopy, which we would tell when we look in there, is how does their sphincter look? If it looks healthy and contracts well, because the sling just puts the sphincter back in an anatomical position to work well. If that's working well, then great. If it doesn't work well, then I'd probably then, push people more towards the artificial sphincter, because that does everything. You don't have to have a functioning sphincter or anything else to work well, to be work. So if those are our best candidates for this sling, and everybody else, really, we would sort of default to the artificial urinary sphincter, because that's really our best overall device.
This is the second time we've done this in 6 months. And all joking aside, I know you and I like to joke a lot behind the scenes, and goodness knows you like to joke about me a lot on your latest lecture. But I do want to say thank you. I mean, you've been a huge hit. You've been a huge hit with the group, with the population of people, including healthcare professionals, patients. I mean, there was just a consensus to bring you back in terms of the way you explain things. And the funny thing is, I've known you for a while, and you've always been that way. So maybe we made the mistake by not inviting you years ago. But I just really appreciate it. And I think for people that really want to learn more about ED and incontinence, besides calling you, which I always encourage them to, because you always like to walk through all the objective options. I've had friends call you who I've known for a long time who are docs, and they've been very, very happy with you just having a conversation, whether or not they have a procedure. I just appreciate everything you do, and that you're specializing in this category. And so, apart from the fact that I think it's completely wrong that you met Steph Curry from the Golden State Warriors, and I have never gotten within 100 yards of him, I really appreciate everything you do. So thanks, man. Thanks a lot for doing this.
Oh, I appreciate it. Thank you for having me. I'm happy anytime to help.
Prostate Cancer Research Institute is an educational organization for prostate cancer patients, their caregivers, and their families. We put patients first and are an unbiased source of information and support. For over 20 years, our goal has been to meet the educational needs of prostate cancer patients at every stage of their journey. Medical technology is advancing rapidly, and new treatments are becoming available. Patients have to make complex choices which have lasting implications. They face unexpected industry biases and doctors who may not be up to date on the latest research. Your donation helps men receive the latest, most up-to-date information, which empowers them to make informed decisions. Our website, pcri.org, is a wealth of information and resources. Our conferences and webinars are a way to get patients' questions answered by leading physicians and researchers. And we have a helpline for men to call with questions about their diagnosis, treatment choices, and side effects associated with these treatments. Each week we produce multiple videos covering concepts and every patient question that we can think of about the disease in a straightforward and easy to understand format. This was a brief overview of what we do at PCRI, and to learn more you can visit our website. Your donation directly funds our educational programs, which give life-changing information to men during a very vulnerable time in their life, and we thank you for your consideration. You can visit pcri.org to learn more.
Provenge is an established cellular immunotherapy used to treat certain men with advanced prostate cancer. Provenge is customized to each individual and is made from his own immune cells. Immunotherapy is the prevention or treatment of disease with substances that may stimulate an immune response. The immune system has memory and can recognize substances it has encountered previously. Immunotherapy is designed to boost the immune system to target and attack advanced prostate cancer. This is why immunotherapy empowers the immune system to fight the cancer immediately and allow the effects to last over time. Indication: Provenge is a prescription medication used to treat certain men with advanced prostate cancer. Provenge is an established cellular immunotherapy and is customized to each individual by using his own immune cells. Important safety information. Before receiving Provenge, tell your doctor about any medical conditions, including heart or lung problems, or if you have had a stroke. Tell your doctor about any medicines you take, including prescription and non-prescription drugs, vitamins, or dietary supplements. The most common side effects of Provenge include chills, fatigue, fever, back pain, nausea, joint ache, and headache. These are not all the possible side effects of Provenge treatment. Provenge is made from your own immune cells, which are collected during a process called leukapheresis. The cells are processed, returned, and then infused back into the patient through an IV, intravenous infusion, approximately 3 days later. This process is completed in 3 cycles, about 2 weeks apart. Each infusion takes approximately 1 hour and requires 30 minutes of post-infusion monitoring. Provenge infusion can cause serious reactions. Tell your doctor right away if you have signs of a heart attack or lung problems, such as trouble breathing, chest pains, racing or irregular heartbeats, high or low blood pressure, dizziness, fainting, nausea, or vomiting. Have signs of a stroke, such as numbness or weakness on one side of the body, decreased vision in one eye, or difficulty speaking. Develop symptoms of thrombosis, which may include pain and/or swelling of an arm or leg with warmth over the affected area, discoloration of an arm or leg, shortness of breath, chest pain that worsens on deep breathing. Have signs of infection, such as fever over 100 degrees Fahrenheit, redness or pain at the infusion or collection sites. Tell your doctor about any side effects that concerns you or does not go away. For more information, talk with your doctor. You are encouraged to report negative side effects of prescription drugs to the FDA. Visit www.fda.gov/medwatch or call 1-800-FDA-1088. Please see accompanying full prescribing information.
Sorry, I assume I'm starting. Okay. Yeah. Good afternoon, everybody. Thank you for taking out your time to share with us some important information and regarding prostate cancer. This slide deck presents certain basic medical information regarding prostate cancer, but then it focuses specifically on several stages of prostate cancer. Provides an overview of prostate cancer. In particular, it focuses on the role androgen or testosterone play within prostate cancer disease state. And we're going to talk about the process of disease progression and clarify some of the nomenclatures and the treatment of different stages of prostate cancer. So first, we start with state of prostate cancer. Prostate cancer is, in fact, the most common cancer in men based on 2019 statistics. And this often is surprising to many people. Prostate cancer, in fact, is more common and more prevalent than even lung cancer and colon cancer in men. The death rate for prostate cancer is also the second highest of all the cancers. And the estimate is that based on 2019 numbers, 1 in 41 men will in fact die from prostate cancer. The risk factors for prostate cancer: age, risk rises significantly after age 50. Race, increased risk of prostate cancer in African Americans in particular. Geography, which some think may be related to diet, is most common in North America, Western Europe, Australia, and the Caribbean islands. Family history clearly is a risk, is higher in men with affected relatives, and certain inherited gene changes, which obviously is sometimes found within the family history as well as other factors. And I tend to focus on the diet and obesity, smoking, chemical exposures. Prostate cancer symptoms. Early prostate cancer usually cause no symptoms. More advanced prostate cancer sometimes cause symptoms, but not always. Problem with urinating, blood in the urine, erectile dysfunction, pain in bones, hips, spine, ribs, weakness and numbness in legs or feet. But a lot of these symptoms can be seen in many other conditions. And oftentimes, even in advanced prostate cancer, there are no symptoms. Because often prostate cancer, especially in early stages, lack symptoms. Prostate cancer screening at the early stage is, in fact, very important. There are several key methodology and testing that we use for screening. I think everyone here is probably familiar with the blood test PSA, or prostate-specific antigen. The digital rectal exam is still important. When the doctor places a finger in the rectum, we could feel one side of the prostate, the side of the prostate that faces and is right next to the rectum. But obviously, prostate is a three-dimensional structure, and the digital rectal exam cannot detect all sides of prostate. And prostate biopsy, which is beyond screening now, is really the main method used to diagnose prostate cancer. And the biopsy is typically performed by placing a needle in the rectum that traverses the rectal wall, goes into the prostate in literally a fraction of a second, takes a small slice of prostate, and we then submit that to the pathology doctor, who will let us know what they see under the microscope. And prostate cancer affects men differently. Research has shown that there are several typical behavioral patterns men may have in dealing with prostate cancer. It could be proactive, could be more practical without any emotion, which as men often are, could feel confused and simply want to follow the doctor's order. And this is not mutually exclusive with the first two approach. And the fourth approach, feeling hopeless, as if there's no choice but to go through the whole process. Regardless of how men cope, the advances in treatment mean there are more opportunities to provide meaningful solutions to patients and their loved ones. And it is important for the men to really understand the new advances in treatment and to take ownership of their treatment process. So we will now talk about the role of androgens in prostate cancer. Androgens, typically we use testosterone as the principal androgen. So there are several different disease states of prostate cancer. On the far left is localized prostate cancer. This is when prostate cancer was first diagnosed and has been found to be present only in the prostate. And typically then the prostate cancer at this point can have a good chance of being cured by one of several treatment methodologies. After the treatment of localized prostate cancer, if the PSA in that treated patient starts to rise again after definitive treatment, we call that biochemical recurrence or PSA failure. Then there's several disease states that may perhaps be a little bit more confusing because it gets more complicated and we're getting into complicated acronyms. And don't panic, in this slide presentation, we will go through each of those in great details to make sure everybody understands the different disease states. So that the tools that help diagnose and identify prostate cancer recurrence or progression. First, blood tests, and PSA is continues to be an important test. Past the screening, as we continue to go along the progression of prostate cancer, PSA is important. Measurement of testosterone, the male hormone, is also important. Radiologic imaging is also important. We use bone scan to detect bone metastases, as prostate cancer tends to first spread lymph node and bones. Bone scan is very important. CT scans of the abdomen and pelvis typically to check on the visceral organs such as liver, as well as the lymph glands, the lymph nodes, which prostate cancer tends to metastasize or spread to first. And MRI as well. And MRI has become more important over the last 10 years, as it is capable of detecting the majority of prostate cancer that's still found within the prostate itself. So we're looking at the first stage, which is localized prostate cancer. This is when men are first diagnosed with prostate cancer that has not spread beyond the prostate, and there's several treatment options. One is active surveillance. So active surveillance means no treatment per se, and this is possible because prostate cancer is a very slow-moving cancer. And within the spectrum of prostate cancer, there are slower moving versus higher moving, faster moving prostate cancer. And certainly those with a lower or mid level of aggressiveness or progression speed are oftentimes suitable to go on active surveillance, where no treatment is rendered, but patients are watched carefully by repeated testings to detect, if any, signs of prostate cancer progression. Or when you have localized prostate cancer, you can have surgery to remove prostate. Most of the surgery these days are performed robotically. And the third method of managing localized prostate cancer is radiation therapy. And radiation therapy has progressed very rapidly over the last 25 years. Radiation therapy, as you probably all know, is really mostly external beam, which means the doctor is just shining the light on you. So because of the advance in computer graphics and 3D modeling and the radiation equipment, radiation therapy nowadays are very precise. People who go through radiation therapy for prostate cancer often have minimal side effects. There's no hair falling out anymore, and it's in fact a very tolerable method of treating prostate cancer. We also want to focus on the role of androgens in men in general. Androgen, the principal form in men is testosterone. It's produced in human bodies, naturally produced. Testosterone or androgens they're needed for prostate to function normally. They're in fact a key component in enabling prostate to grow. And prostate cancer cells also, for the most part, need androgens to grow. And so how it functions that the triangles are androgens, testosterone is made by our body, and cells that respond to testosterone in our body have receptors. So this little quarter circle with little divots, triangle shape, are receptors on the surface of cells. And testosterone can attach to these receptors and thereby activating the cells. And the role of ADT, so ADT stands for androgen deprivation therapy. So it is by one method or another to reduce the testosterone in men, and thereby by taking away the testosterone, which is a key growth factor for prostate and prostate cancer, will reduce the growth of prostate cancer and oftentimes cause the shrinkage of prostate cancer. So it's called ADT. Now, the other ADT, the original way of removing androgen prior to medication is in fact by doing surgical castration, removal of the testicles. So that, therefore, the other name for androgen deprivation therapy is also called castration. And this will have an import as we go on to the next few slides. So coming back to localized prostate cancer, if the patient has elected to go through either surgery or radiation therapy, so we call these definitive therapies, and sometimes ADT or androgen deprivation therapy is used after the surgery and radiation, especially in the situation where the cancer may have been more aggressive. Androgen deprivation therapy can be used to reduce the risk of cancer recurrence. So this is how androgen deprivation therapy works. When the androgen or testosterone attach to the receptors, they stimulate the prostate cancer cells. And androgen deprivation therapy, by one method or another, it reduces the amount of testosterone in the man's body and thereby reducing significantly the growth stimulation to prostate cancer cells. And then the prostate cancer cells will hopefully stop growing, and in many cases, the shrinking of prostate cancer by bulk. And reducing the androgens could be done either with medication or through surgery. Again, through surgery is just called castration therapy. Talk a little bit about disease progression. So the disease can progress to a state called castration resistance. So castration resistance means that the patient has gone through some sort of castration therapy, so their testosterone has been reduced significantly. But the prostate cancer cells eventually figure out how to continue to grow and thrive on a very low amount of testosterone that is still present in our body. And so this is when it's castration resistant, because a patient has gone through castration therapy. Literally, a patient can go through castration, have testicles removed, and there will still be a small amount of testosterone in our body that's made by principally the adrenal glands. And then the prostate cancer at some point learns how to continue to grow and thrive even in that reduced testosterone environment. So it's been estimated that 10 to 20% of patients diagnosed with prostate cancer will develop castration-resistant prostate cancer within 5 years. And Castration-resistant prostate cancer is a disease state that is clearly takes us into a different severity state. Before this, there are good treatments. Most people respond to androgen deprivation therapy really well. Testosterone drops, PSA drops, tumor shrinks, and up to this point, it's easy for the physician and the patient to feel like that they are in control of the disease. When castration-resistant state hits, which occurs in 10 to 20% of patients, then we get into a state where much more advanced therapies will be necessary, and each therapy works only for a limited period of time, signifying a significant escalation in the severity of the disease. So let's look at the first disease state acronym that we will dissect here. So NMCRPC, it's a mouthful, and stands for non-metastatic castration-resistant prostate cancer. So this is non-metastatic, NM. So metastatic means spread to body parts outside of the prostate. So non-metastatic means that the prostate cancer has not been detected to have spread to other parts of the body, but yet it's castration resistant. So how do we know it's castration resistant? It's because by monitoring their testosterone, we know their testosterone is still really low, so they're still in the castrate state, but their PSA is starting to rise. So the cancer is growing in spite of the castration. So castration-resistant prostate cancer. Yet it hasn't really progressed to the point that the disease are bulky enough to be picked up by imaging tests. Early identification is vital in patients who have non-metastatic CRPC, because at 2 years, 46% of people developed spread to bone, and 20% of people, in fact, died within 2 years. So this, even though it's non-metastatic, but when you reach this non-metastatic CRPC status, the severity of disease is highly escalated, with 20% of people dying within 2 years, and 46% of people having metastases within 2 years. And just reading the print on the right side, metastatic CRPC is when the cancer has spread to distant areas of the body and patient has stopped responding to ADT. So some men could progress to metastatic cancer regardless of whether they ever receive ADT, right? So there are people who, even when they first get diagnosed with prostate cancer, that already have metastases. And this disease state is more common because starting about 10 years ago, the recommendation for screening for PSA for prostate cancer was relaxed. And studies have shown that there are now more men presenting with metastatic cancer or cancer that's spread outside prostate already at diagnosis. Or men can have metastatic cancer because they have been treated previously already, but their cancer has now broken out of the control of ADT and has continued to progress and spread. Second acronym disease state we'll look at is metastatic castrate-sensitive prostate cancer. So the difference here, this is metastatic, whereas the prior one was non-metastatic, and this is castrate-sensitive, and we'll get into that. So first of all, this is when prostate cancer has spread to other parts of the body as detected by one of the imaging studies. But it can still respond to castration therapy. So this is called metastatic castration-sensitive prostate cancer. So typically, when men are diagnosed initially and if found concurrently to have metastatic disease and they have not been on ADT, their cancer at this point is typically still sensitive to ADT treatment, so therefore castrate sensitive. Or people who've been previously treated for prostate cancer with surgery or radiation, and now with recurrent disease, but is not currently on ADT, then they are likely also castration sensitive, meaning that their cancer will reduce in size, in bulk, PSA will drop with castration therapy. So when we look at a patient, and when the patient looks at himself, we look at the individual and we take all the different factors of the individual into account to decide if a treatment is appropriate. Age and expected lifespan. The treatment considerations for a 70-year-old man is very different from a 90-year-old man because of the different life expectancy. And other chronic disease or condition. A 70-year-old healthy man is very different individual from a 70-year-old man who has diabetes, heart disease, hypertension, has had a stroke, and is not mobile. State and grade of prostate cancer. Grade is of the prostate cancer is really kind of what the prostate cancer looks like under the microscope, and it's correlated with the aggressiveness of prostate cancer. So low-grade disease, low-grade prostate cancer is expected to move very slowly. High-grade prostate cancer is expected to move much quicker. And then we need to look at the pros and cons of each treatment option. How much help is it going to provide, and how much distress, side effect will it cause, are all taken into consideration. So it's a complicated redux that's different for every individual at every point in the disease process. So the treatment options. So on the two disease states that we looked at. So if you have the non-metastatic castration-resistant prostate cancer, so here someone typically is already on castration therapy, ADT. That ADT will need to be maintained to the ADT that already has been ongoing. Additional anti-androgens medications can be added, which will serve to block the residual low amount of testosterone that still is present. An observation, and sometimes people do observation because they don't want additional treatment. This should be a patient's choice for one reason or another. And since there's no metastases, sometimes people feel comfortable watching it. The other state, metastatic castrate sensitive. So this is typically a guy who either has had prostate cancer previously and now is found to have prostate cancer coming back, or someone who was first diagnosed to have prostate cancer but has metastatic disease already, has cancer already outside of the prostate. So the first and foremost treatment is ADT. And studies have shown that anti-androgens, which are additional androgen reduction medication or chemotherapy, if added to the standard ADT at this point, can actually give longer survivals. What's really important is to empower yourself, the patient, take control of the treatment process. There are three main areas that people struggle in managing prostate cancer. Confusion about the state of prostate cancer and treatment options. As you can see, the states of prostate cancer can be very complicated and many, and the treatment options even more variable. It's a blessing because over the past 10 years, there are probably more than 10 new treatment options for prostate cancer that's been approved and found to be effective, but it has added a lot more knowledge in the space, and confusion is not unusual. But not understanding what the future holds and how prostate cancer can progress, it adds a lot of anxiety, fear of the unknown. And the other area is that there can be an underappreciation of what it means to progress to the metastatic stage. When it's metastatic, especially castrate-resistant, as we saw in the statistics, is a serious illness. And prostate cancer in its early stage, especially the slower moving prostate cancer, we can be so relaxed as to just watch it. But when it progresses to metastatic stage, it's a different disease state with completely different prognosis and complications and implications, and a different approach needs to be adopted. And these are areas where the patients should educate themselves, their loved ones should educate themselves to understand the options, the awareness of the treatment options, so that the patient can be empowered to manage his prostate cancer. And you do this by asking questions, doing research, seeking a second opinion. Don't be afraid to seek out another doctor, prostate cancer expert. You need to really find out and understand the different treatment options. How can it affect your health and life, both the positive aspect as well as the negative aspect, and know that you are in control of the health decisions and that your health status is important for discussion with your healthcare team, which includes not just the doctors, but also your loved ones. And the key questions are, and I'm sure we all wonder, is my treatment actually working? If it's not working or not working well enough, what options are there? What more can the patient or the physician do? Has the cancer spread? Has there been metastases? If not, or even if yes, how can you delay the metastases or delay further metastases? These are essential questions to know and to understand of your own disease state. There are a lot of resources. These are more reputable resources versus other resources that Dr. Google may provide. And American Cancer Society, National Cancer Institute, Cancer Support Community, cancer.com, all are reputable websites that can provide appropriate evidence-based information. So thank you for sharing your valuable time with us. I hope we have imparted some knowledge that may be helpful.
Thank you, Dr. Koo. Our next speaker is Dr. Laurence Klotz. He's a world-renowned expert urologist, and he's the father of active surveillance. He basically created it. Dr. Klotz is an incredible friend of the PCRI, always volunteering to help educate our patients, and he serves as a professor of surgery at the University of Toronto and holds the Sunnybrook Chair of Prostate Cancer Research. Today, he's going to give us an update on active surveillance. So welcome back to our conference, Dr. Klotz.
Hey, welcome. Here we are, 2022. We got the beautiful introduction from our CEO, our fearless CEO, Alex Scholes, and now we move on to the next level, which is basically, I'm not going to do an introduction because A, I don't believe in introductions for people that are so well known that to say anything more than an introduction is almost insulting. So When I went to my first Frank Sinatra concert, they said, ladies and gentlemen, Frank Sinatra. That was it. There was no introduction. Same thing happened with Michael Jackson. Same thing happened with a lot of other famous people. They decided, why waste the time with the introduction? So Dr. Laurence Klotz, welcome. I've known you for 20, 25 years. And I told them one of the requirements after, at least before or after your presentation today, if people don't know this, he's very skilled outside of medicine. And one of his skills is piano playing. So if he should retire anytime soon, he could start working at the bars and clubs in the Toronto area. And so I said, there's no way in HE double toothpicks, we are going to start a talk on active surveillance and have fun together unless you play the piano. So with that incredible introduction by me, I leave it to you, Sir Laurence Klotz, and I want you to open up your intro with a piano playing medley, unless there's something else you want to add to my introduction.
Thanks, Mark. Yeah, great to be back. Well, for those of you who were present 3 years ago in 2019 in Los Angeles, you might recall at the end of my talk, Mark came up and there was a big kind of shape under blankets at the edge of the stage. He said, you can take the blankets off now. There was a piano, and he says to me, please play. That was my warning. So this time he said, okay, we want you to return visit. So at least I had a little warning this time. And so, yeah.
If I had a $5 bill or a Canadian one, I'd put it into a cup next to your piano. Bravo! Bravo!
All right, thank you.
Thank
now
you.
We get serious. I'm going to switch to my desktop computer and we'll keep going. Hello, ladies and gentlemen. And again, it's a pleasure to participate in the PCRI symposium. It's really been a wonderful tradition over the years. And I've had some very memorable experiences, probably of which one of the most memorable is having the piano sprung on me at the end of my talk back 3 years ago. And despite my playing, they invited me back. So I'm happy to be here. This is Toronto looking at its best. Sky Dome, CN Tower. It's become a beautiful international city, and I really welcome visitors. So I'm going to focus on active surveillance, kind of what's happening. It's become a very active field. My disclosures, I'm going to mention briefly the products of both Exact Imaging and Mere Scientific, the high-resolution ultrasound in the case of Exact, and the Sentinel assay. And I receive research support, and I'm a consultant to both. So today we've got real progress in a whole slew of areas related to conservative management of grade group 1 and higher prostate cancer, a lot better understanding of the molecular genetics of grade group 1 or Gleason 6 or pattern 3. They all mean the same thing compared to higher grade cancer. I'll come back to this. Patient selection, what is the impact of age and race and family history and so on? The importance of germline testing, particularly for DNA repair defects. Imaging, obviously MRI has been a game changer, but new imaging modalities like high resolution ultrasound and PSMA are both having an impact. The role of biomarkers, both the strengths and the limitations, I don't use them very much. I'll explain why not. They do have a role in some situations. It's quite important. Predictive nomograms. So people have modeled surveillance compared to intervention, and essentially these have shown that first of all, the robustness of the approach, and also using clinical parameters to identify patients who are at risk, for example, who are at higher risk for having higher grade cancer in their prostates. I'll come back to that too. Long-term outcomes. So a criticism for at least 10 years after we first reported was, you're reporting too soon. You guys wait. You'll see what happens. The patients are going to start dying if you wait long enough. And that has simply not happened. And now we have many hundreds of patients, probably at least 500 patients in the collective prospective series who've been followed more than 15 years. And there is no cliff of mortality. Patients continue to do well. Follow-up strategies. This is an area where there was a lot of heterogeneity and differences in practice. These are starting to get more consistent as people share ideas and experience and decide how much is necessary, how much is not. A very fascinating area here is the tumor microenvironment and how some environmental and dietary and other influences influence the tumor microenvironment and alter the rate of proliferation and invasiveness of these cancer cells. So I'll mention some of the recent data on this. And finally, and this has been a longstanding interest of mine and of course Mark's, but dietary and other innocuous interventions in men on surveillance and how you can actually not only improve their general health, but reduce the risk of prostate cancer progression, often with the same intervention. So I'll cover a lot of this over the next 40 minutes or so. This is a scientific talk. I've tried to target it to a level of informed, scientifically literate lay people, but just some acronyms, PCA for prostate cancer, GG for grade group 1 is Gleason 6 now. We've changed the lingo for those who are new to this. It used to be called Gleason 6, now it's grade group 1. The main reason for this is people would hear Gleason 6, which is the lowest Gleason score, and their interpretation was, okay, I'm 60% of the way to the grave. Whereas hearing there are 1 out of 5 is much more reassuring and is actually much more accurate. Grade group 2, Gleason 7, and so on. OS for overall survival, CSS, cancer-specific survival, the likelihood, in other words, of not dying of the cancer. Progression-free survival, the likelihood that the disease is stable without evidence of new disease showing up somewhere, PFS, AS for active surveillance, ultrasound. And this, I'll just explain what this forest plot is. This is how, in the medical field, we display huge amounts of data very concisely. So this is an example. Each one of these lines is a clinical trial. And it shows, for example, in each clinical trial, how many deaths. These are randomized trials. So, for example, in this trial, this set of trials, these patients got a steroid, these got placebo, and this shows the likelihood of dying in this case. The longer the line, the greater the confidence limits. The larger the square, the greater the number of patients. So you can see more patients, tighter confidence limits, and vice versa. And then down here, you see what's called the effect size, which is what is the impact of this treatment on, for example, reducing mortality. And the size of the diamond is the kind of confidence limits or the uncertainty. So I'm going to show a few of these, and just so you're not completely bewildered by it, it's a very useful technique for summarizing, in this case, what did the 7 trials show that studied this question? Okay. So now on to the topic. So it's really been an amazing journey over the last 20 years, from a great deal of pushback against the concept of conservative management. Patients are going to die. This is not safe. It's not ethical, etc., to really now widespread acceptance all over the world. These are each regional guideline groups, NCCN in the US, the consortium of AUA, ASCO, and ASTRO, it's a radiation oncology. This is medical oncology. The Canadian Association, Europe, Japan, Australia, everyone has adopted active surveillance as the standard of care for grade group 1 prostate cancer. There's an active surveillance aircraft. I believe PCRI paid for this out of their research foundation. Mark, you can comment on that later. But no, this has really been an amazing consensus that's developed. There was a bit of a political foo-for-all earlier this year when NCCN changed active surveillance as the indicated treatment of choice to one of 3, surgery, radiation, or active surveillance for grade group 1. And there was a massive pushback, and they actually flipped back, and now it's once again considered the standard of care. I think the reason for the flip-flop initially was there was concern. There are patients who should be treated, and I'll come back to that. So always for these groups, the question is, how binding is the recommendation? I think that's what drove that transient change in the recommendation. So I thought, this is kind of an overview. I'd just give a little bit of the history, one slide. So this goes back to a meeting that I had with 2 pals of mine who are radiation oncologists at my center, Sunnybrook, Richard Chu and Cyril Danjou. And I think it was no accident. Some of you may have read Walter Isaacson's book, The Innovators, which is about the development of the computer. And it really is multidisciplinary collaboration where you get people from different fields coming together that sparks fly. So here was a urologist and 2 radiation oncologists, and we assigned ourselves a task by the end of the lunch to come up with some strategy to reduce overtreatment of low-risk prostate cancer. So we came up with this idea: why not just follow the patients, track the PSA, repeat the biopsy, treat the ones where the PSA rises rapidly or their grade progresses. We never thought it would come to anything, and I got a grant of $35,000 from a brand new research foundation, the Prostate Cancer Research Foundation of Canada, and boom, we were off. And then 5 years later, we had our first publication. This was not such an original idea. I had trained with Whitmore, who was kind of a giant in the previous generation before me at Sloan Kettering, who coined the aphorism, "Is cure possible when it's necessary and necessary when it's possible?" Meaning you can cure the patients who don't need treatment because they have very slow growing cancer. And in the guys who have aggressive cancer, you tend to fail. And that basically emphasizes the primacy of tumor biology. And that is a very kind of fundamental aspect of the field of oncology in general, but it was considered quite revolutionary at the time. There were a number of guys, including Jerry Chodak, I would say above all, who promoted this idea of conservative management, but it was still a kind of either or. In other words, you do nothing or you treat radically. And we thought, maybe there's a middle ground. You don't have to deprive the patient of curative therapy if they look like they have more aggressive cancer over time. So that was the strategy. And now we have about 1,500 patients in the cohort. We've got long follow-up in a lot of them. Of course, many have died of old age, and a few have died of prostate cancer. And just the initial reaction, Pat Walsh, who was really the god of urology in those days, who described the nerve-sparing radical prostatectomy, said with conviction that the Gleason 6 patients were the ideal ones for this operation because they were the least likely to have disease that had spread beyond the prostate. Therefore, you were most likely to cure them. We have data from that era that almost 100% of these low-risk patients were treated with either radical surgery or radiation. And there were these very negative and personal comments like, Dr. Klotz will be responsible for these unnecessary deaths. So fortunately, I have a fairly thick skin. I also heard from colleagues, you'll never convince American physicians to stop operating or radiating. And all that, of course, proved to be untrue. So now it's a different world. What made it a different world? One thing was the U.S. Preventive Service Task Force recommendation against screening due to overdiagnosis and, above all, overtreatment. And that was, I would say, a real cold shower for those people who argued that all patients should be treated radically. And so they, of course, reversed this and went to a neutral recommendation a few years later based largely on the adoption of active surveillance. So the principle is no longer in dispute. And now at meetings where you have folks like me involved in debate and controversy and argument is how to do it optimally. Who's the candidate? Where do you draw the line? What should be the triggers for intervention and so on. So that's kind of the background. And we've learned a lot recently, like particularly in the last less than 10 years. First of all, molecular genetics. The Gleason 3 and Gleason 4, which are the two most common patterns, are like night and day when it comes to molecular genetics. 90% of pattern 3 has the molecular aberrations are essentially non-existent. They look like normal cells genetically. It's not 100%, it's 90%. But insofar as cancer is a genetic disease, the more the aberrations, the more aggressive the cells tend to be. This is very reassuring. The implication of this is that these cancers are non-metastasizing, and that is also supported by extensive worldwide clinical evidence. There's almost no cases out of really hundreds of thousands where a pure Gleason 3 or grade group 1 that's been treated with surgery, so you've had the chance to go through the whole gland pathologically, there's no hidden higher grade cancers, that these go on to recur and metastasize. They can invade locally. They don't metastasize, they can invade locally, and therefore they fill the strict criteria of cancer. Maybe I'll come back to this slide. I just kind of summarize what patients tend to ask in the clinic, but I can come back to that if necessary, because I'm going to cover a lot of those questions in my talk. So this is one study from a couple of years ago that looked at this issue of genetic alterations comparing grade group 1 or Gleason 6 to higher grade cancer. And they assessed what is called the average genomic risk, which is a metascore of genetic aberrancy. So this is called a heat map, and this is the degree of genetic mutations and aberrations in the cancers. And each one of these across the top is a cancer. So this represents many hundreds of cases. The second line is the Gleason score. The light blue is grade group 1. The dark blue is higher grade cancer. So you can see as you move from left to right, this is favorable. On the left, this is unfavorable genomics on the right. It goes from light blue to dark blue, but it's not quantized. In other words, you got a few light blue lines out here in the worst genomic category. You've got a few blue lines, which is interesting, with very favorable genomics. That's another story. And the data was that for grade group 1, 2% were in the highest AGR quartile. So what's going on with those 2%? There's another basic observation in biology that the outliers often hold the clue to what's really going on. 2% are the patients probably where their Gleason grade group 1 is about to switch to grade group 2. You get genomic alterations as a rule before you get changes in the histology or in the pathologic appearance of the cells. So as soon as you have any elements of grade group of Gleason 4, so that's grade group 2, which is 3 plus 4, 7 times the likelihood of having really adverse genomics. And another major development, and this is quite ironic in my view, because this project, which is called a SPORE, which is a very well-funded team grant that usually involves 6 or 8 different teams around the country working in the same general area, led by Bill Catalona, who at University of Chicago, who was the most fierce and consistent advocate for treatment for everyone, and the opponent of active surveillance for many years. Basically, he saw the light eventually and now leads this study looking at which genetic germline factors, meaning present in every cell in your body, predict for progression to higher grade cancer. So they pulled together almost 6,000 patients, 28 centers. We were one of them. I was happy to cooperate and collaborate with him. And they've identified, by doing whole genome sequencing in these 6,000 patients, it's a huge undertaking, 18 variants associated with progression to higher grade cancer, 15 never previously associated with prostate cancer at all. And they developed this 269 variant genetic risk score. So in other words, the patient sends in blood or saliva. It's a bit like 23andMe or color.com, if some of you are familiar with that. And so they characterize the germline variants and are able to stratify patients according to the risk, if they're on surveillance with grade group 1, of being diagnosed with higher grade cancer. And it really stratifies them quite widely. And I just emphasize, this is the first study to come out of this major initiative, just published within the last 6 or 8 months. And we're going to hear a lot more about this. So this is kind of the germline approach to risk. Just some of the more recent data on outcome. This is from the Hopkins group, 1,800 patients, median follow-up 5 years, but many of them followed for 10 to 15 years or more. The prostate cancer mortality, 1 in 1,000 at 10 and 15 years. Now, who are those guys? They are the guys who had a very aggressive cancer at the time of diagnosis, which was missed on biopsy. It happens. And probably those cancers had already metastasized at the time of diagnosis, and the patients really wouldn't have likely done any better even if they'd been identified and treated radically right at the start. But again, 1 in 1,000 is such a favorable proportion. It's very reassuring. And now the proportion of patients who are treated is somewhere around 1/3 at 15 years. We think this is going to go down going forward as we get better at stratifying patients from the start with imaging. A lot of this data reflects pre-imaging results. This is another recent group from Sloan Kettering, 2,900 patients, 2,664 were grade group 1. And I just want to emphasize these 2 lines here. The blue line is the rate of upgrading. The orange line is the likelihood that patients were treated. It's the same. So the laudable thing that the Memorial Sloan Kettering group has done, and we have done the same, the only reason to treat patients is for upgrading to higher grade cancer. In other words, presence of pattern 4 or 5, not for PSA kinetics, not for a biopsy that shows more grade group 1. And that is the strategy that makes sense at this point. And there, the metastasis rate, 1.5%, still very low, although higher than the Hopkins group. And this is largely because they were more inclusive in terms of including somewhat higher risk patients. The question that often comes up, what about men who are very young, say patients who are age 50 or 45 who have a 40-year life expectancy? Is it safe? What about those with a strong family history? So the message is it's still safe. In fact, active surveillance actually makes more sense in younger men for two reasons. One is the loss of erectile function with treatment is more of an issue, obviously, for a 50-year-old than a 70-year-old, rightly or wrongly. And second, high-grade cancer tends to develop with age. So younger men are much less likely to be harboring higher grade cancer. So in a sense, it's a safer strategy in the younger men, which is kind of the opposite of what you might think. So this was a collaboration between us and the group at Harvard, more than 400 men under age 60 on surveillance, and basically no difference in intervention rate, progression rate. The fact that they're younger doesn't mean they have more aggressive disease. It's actually the opposite. They're less likely to harbor higher grade cancer, and almost no deaths in this whole group. And then race. So race does have an impact, and mainly for reasons that are not completely understood, but that are probably largely genetic. There are differences, for example, in the structure of the androgen receptor, which is a key molecule involved in the development and progression of prostate cancer between races. Black men seem to be more likely to harbor higher grade cancer. So if you find grade group 1 in African American, you have to remember that their likelihood of harboring a higher grade cancer is higher, about 10 or 15% higher. However, if you look at the likelihood of a bad outcome, the likelihood of developing metastasis or of dying of prostate cancer, it's still virtually zero. So these men absolutely should be offered active surveillance. It should still be the standard of care. It's just they have, at this point in time, as far as we can tell, a modestly increased rate of being found to have higher grade cancer and requiring treatment. The next special group is the group with DNA repair defect mutations in their germline. So I'm hoping that people are somewhat familiar with this now. The most important of these genes, there's about 10 of them, but the one that's best known is called BRCA2. And this is relevant in both prostate and breast cancer. And the DNA repair pathway, as the name suggests, is responsible for repairing mistakes that are made in replication of the DNA every time a cell divides. And we have about 1 billion base pairs, and the likelihood of a mistake in any one base pair is around 1 in 1 million. So it's quite common to have these errors in replication, but fortunately our bodies have a mechanism, a molecular pathway, there's actually several of them, that identify and correct these mistakes. So what happens in the sporadic situation where there's no mutation, you gradually, over a long period of time, get loss of some key, what are called tumor suppressor genes. You get acquisition of some oncogenes that are cancer promoting, but it takes 10 to 15 years, and that's the kind of typical time course for progression of prostate cancer. Whereas if the patient has one of these mutations in the DNA repair pathway, like BRCA2, as soon as you get the initial inception of the cancer, boom, all hell breaks loose. You get this explosive accumulation of mutational events over a very short period because the repair mechanism is faulty. And you can appreciate that if you diagnose grade group 1 cancer and you think you're going to follow the patient for the next 15 years safely, that is not likely to be the case if they've got these BRCA mutations. And there's only a little bit of clinical evidence for this now. We know a lot about the pathways. This is one study from Hopkins, 26 men with BRCA or ATM mutations, kind of the same pathway. You can see here the likelihood, HR is the increased risk hazard ratio for developing higher grade cancer with the patients with the BRCA2 mutation compared to normal is almost 3 times greater. So it's here, it's 80% at 10 years. It's plausible to me that they missed 20%. It's actually more like 100%. So these guys should, in my opinion, and most people's right now, should not get active surveillance. They should be treated even if they have only grade group 1 prostate cancer, and mostly treated with surgery. They're only about 5% of the population, so it doesn't apply to most men. But when you do find these germline mutations, it has implications for the whole family because these are inherited mutations. So finding a BRCA mutation or one of the other ones in a patient means that the children should be tested and other relatives potentially. It's quite meaningful and important information. It's become quite inexpensive to screen for this now. You can do it through one of the commercial companies like color.com or Invitae for only a few $100s. We now are pretty much screening all our active surveillance patients for these DNA repair mutations. The next question is, how important is it to have close follow-up? So some of our patients agree to the serial biopsies. We don't do it very often, but we do a second biopsy 1 year after the initial diagnostic biopsy, and then now about every 4 to 5 years. Used to be a little more often. We went back and said, did it make a difference? And, you know, there's very few examples in the whole field of oncology where how you follow the patient really has been shown to make a difference in terms of survival and mortality. And somewhat to our surprise, it did. So the red is the patients who complied with the protocol. They had their biopsies. The black is the patients who said, no way, I'm not having another biopsy. I don't care what you say, or they disappeared. And they had a very significant increase in their rate of progression. This is metastasis-free survival, in the rate of prostate cancer mortality and even overall mortality. So patients do need to be followed. The biopsy is still important, although much less often than we used to do it. And I think this just emphasized that point. The next topic is imaging. So traditionally, we did biopsies systematically, guided by conventional ultrasound. 12 cores was the standard, 1 million biopsies a year in the US. But the ultrasound, conventional ultrasound, is good for imaging the outlines of the prostate. And you can imagine it could help you guide the needle into different parts of the prostate. But it was not useful. Unless you had a huge cancer, you really couldn't see it by ultrasound. So, of course, MRI has had a huge impact. This is, I like this case because it's so illustrative. This is a guy whose systematic biopsy showed 1 positive core, 10% grade group 1 or Gleason 6. In the old days, we might have repeated his biopsy, probably wouldn't have found much. Now he gets the MRI. There is the lesion right at the top. There's no way you would ever hit that with a systematic biopsy unless you really had the luck of the gods. But now he has MRI, targeted biopsy, showed Gleason 4+3. He has a radical prostatectomy, great big aggressive cancer in the anterior prostate, which is actually quite common place for these to hide. And there's his totally insignificant grade group 1 cancer that was the one found on the biopsy. So you can appreciate kind of writ large that MRI has had and continues to have a major impact, but it's not perfect. I'm just going to emphasize the limitations, which is not to say it's not tremendously useful, just it has limitations. So it's not real time. The patient has the MRI, then it's reviewed by the radiologist. If he needs a biopsy, there has to be a fusion process where the MRI image is kind of superimposed on the ultrasound image. It requires a specialized radiologist with a lot of expertise that takes time to develop. Treatments and biopsies can cause artifacts. It misses lesions. It's expensive. In many parts of the world, you can't get an MRI for the average patient. There's just no access to it. Some patients are claustrophobic. Some have pacemakers or hip implants. They can't have an MRI. Insurance can be a barrier. It underestimates volume. So this is from a center of excellence showing that the average volume on MRI of the cancers is underestimated by about a third. In this study, the average estimate was 1.6 cubic centimeters by MRI, 2.4 when you actually took out the prostate. So you have to take that into account, that it tends to show, it doesn't show the margins of the lesion very well, and it misses lesions. So another report from a center of excellence in 588 men who had an MRI followed by surgery and had whole mounts. So you could actually see exactly where the cancers were, how did they correspond to the MRI. And the shocking thing, at least to me, was that in men who had more than one cancer, so this is the multifocal prostate cancer scenario, which is the norm. Most patients' prostates, if they have significant cancer, have more than one site. If the cancers were less than a centimeter, 80% were missed. If they were 1 to 2 centimeters, 50% were missed. So MRI misses a lot of cancers, particularly the smaller ones. And this is from Sloan Kettering showing the performance of MRI in men who had a biopsy and an MRI at baseline, and then 3 years later had another MRI and another biopsy. And again, the disappointing thing, in the men whose MRI was completely stable, a third of them, despite the stable MRI, were upgraded to grade group 2 or higher. So you can't just sit quietly with your negative MRI or stable MRI and assume that nothing is happening. So that's where I think there's been some progress in this area. I'm very enthusiastic about this novel technology called high-resolution micro-ultrasound. So the difference between this and conventional ultrasound is the megahertz, the frequency is 29 million hertz per second, versus conventional ultrasound is 6 to 9. So what that does is it improves the resolution to 70 microns, which is 0.07 of a millimeter, compared to 200 microns or 0.2 of a millimeter with conventional ultrasound. And why that's so important is because the ductal anatomy of the prostate, the prostate is a gland, it's secretory, it's full of ducts. And the key change with cancer is loss of the ductal anatomy. That's why you see it on MRI. And that's why you can see the cancer with this high resolution ultrasound. You don't see these changes with conventional ultrasound. It kind of looks, feels like a normal ultrasound machine. The cost is in the same ballpark. And just some examples, this is conventional and this is high resolution in the same patient. And there's really, you see details here that you simply don't see conventionally. And you use transperineal biopsy, different techniques, stepper arm or template. And this is just an example. So here's the prostate on ultrasound, and there is the lesion. Now, you would not expect to see this with conventional ultrasound. So if you were doing this the way it's been done for the last few years, the patient would have an MRI. The lesion would probably show up on MRI. And then the radiologist, let me just stop this, too distracting. The radiologist outlines and superimposes this image on the conventional ultrasound. That's called fusion targeting. And you hope it's done accurately. Whereas here, you see the lesion. So about 80% of the time when it's visible on MRI, it's visible on ultrasound. And there's no question you have accurately targeted that lesion. And this is a publication of mine, which was the initial experience from the first centers who started using this. And despite the fact that a lot of these centers were still on the learning curve, the sensitivity of the ultrasound, this is sensitivity on the top and specificity on the bottom. So the sensitivity, meaning the accuracy with which it finds cancer if it's present, was actually better with ultrasound than MRI. The specificity, meaning if it shows something suspicious, how likely is that to really be a cancer, was about the same. And now there's some actual more mature data from, this is a center in Milan that was rigorously blinded to the MRI findings, and basically the ultrasound performed just as well as the MRI. So this is for each level of abnormality. These are 5 out of 5. So very suspicious lesions on Primus is ultrasound, PIRADS is MRI. Basically for each score, the likelihood of finding significant cancer, which is the brown, is exactly the same. Of course, it's a lot cheaper than MRI. It's a lot more available, and it's really very complementary. Not going to replace MRI, but it's a very useful tool. I just talk briefly about how the biopsy is done. So for approximately 40 years now, 35 years anyway, biopsies have been done with transrectal approach. And only recently has the technology become widely available to do it with transperineal approach. And the basic problem with transrectal, it's nice in a way because the needle goes directly from the rectum into the prostate, but you're taking basically a sterile needle, you're putting it through poop and then putting it into the sterile prostate, and that causes infection and bleeding not infrequently. And there's even a rate of mortality, which is somewhere less than 1 in 1,000, but more than 1 in 10,000. And it's simply too high. These are typically healthy patients. So it's a little easier to target, but overall, once one acquires the skill set, transperineal is equivalent. And here's some trial data showing that whether it's randomized trials or observational studies, the accuracy of, this is again one of these forest plots, the accuracy of transperineal and transrectal is the same. So we should switch. And this is, to me, a very compelling story from Norway. So this is the wife and mother of this Norwegian guy, Roar Gilbranson, who had a transrectal biopsy and got acute infection or sepsis and died. A healthy guy. And his wife and daughter found out about the alternative and were so outraged that they mounted a public relations campaign. This is from the front page of a Norwegian newspaper. And they got the public on side, and essentially almost overnight, transrectal biopsies disappeared from Norway, and now 100% of the biopsies there are done transperineally. And we need to, I would like to see this transition take place in United States and Canada, but without the public outrage. So we need to, in my view, we need to adopt this as a profession. What about intermediate risk disease, expanding the boundaries for surveillance? Well, I mentioned at the start that Gleason 4 pattern, you can't be so confident that the molecular genetics are favorable. They can be. And in fact, many grade group 2 cancers, which is a combination of 3 plus 4, but primarily pattern 3, are indolent. However, our experience, we were very inclusive with surveillance from the start. We had about 250 grade group 2 cancers, and 30% of them went on to metastasis at 15 years. So this is way too high. It was pre-MRI, pre-biomarker. The key thing here is the percentage pattern 4. If it's a very small amount of pattern 4, these patients basically should be treated as if they were grade group 1. If it's more than 5%, this is where the molecular biomarkers come in. Try and get a sense, does this cancer have favorable genomics or not? And also focal therapy is an option here. So this leads me to the next aspect of this, which is the molecular biomarkers. This is a huge field. You can look at protein, DNA, RNA. You can look at blood, at urine, at, of course, semen is an obvious candidate for prostate cancer biomarkers that we're just beginning to examine semen as a source for molecular biomarkers. But first of all, just to show you don't actually need the really sophisticated and often expensive genetic biomarkers to get a handle on a patient's likelihood of having higher grade cancer. So this is a new nomogram from the Canary Pass Group, which is a consortium based on the West Coast, biopsy risk calculator. So it takes readily available factors, age, BMI, PSA, prostate volume, time since diagnosis, maximum core ratio, what proportion of the core was involved by cancer, and gives actually a very tight reading for the likelihood of the patient being upgraded on their next biopsy. So this should be more widely used, in my opinion, freely available. Patients can look it up themselves, put in their own data if they have it. And then you have this huge initiative to develop molecular genetic biomarkers. These are the ones that are commercially available. They're in blood, they're in urine, and they're in tissue. So far, none in semen that are commercially available. They're not cheap. The tissue-based ones are in the $4,000 to $5,000 range. The liquid ones in blood and urine tend to be around $500 to $700. They're all trying to do the same thing, which is find the patient diagnosed with grade group 1 cancer who's actually got more aggressive disease, particularly grade group 2 or higher. You can see this is called area under the curve, or the accuracy, somewhere around 0.75 to 0.9. They haven't been compared head to head at all. So the differences here cannot be relied upon. They all work to some degree, and there's more coming down the pipe, particularly these liquid assays, circulating tumor cell-based assays, free DNA assays, and so on. The tissue-based assays are the ones that have a role in the patient with intermediate risk cancers considering surveillance. They haven't really caught on for the average grade group 1 patient. And the main reason for this is the limitation of something called tumor heterogeneity. So there's now many studies that document this. This is one of them. So this is a group of about 40 patients, each one of which had at least 2 to 3 individual cancers in their prostate. The average was 4. So the group dissected out each one of these cancers separately. And then they did what's called whole exome sequencing. So they analyzed the genetic sequences in those cancers. And they looked how often were the abnormalities shared and how often were they unique. And what is striking, the gray is the unique ones, the brown is the shared ones. 95% of the mutations, these are different genes that are involved in prostate cancer, 95% of the mutations were unique. So you do your biopsy, it shows grade group 1. The patient may have another cancer present in his prostate. It is, in most cases, not going to share the mutations that you find in the cancer you're examining. And so that's a kind of conceptual limitation, and why I think the liquid biomarkers have more of a future, because they don't have that problem of sampling. The one that I'm involved in is called the Sentinel assay, which examines urinary exosome microRNAs. These are, this is RNA that's shed into the urine in exosomes, which are these tiny vesicles that are shed by cells. And just to, this is what the exosomes look like. A given cancer cell may shed thousands of these per day. They're extremely small. And they contain important biological material. And because the assay looks at more than 400 sequences, each one of whom is predictive. This has given a tremendous predictive accuracy. So here you see the accuracy compared to the other assays I showed, where this was like 0.75 to 0.9. Here it's 0.96 for the likelihood of finding grade group 2 or higher cancer, 0.97 for any cancer. Hard to do a whole lot better than that. Now, this is preliminary data, still needs to be validated, but this just gives you an idea of what is coming down the pipe. And what this lends itself to is what's called dynamic risk profiling, which means instead of doing a biopsy every few years, or even instead of having to image the patient every few years, you just do the urine test. If the test is negative, you follow the patient. If the test provides a signal that there's something going on in terms of significant cancer, then you may have to go back, re-image and re-biopsy. But if that pans out, that will make surveillance so much more appealing. Imagine a test with 97% accuracy that only requires a urine specimen. It would really enhance the appeal of this approach. The final topic I'm going to address is innocuous interventions. Can we prevent failure or progression or do something good for the patient? And why do this? Multiple reasons. The typical type A male doesn't like the passivity of surveillance. They want to feel like they're doing something to help. A lot of these proposed interventions do other things for the patient's health. And I think as a physician, if you can induce the patient to take on these other interventions, you do more for their health than you will by managing their prostate cancer. And maybe you can actually reduce the risk of progression. So there's two groups of these. These ones are the motherhood ones. Number one, stop smoking. Everybody knows this, but a patient who's newly diagnosed with prostate cancer, if the doctor spends 2 minutes telling them to stop, that's been shown to have a favorable effect on smoking behavior. That is the most cost-effective intervention in all of medicine. My colleagues need to do more of this, and I think that's really important. Regular exercise, I'll come back to that. And dietary modification, again, don't avoid obesity, not too much red meat, fruits and vegetables. Coming back to exercise, so this just summarizes the 8 different molecular pathways that have been demonstrated to be favorably influenced by exercise in prostate cancer, related to the levels of things like growth factors, something called epigenetic modulation, hormonal levels, the tumor microenvironment, and so on. But now we actually have some clinical evidence for this. A lot of that comes from preclinical studies, animal studies, and so on. Just within the last year, this randomized study in men on surveillance of the effect of intensive exercise compared to a pamphlet. So this was a small study, 52 men. The half of them got high intensity interval training, HIIT, which meant they had a trainer, they had phone calls, they were constantly harassed to exercise at a high level. The other group got just basically, yeah, you should exercise, which didn't have much impact. And not surprisingly, the group that exercised regularly had improved cardiovascular fitness, but their PSAs went down and their PSA velocity went down. Their PSA doubling time was more favorable. Their testosterone improved. So here's a small study, but with a prostate cancer endpoint of PSA and PSA kinetics that's sort of favorable, a favorable benefit. So this is a kind of pilot study, but it's really got people excited because it actually showed evidence of a benefit. I referred earlier to the tumor microenvironment. This is an amazing study for those of you who have a serious interest in this area. This is New England Journal publication from last year, Rathmel. And this, everyone knows, or the people in the field certainly know, that obesity is not good for prostate cancer. Obese men have a higher rate of prostate cancer metastasis, of more advanced disease, of prostate cancer mortality. Now, for the first time, we know why that is. And it's quite a fascinating story. So it turns out in obese men, there is a metabolic tug of war between the tumor cells and the immune cells, which are called the T cells, for these crucial lipid substrates that are required for normal cellular metabolism. The tumor cells basically grab all the free fatty acids, and the tumor infiltrating cells, the immunocytes that regulate tumor growth, are deprived, and their immune function is impaired. And this results in impaired tumor surveillance and anti-tumor immunity. This is why obesity is associated with an increased rate of prostate cancer, because it impairs cellular immunity. And I think this has been a really important step in our understanding of how this works. The next issue is diet. Should patients who are diagnosed change their diet? Should they become vegetarians or vegans or whatever? And so this has now been tested in a prospective randomized trial called the MEAL trial. Almost 500 patients randomized between vegetarian-based diet with counseling and phone calls, etc., and a pamphlet. And the primary outcome was a prostate cancer outcome, PSA kinetics and biopsy. Now, everyone knows, I think, that the diet over your lifetime influences your health. And the question is, once you're diagnosed with prostate cancer, does it make a difference? Sadly, it made no difference whatsoever. There was absolutely no impact of the dietary switch to vegetarian diet, either in PSA levels, PSA rate of rise, or upgrading on follow-up biopsy. So again, this doesn't mean that diet doesn't matter. I think what it does mean is that in the 2 to 3 year time frame, it probably doesn't make much difference once you're diagnosed. Maybe it's just too late. So a healthy diet is good, probably not going to make that much difference. I just tell patients, eat a heart healthy diet, avoid obesity. And then finally, last part of my talk is for those guys who really want to be proactive, who want to do something. They say, I hear this all the time. What can I do? There's got to be something I can do to stop this thing from getting worse. So there's 3 interventions. I emphasize that none of these are supported by controlled trials yet, although some trials are going on as we speak. So the first one is vitamin D. In northern parts of the world or polar parts of the world, vitamin D deficiency is ubiquitous in older people. They don't get enough sunlight. And there is a ton of data from mainly epidemiologic studies that low levels of vitamin D are associated with higher rate of prostate cancer mortality. So this is prostate cancer mortality by vitamin D level, a bunch of individual trials. There's the effect size, about a 10% increase in mortality. Nice thing about vitamin D is it's really cheap, it's harmless, and patients in general who don't get enough sunlight, I believe, should be on a vitamin D supplement, around a total of around 1,500 units per day. The next one is statin use. I know this is, of course, a long-standing interest of Mark's and of mine. There's a lot of epidemiologic data. It's the same story, that men who are on a statin have lower rates of prostate cancer metastasis, all-cause mortality, probably in part for the cardiovascular benefit, but even prostate cancer mortality. And why is this? These statins interfere with a pathway called the mevalonate pathway that leads to a number of molecules that stimulate prostate cancer proliferation and invasion. So aside from the cardiovascular benefits of statins, there's the prostate cancer benefit. I'm very pro-statin. I think all men, middle-aged men or most, should be on a statin, at least low dose, and certainly if they're diagnosed with prostate cancer. Mark and I have been planning a study for many years of statins in men on active surveillance, and I hope we're going to get around to it shortly. And then finally, there's the metformin story. Metformin has a favorable effect on, this is a diabetes drug, but it has both a favorable effect on prostate cancer growth and progression, both through a direct mechanism by basically stressing the cells metabolically. It kind of fools the cells into thinking the cells are starving, which has some benefits in terms of reducing the likelihood that the cells will proliferate, and an indirect effect by reducing some of the signaling pathways like mTOR and insulin signaling pathways that tend to stimulate cell growth. And there's a lot of data on this. We're doing a randomized study of this in Canada in men on surveillance, but this was a systematic review of the topic in more than 1.6 million patients. So just massive collective population, and that showed the likelihood of, this is a recurrence-free survival, of cancer-specific survival. They metformin patients who were mostly diabetics, but they had reduced rate of prostate cancer mortality. So, it's a safe drug to take even if you're not a diabetic. And I don't really encourage it until we have actually direct data from randomized trials, which we'll have in a few years. But I do think it's likely of benefit. And then this just to show the adoption of active surveillance over time. The blue is the increased utilization of surveillance all through the United States, Southwest, Northeast, Midwest. Still some ways to go. In Canada, it's about 90%. In the US overall, around 60%, but it's trending in the right direction. So I think I'll leave it at that. Thank you for your attention. And I know we have some time for questions and discussion.
Dr. Klotz, that was brilliant as usual. Now, of course, I'm president of the fan club, which I know you're president of my fan club. How did you feel? I mean, that was over an hour of presenting, which I believe in the history of PCRI is the longest presentation that you have given. How do you feel about that?
That's not necessarily a compliment, Mark. But no, I mean, there's a lot to cover. And, I try to be fairly comprehensive about what's happening in the field.
Yeah.
So, yeah, I mean, I think, it's all good.
Okay. So, shifting there, tell us a little bit more about yourself in terms of personally, are you still playing? You were playing hockey up to a couple of years ago. Are you still playing hockey?
So, yeah. So, the thing is, it's a demanding game, but it's kind of a low impact sport, skating. And so I've been playing ice hockey my entire life, and I still play Sunday mornings with kind of old timers, quite popular. And yeah, I hope to keep playing. And kind of dropping dead on the ice in your 80s is not such a bad way to go.
Hey, I think that's incredible that you're still playing, but at the same time, so let me just throw out some stereotypes for Canada. You don't do curling, do you? I don't understand.
I have, but that's I'm kind of more active guy, still. So I'm in there. I'm out to get some aerobic exercise, and curling's fun, but not my sport.
Okay. And then last but not least, whenever we have and I want to tell this to the audience because they don't understand this, that I can guarantee you the one speaker that was disappointed the most that we didn't have an in-person meeting in the fall for this conference was Dr. Klotz. He really wanted in person, and I'm making him this promise that you will be in person again very soon. We're going to be in person spring, and so next fall or around this time, we're going to get you back in person because people need to see in person. So I know you're going to say yes because now you're on camera, so you have to agree.
100%, I'll be there.
But I appreciated the fact that was a bothersome because there's nothing like the in-person event, and I can't say more than that unless you've been there, right? There's an energy there.
For sure. I mean, there's obviously a huge advantage to doing it this way. You don't have to bring people across continents to get to hear what they have to say, but it is not the same. And there's the kind of interpersonal aspect of it. And, I referred in my talk to this the interdisciplinary interaction is what leads to sparks of innovation. And it's the going out for a beer with your colleagues at these meetings that often is where things really happen. So you don't get that by Zoom.
No, that's a really good point.
But just I have a selfish reason, which is my son now lives in Long Beach, California. So every time I get a chance to come out there, I get a chance to visit him.
Yeah, and not only do you do that, I'm going to see if you're going to commit this time. You always play Dr. Scholl's in tennis, and every time I ask you guys who is dominating the other, because that's the only thing I care about is the controversy. Are you better than him in tennis when you ever come out and play against him? Please don't say it's equal. That's too PC for me.
That is a no-brainer. He is a phenomenal tennis player, and he's a better player than me, and I'm happy to admit it.
Really?
Yeah.
Interesting. Do you think it involves any type of steroid use on his part?
That's certainly one possible explanation. I can see that. Androgenic steroids probably would explain a lot.
Okay, that makes my day. Now, I'm going to ask you quickly about the Canadian versus the U.S. medical system. All right. Do you have some thoughts about this? I'm going to tell you why. I'm going to tell you why this is why it's called the first annual out of the box, because the reason I'm doing this for you as a favor, because everyone's pinned you as the active surveillance guy, right? And what people don't know, because I've known you long enough, that you have expertise in a lot of area outside of active surveillance, not just active surveillance or going to pizza joints. And so that's why after this question, I'm just going to ask a couple other general questions, and then we're going to move into active surveillance, because I want to hear, I may not agree on some of it, but it doesn't matter. It doesn't matter what I think. I want to hear your opinion on some of these things. What's your take on the Canadian versus U.S. medical system? Because in Michigan, we're close by. So here's my new theory I've never shared with you, and I'm not kidding about this. I'm actually very serious.
All right.
I think you can talk pros and cons of both systems all day long until you're blue in the face. I think that the milieu, the environment for someone to dramatically change the face of prostate cancer by non-treatment is potentially encouraged in a Canadian type system. Am I wrong or right? Because I did public health, and I can tell you one thing about the Canadian system. It's all about prevention, whether you agree it or not, right? There's money put into prevention and an emphasis there that's different, but I'll let you talk there. What do you think?
So no, I thought, first of all, it's not just prostate cancer. Like Canada was a leader in surveillance for stage 1 testicular cancer, for kidney cancer, small renal masses, all came out of Canada. So it's no accident. And why is, I think there's a few reasons. One is we're a little bit underserviced compared to the US. So every Canadian urologist is busy. So there's not this sense that, you have to kind of scrounge for cases. Underutilized surgeons are dangerous, right? You don't want a surgeon who is kind of scrounging for work. That is not good for the public health of the population, because you tend to get, over treatment. The second thing is, and believe me, I am a harsh critic of our system in many ways. I'm not Pollyannish about it at all. But the one thing that I think our system got right was we're roughly appropriately incentivized financially. We're fee for service, right? So in that sense, we're like that's kind of similar to the US system. We do an operation, we get paid for it. Very, very few surgeons are salaried employees. Some are nowadays, but most are. So, but for us, whether we operate, whether we see the patient in the clinic, we get paid about the same in terms of, hourly rate. So what that means is guys are busy. If you lose a case because you're not going to operate on the patient, doesn't really make a difference. There's no financial impact of that. And so I think, therefore it was quite easy in Canada to say, listen, guys, you should stop operating on these patients. It's not like there was any kind of financial price to pay. So that was one difference. And then also then it gets a little softer. I mean, maybe there's a little more of a sense of like the public health perspective by clinicians than in other places.
Yeah.
And I think probably one more reason, we're a smaller professional community. So we're small. There's about 1,000 urologists in Canada. So, people know each other. So when you get an individual making a compelling case for change, people know me, I know them. It's much more of a kind of personal interaction than I think you get in a larger country. So that, I'm not trying to sound self-aggrandizing, but I'm sure that our being a fairly small community had a lot to do with the rapid uptake of active surveillance in Canada.
So that's interesting, because I've never talked to you about that. And now, of course, I have to play both sides now. So what we hear constantly in the US, and I've heard it in Michigan since I was a little kid, is that, yeah, but they've got these massive queues. People are waiting in line 6 months, 9 months for treatment. So when you need treatment, you're going to be sitting in a line that's as busy as the busiest deli in town. And so do you have any comment on that?
So you raise a big topic. So there's no question we have a centrally planned system. It's not responsive to, market forces. It's responsive much more to political forces. That's definitely a defect. I am personally, I'm a kind of free market person philosophically. I don't like central planning. I think it's been shown not to work. But in the specific area of oncology, so what happens is if there's a significant constituency of people who are unhappy because they're waiting, the politicians hear about it and resources get put into that area. So in the area of surgical oncology specifically, and radiation oncology and medical oncology, there's a lot of resources. People do not wait, by and large, very long for cancer surgery now, because that it's a kind of politically identified area that warrants a lot of resources. The problem is if you don't have a constituency. So, for example, in our field, patients who have incontinence post-prostatectomy, who are candidates for an artificial sphincter, they have no political voice. No one's interested in incontinence, as a politician. So they wait a long time. You wait a long time for an artificial sphincter nowadays.
That's interesting.
So yeah, that is one of the problems of our system. Our system has to change too. Yours has got to change. Ours has got to change. And the problem is we are at the two opposite ends of a spectrum. The action is in the middle. Europe, Singapore. These places have blended systems. They have a high quality, publicly funded system offering basic care. They have a parallel private sector system where patients who want to put more money into access are able to do that. And my impression, based on pretty extensive reading about this, is they work better than ours does in terms of the waiting lists and so on. They work better than the American system in terms of cost containment, in terms of having people have no access to care and so on. So I think both of our countries need to look at other places for the way forward.
Wow, that's really interesting. I've never even had over a beer. I've never even had this conversation with you. So that is really very interesting. So thank you for that.
All right.
Now I'm going to leave, before we go to active surveillance, there's a couple areas that are hot and not so hot in prostate maybe. And I just wanted to get again, I'm not trying to solve the world's problems. I'm just trying to get what your thinking is right now in the area. Let's talk about immune therapy briefly in prostate cancer, because to me, immune therapy in metastatic melanoma in a variety of other areas is sort of, to me, it's wow. It's interesting. In prostate, it's, what's your feeling about immune therapy in prostate, where we are and where the HE double toothpicks are we going?
Right now, basically it kind of looks like a bust. The real progress is in the PARP inhibitors. That's where all of a sudden there's a whole slew of really exciting new data showing response rates that are almost unprecedented in patients who previously been resistant to therapy. That's for the patient where you have a DNA repair defect.
Right.
The PARP inhibitors are directed at that pathway. For whatever reason, and I'm not sure, I don't really know. I have wondered, why in so many tumor sites, the checkpoint inhibitors are so powerful, and they don't seem to be very powerful in prostate cancer. And I don't have an answer as to why, but so far they've basically been a dud. The combination studies of drugs like pembrolizumab in combination with hormone therapy, for example, for castrate-resistant prostate cancer, or pembro plus abiraterone, no difference. So I am not aware of a single study yet that has actually shown any significant improvement in response rate or with the IOs in prostate cancer.
Yeah, but you and I have been around long enough. I'm not saying you're old. I'm not saying I'm old. I'm saying you and I have been around long enough.
Yeah.
That there's always these two camps in immune therapy and prostate cancer. One is you need to treat people with the most advanced forms of the disease when there's a ton of mutations. And I know they're struggling in that area, but then there's the area that impacts you that I don't think a lot of people realize. There's always that argument that, no, we should be using immune therapy earlier.
Yeah.
Maybe for people that are in active surveillance, because there's a trial going on in the US. I don't know the status of it, where basically you're taking patients with localized disease and seeing what the immune therapy effects are. Do you have any comment on any of that stuff?
Yeah, so it's a nice hypothesis. I'd like to see some data. These drugs are not innocuous. They can have very significant side effects. There's no way that a checkpoint inhibitor should be used for grade group 1 prostate cancer. It's basically a pseudo disease that doesn't pose a threat to the patient. You need to, it can progress to higher grade cancer. I don't even like dutasteride or Avodart for grade group 1 prostate cancer, because although it actually, there's recent data, it actually does seem to work.
We're going to get
it works. Yeah. It works, but what's the cost? The cost is loss of libido in a significant proportion of patients. Well, loss of libido is not the end of the world if you're really achieving something. So if a patient has a huge prostate, a lot of voiding symptoms, and they're improved on a 5-alpha reductase inhibitor like Avodart, maybe it's worthwhile, but not for a disease that really doesn't need treatment. So, pembrolizumab, the checkpoint inhibitors are far more toxic than Avodart, and therefore I don't think they have a role. Now, the question is in high-risk localized, which is a different topic. So high-risk localized, these guys are at serious risk for progression and failure. And sure, we need to do studies of neoadjuvant or pre-treatment or post-treatment. The idea is that by activating the immune system, you mop up the small clones of cells that may have micrometastasized and potentially increase the cure rate. But that's hypothesis. So this is where you need clinical trials. Basically, we don't have them yet.
Do you have any comment? Because my next goal with you, be it at the next meeting or just as a private for PCRI, my next goal with you, because I think you and I could share a lot educationally from different backgrounds. People don't realize that you do a lot with hormone therapy. You do a lot with educating on hormone therapy, and hormone therapy has been around, it's over 3 decades as a treatment. But you talk a lot about the side effects of hormone therapy. Do you have any comment on where we are with the side effects of hormone therapy, or just any sort of Klotz comment on they still don't get enough attention? They get plenty of attention. I'm worried about the cardiovascular risk. What's your kind of off the cuff thoughts of androgen deprivation therapy, also ironically known as hormone therapy?
Well, I would say what you raise is a very important issue. And the problem is it's become kind of shifted to the back burner, because the action today is with the drugs that are called ARATs, androgen receptor axis targeted drugs like abiraterone, enzalutamide, apalutamide, etc. And now the PARP inhibitors. So all these drugs are given with ADT, androgen deprivation therapy, but it's become quite multifaceted and complex. So the systemic effects of ADT, which, I mean, most patients tolerate ADT quite well, but these systemic effects actually are quite important over time. They are neglected. There's no doubt about it. And I take the position that if you're going to put these patients on the drugs, you basically, and I know you're a primary care physician initially, you need to be the primary care physician for those patients. So I think as the guy putting the patients on the drugs, you need to be attentive to the bone health. They should be on a bone targeted agent, particularly an oral one, like not necessarily denosumab, but leronate, Fosamax, the same drug that postmenopausal women are on. It's basically a very analogous situation. They should be on a statin. They should probably be on either metformin, or people are just starting to do studies with the semaglutides that may reduce the weight gain, sarcopenia, insulin resistance associated with ADT. You should counsel them about diet, managing their weight, because the weight gain is amenable to dietary control. So I think all that stuff, and then the cardiovascular side, of course.
Yeah.
So all that stuff needs to be addressed. Unfortunately, the average guy, it's not part of the culture. The average clinician I'm talking about.
Yeah.
So I think there needs to be a kind of shift in perspective that, like, a medical oncologist would think nothing about putting a patient who's getting high dose chemotherapy on GM-CSF, which is a drug that stimulates white cell production, prevents the low white cell count that predisposes to infection and sepsis. And we should think it should be almost automatic, alendronate, statin, counseling about lifestyle and so on. And we don't do it too well.
Well, I couldn't agree more. I think it's really strange that big study from the US came out this year that essentially showed that less than 10% of men initiating ADT were getting DEXA scans or osteoporosis scans.
Yeah,
it's like, when did it become the exception, not the rule, to get an osteoporosis scan when you're on a drug that accelerates the risk of osteoporosis?
Right.
Weird. It's weird. Yeah. Okay. Last comment, and then we move into just active surveillance. Are you enjoying your first annual out of the box with Klotz game?
Very much.
I would rather do an interview with you on everything but active surveillance in the future. Because, but I'm serious, because people don't understand the diversity, the depth, the breadth of what you do, because it's so dominating. It's so dominating the active surveillance realm. So it's really good. Like when I was picking my dad's brain, who I thought was the smartest doctor in the world, even though he did surgery and he was a urologist, I would love to just get his thoughts on anything, whether it was colonoscopies, because he was so well versed in medicine, right? But anyway, I digress.
All right.
I always go through your papers. You have over 500 papers now on PubMed, so it takes me a lot longer to go through all your papers. And I just look for anything that catches my eye before I do the interview. One that caught my eye that I had never seen before was your name was on a paper for chemotherapy, and it was about an intermittent versus continuous docetaxel or chemotherapy. And I thought to myself, well, I didn't know you're involved in some study where you do. I mean, I'm just laughing because it's intermittent, because you've done studies with intermittent hormone therapy, and I think you're still a fan in the right patient, right?
Yeah.
But what's this? Yeah. Well, what's this about this intermittent chemotherapy stuff you're involved in?
So, I mean, the idea is the basic concept that's evolved of intermittent therapy is that you should hit health cells as hard as possible. So this has to do with the issue of combined androgen blockade. It used to be bicalutamide. Now I think there's interest in giving an ARAT with ADT. You get better results if you hammer the cells hard, but there's value in stopping the treatment and allowing recovery of the cells that tend to recover off treatment. tend to be the more favorable cells. That's the concept, that if you continue treatment permanently, you get treatment-induced resistance pathways upregulated, and that leads to failure. So by stopping treatment, you get other pathways that dominate over the resistant pathways, because they tend to be more kind of stressful for the cells to handle. So it's not just hormonal therapy. You can use chemotherapy. You can use tyrosine kinase inhibitors. And there's this concept of metronomic therapy, which is kind of hitting the cells very regularly for a period of time and then stopping. So I was involved in some of that research, although definitely it was a sideline.
It doesn't seem so wild to me because, I mean, look where we are with oligometastatic prostate cancer. The idea that sometimes less is more, I think, right? What we're saying. And I don't know if you have a comment on that. And that's kind of interesting. The reason I'm saying this is because what you tend to hear in advocacy all the time is, I got cancer, let's throw the kitchen sink at it. Let's do everything possible. And maybe for some people, like you've shown in active surveillance, that's not such a good idea.
Look, first of all, less is for sure more in medicine. You know, there's the basic idea of the whole field of clinical epidemiology is that errors of commission are worse than errors of omission. If you have a choice between doing something that you're not sure about or not doing something, it's much riskier to do it than not do it, right? And that is what drives evidence-based medicine, that you need evidence for something. That's why, for example, a type 1 error is set at 1 in 20, a type, which is the risk of thinking something works when it doesn't. The risk of a type 2 error, which is that you fail to see evidence, is only 1 in 5 typically. So that's because errors of commission are worse. So I believe very firmly, if in doubt, punt. And this is a case in point. I mean, one of the hardest knee-jerk reactions to counter in the whole active surveillance, as the whole active surveillance story developed, patients hear cancer and boom, it's like, I want that out of me. I don't care if it's indolent. I just don't want any cancer in my body. Operate. That's still a hugely powerful sentiment. So, this idea that somehow doing something is inherently good is very maladaptive in medicine.
Okay, so that was my first annual Out of the Box with Klotz. Let me tell you something. Okay. You have convinced me I'm going to be doing this a lot more with you. Really? All right, I'm going to go through because I'm not smart enough to think, just jump around. I like to think alphabetically, but I'm going to start trying to work on the alphabet and make sure that the audience understands where you stand on a variety of these issues. The first thing I want to say is cardiovascular disease, because you had written this, and I'm going to jump out of sequence for a second. I just want to make this clear for the audience and see if this has changed. You taught me long ago, which did change my career in a big way, that in your series of active surveillance patients, the number one cause of death was something else. It wasn't prostate cancer, and that cause of death was cardiovascular disease. Is that still the case? Because if that's the case, that's the monster that you look out for when you are on an active surveillance protocol, right?
Well, it's unequivocally the case. I mean, it's not only for sure it's the case in the active surveillance population, and the only reason it would change if heart disease was no longer the number one killer of American men. But I don't think that has changed. That it is deeply entrenched.
Yep.
You may know this better than me. So I don't track that sort of population-based data too. Yeah.
Yeah, but in your series, still, I knew this 10, 15 years ago. Still today, it's clearly has the gold medal.
Yes. I mean, it's not just in the surveillance patients, in the patients so for example, in our intermittent hormonal therapy study, where these were patients who've been treated for prostate cancer and had recurrence, it's still twice as many patients died of heart disease as died of prostate cancer.
I know you mentioned this. I've seen it in the papers. Can you just repeat it? That you said there were a couple of reasons why you would argue that even younger age are just as appropriate for active surveillance. Can you go back over that in my brain? Because
Yeah.
you have to admit, in the States, I think, I don't know about the rest of the world, I don't know Canada, people think of active surveillance as something that you do when you're old.
Yeah, well, that is a complete misapprehension. So there's about 3 key facts to this. Number one, keep in mind that low-risk prostate cancer develops in men basically as a percentage according to their age. So men in their 30s, autopsy studies have shown 30% harbor microfoci of low-grade prostate cancer. 40% in the 40s, 50% in the 50s. It's quite consistent all the way through. So finding it in a guy in his 40s doesn't mean that somehow he's got some horrible condition that's been developed 20 years earlier than it would in another patient. It just means you've found some of these latent microfocal cells that are so prevalent in men with age. That's why I call it part of the aging process. So it doesn't mean it's not like, say, there's some cancers that are normally develop in older people that in young people are more aggressive. Not the case with prostate cancer. The second thing is, so it's the opposite. The tendency to develop higher grade cancer is age related. If you take a population of 75-year-olds, they're much more likely to harbor higher grade cancer than 45-year-olds. So the Achilles heel of surveillance is finding low-grade cancer missing something worse just because your needle missed it. Much less common with targeted biopsies, 15% compared to 30%, but still it happens. But that tends to be much more likely in an older population of patients because they're more likely to harbor higher grade cancer. And the third reason is the loss of treatment impacts the treatment impact on quality of life. So, the average 70-year-old, every male likes his erectile function, but the way it's viewed by a typical 70-year-old is much different from the way it's viewed by a 45 or 50-year-old. Whereas, 50-year-old, he wants to hang on to that at all costs. It's very common at age 70, not everybody. You got 70-year-olds who are also extremely focused on their erectile function, but I hear from the majority of men, I don't know how generalizable this is, I had my day and I'm okay with the fact that, now I have my memories and I'm not sexually active anymore. So it's just, kind of value of that, of loss of sexual function is much different in those different age groups. And therefore, you do a radical prostatectomy in a 45-year-old that causes erectile dysfunction. It's worse than when it happens in a 70-year-old.
So if I'm in your active surveillance cohort, my chances, while you're monitoring me, my chances of adverse pathology or a pathologic change on a subsequent biopsy is higher as I become an older man.
Yes, that's true. Except you've got 2 competing tendencies. One is what you just mentioned, the tendency to have higher grade cancer. The other is competing comorbidity. So your life expectancy goes down. So, and prostate cancer in the average patient is a 10 to 15 year process. So for example, I think another key fact the listeners might be interested in, the best natural history study after radical prostatectomy came from Hopkins. It was Pat Walsh's patients. I think 1,000 patients followed for 25 years. In the patients who died, which was only a small percentage of them, so they all had surgery, the time from the surgery to death on average was 16 years. Those are the worst patients. The ones who weren't destined to die, they had recurrence in a lot of cases, but 10, 15, 20 more years goes by. So So there are much more aggressive cancers in that cohort. There are patients who died within 5 years of surgery, but the average was 16 years. So if you're 75-year-old and now you have, or 70-year-old even, now you have some grade group 2 cancer because you've had progression, doesn't mean you're at risk. You know, there's some recent data. The likelihood of metastasis in grade group 2 followed with surveillance untreated is only around 5%. So, you know, it's still higher than 0 to 1%, which is the grade group 1, but it's still a very small minority of patients. So, you know, yes, you have an increased risk of higher grade cancer, but that cancer is less of a threat the older you are.
Interesting. The other factor, we're gonna touch upon this a little bit more, but there's this argument in the literature that family history is just not enough anymore. Because in prostate cancer, you have to have had experience this your whole career.
Yeah.
People think family history. I think a lot of people think family history means somebody in the family had prostate cancer.
Right.
But, you know, in breast, there's a whole other game going on. If someone died young of breast cancer or got breast cancer, aggressive disease early, that was considered family history. If someone got breast cancer at 82 that was non-aggressive, that's not a family history.
Right.
Can you comment on that and why family history makes people bonkers?
So I call this family history inflation. So you get a guy who was diagnosed with grade group 1 prostate cancer 25 years ago, told he had prostate cancer, had surgery. His son now has a family history, more likely to be screened, more likely to be overdiagnosed and overtreated. Now you got 3 generations potentially, you know, every one has had, quote, prostate cancer. So overdiagnosis leads to family history inflation. So I think now we're in the era of genetic screening for germline defects. So I think it's changed the whole thing. So now you say to the patient, well, you have a family history, let's find out. So instead of the patient just worrying about it, you do the test, it's $300. You find out actually there's no DNA repair defect variants in the family. In fact, there's no it's just coincidence. And that's tremendously reassuring. So, you know, I think that whole field, we're moving from family history to germline predisposition, which is far more kind of scientific. And the main effect will be to reassure a lot of people who worry about the fact that, you know, someone in their family had prostate cancer, and does this mean they're at risk and they're going to get it, and so on.
So you might not remember, I should play the tape. In 2019 and 18, and when people came up for active surveillance, and that's the time where people were doing biomarkers and genetics on the advanced patients. It was becoming more in tune with that.
Yeah.
There's a discussion of, are we moving to the point in the next few years where everybody, you're going to start looking for a BRCA1, 2, or an ATM. So are you telling me, what I heard in your presentation is anybody diagnosed with prostate cancer, especially that wants to stay on active surveillance, should get the test to see whether or not they have a mutation in one of these?
So we're almost there, but maybe not quite. So I do it. I think, yes, that it's appropriate. Look, the test is not expensive.
Yeah, exactly.
Certainly, if they have any red flag, any family history, even an inflationary family history, breast cancer, ovarian cancer, young age of death, you know, in a parent from, I would do it. The question is, in the patient got no red flags, we're not 100% comprehensive, but I think we probably will be another 3 or 4 years. I mean, it just makes so much sense.
Okay, I'm at a Toronto bar with you. I'm ordering Labatt's, you're ordering Molson.
Yeah.
We're watching the Red Wings on one TV and the Maple Leafs on another. Maybe they're playing each other. And I say, Lori, between me and you, if you got diagnosed and were on active surveillance and you might not have the family history, would you personally get this test? What are you saying to me?
Yes.
I agree. I would too.
Yeah.
That's where, how can you, okay, so here's the counter argument, because that's my job. It's just like the Canadian versus US system. There's always a counter. The counter is, if you look at some of the papers in the Journal of Urology, and these are good papers, there's one from Israel and other places, they have patients on active surveillance with these mutations, and some of them are arguing that they're not more likely to progress in the first few years. But the problem I have with that is they're saying in the first few years.
Right. So look, first of all, we still have a lot of uncertainty in this area, right?
Right.
Number one, we know about BRCA2. We don't know nearly as much about BRCA1, ATM, PALB2, et cetera. Plus there's 10 others. So the patient turns out, CHEK2, the patient turns out, say, to have a CHEK2 variant. No one knows what to do with that patient right now. So, but the commonest one happens to be BRCA2 in prostate cancer. It's actually more common in prostate than breast. Breast tends to, as I understand it, tends to be more kind of distributed amongst all of them. Whereas BRCA2 is something like 60% of the patients who have a mutation in prostate cancer is BRCA2. So first of all, there's uncertainty in the patients who have other than BRCA2.
Right.
But these you can tell these patients based on what we now know that over the next 10 or 15 years, they have almost 100% chance of progressing to higher grade cancer. And some of those guys, you may miss the boat. Now, there's one other aspect to this that's not that well known, which is there's one paper from a group in the UK, Ely's lab, that the patients with BRCA2 mutations who were radiated had 100% mortality. The patients who were treated with surgery had exactly the same mortality as a comparable group who didn't have BRCA2. In other words, they were effectively cured at the same rate. So it's only one paper. The paper was published about 10 years ago. It hasn't been validated, but no one has come out with contrary data either. So I really think surgery is the answer for these guys, even if it's pushing the limits in terms of age, in terms of minimal disease. Like why mess with it?
Yeah, that's really interesting. The other thing I think I find fascinating about BRCA2 is it hung out in breast and ovarian, right? And now it's in prostate. Now some people are saying they're seeing it in the pancreatic patients, and
right.
And so there's clearly other cancers it's associated with.
Oh yeah, yes.
So that's really good stuff. Now I'm going to go we're doing really well. It's almost 45 minutes and I'm to the letter B.
All right.
I'm going to get us through this. Trust me. So
right.
When I think of B, when it comes to active surveillance, I think of biopsy. And what you said to me, if I understood you correctly, is you definitely now are a fan of transperineal versus transrectal, and we should be moving that direction, right?
Yes.
Is that what you said?
Yes.
Okay.
We should move fast in that direction because it may come back to bite us. I mean, I think the next time you have I hate to raise the specter of medical legal suits and stuff, but I think the next time you have a patient in the United States who dies after a transrectal biopsy, that doctor's going to have a problem because there's another way to do it. It's safer. The patient's not at risk. Why did they expose the patient to that risk? And that, I think, ultimately, it may be like the tort side that drives the change.
So then why weren't transperineal? I'm asking this out of sheer lack of knowledge.
Yeah.
Why weren't they doing transperineals 15 years ago, 10 years ago? Why is this?
Yeah.
Why now?
Well, first of all, never underestimate the power of inertia and established practice in sustaining a certain practice. Second, the transrectal biopsy is easier. The prostate is right there. So it's a technically easier procedure. It's less demanding in terms of time. It's less demanding in terms of anesthesia. I think the patients do have more pain doing it transperineally. It's harder. It's quite easy to get effective anesthesia with the transrectal. It can be a real challenge doing it transperineally. Some people do it in the operating room. We just simply don't have the resources. I do it under local. But another reason for resistance to change was the way it was done initially was in the operating room. So, people want to operate in their operating room. They don't want to use that precious time to do something like a biopsy. Finally, most patients do well, but 90, the sepsis rate is in the 2 to 4% rate. 95+% of patients kind of sail through it. So the problem is you need the kind of rare events, some of which can be catastrophic, to drive change. It's not that trivial.
So everybody can move to our locals, because one of the hits was that if general anesthesia or using anesthesia as you get older, it comes with its own little controversies.
Yeah.
So it doesn't have to be done with general anymore. It
No,
can now.
I have only done it under local.
Okay, then I would say again, if I'm just playing devil's advocate, what about the learning curve? I mean, if someone's been doing transrectals their whole life, nobody wants to be patient zero or the first experiment. What's the learning curve like to do the switch?
I think for someone who's experienced with the main learning curve is the ultrasound, and you need there's some additional equipment involved, but basically it's a short learning curve.
Okay, well, that's good to know. Well, then my next thought is the Canadians and the Americans are sharing one thing in common off the top of my head in my world is we're all getting bigger in size. If I assume that we are, at least in the United States, by 2030, really going to hit 50% obesity, barring something change, or in Canada, it's moving up, is it easier or harder on a larger patient or individual to do a biopsy with the transperineal? I've never thought about that, but you made me think about that. I don't know why.
We have plenty of big patients, BMI well over 30 in Canada in my practice, and it hasn't been an issue.
Has not. Okay.
I think, listen, it can be an issue both ways.
Yes.
Because obese patients, the prostate is further away from the perineum and from the anal verge. So, I think either way it can present a challenge, but it hasn't been an insurmountable challenge for me yet. And I've probably done 500 of these over the last transperineal since I switched a couple of years ago.
So you switched a couple of years ago. So that's interesting. So, everyone needs to learn new tricks at some point. And so if you have someone with a BMI of 35, you feel comfortable sampling the prostate in somebody like that?
100% comfortable. Not an
really
issue at all.
Wow. Okay. Can we talk about biopsies also and active surveillance? I saw a paper that suggested that if you had a lot of favorability, the idea of doing surveillance biopsies, what I mean by that, of course, is doing biopsies later in time when you've already been under active surveillance to see how your disease is going. In other words, if your PSA if your PSA density was favorable, the MRI was stable, what do you tell patients about the idea of when to do a repeat biopsy? If everything's looking good, is there a purpose in getting a repeat biopsy in a few years, or can you delay that further?
Yeah, so I think this is really evolving. Our practice is still to do a biopsy within the first year.
Okay.
And the reason is even the best data, there's a 15% undergrading rate with targeted plus systematic. This is from the NCI data. Targeted plus systematic, 15% of patients are subsequently upgraded. So I like to do a first confirmatory biopsy a year. After that, it's extremely variable. And I would say in the average patient, maybe every 5 years. There's another wrinkle coming to this, and that is increasing. There's this kind of emerging observation that patients who have image invisible significant cancer, so that would be the guys who have like grade group 2 or 3, but nothing on MRI or ultrasound, micro ultrasound, that those are biologically more favorable cancers. They tend to be small. They tend to probably have less dense cellular packing, meaning less aggressive characteristics. And that's why you don't see them. And so really, does it matter if you miss those. Maybe it doesn't matter that much, particularly if they're grade group 2. And so the idea is kind of wait for something to show up. So I think that that is a very appealing strategy. I wouldn't call it hard fact yet. There's kind of limited data on this very interesting question of what is the clinical features of image invisible significant cancers. But if that's true, and it probably has quite a bit of truth to it, then you're really talking about just doing targeted biopsy and maybe biopsy the area around the target to make sure you haven't missed anything, but moving away from biopsying normal looking prostate. And that I think is going to be where this is going within the next few years.
That's really interesting. And I didn't think you were going to say every 5 years, you do a rebiopsy, because it seems like some people are sometimes caught in a protocol where people have to come back every year, 2 or 3, and regardless of who they are, they got to be rebiopsied. Don't you see that? That seems still.
Hopkins did it their practice was annual biopsy for years and years. And it was really, they didn't think it was necessary either. People joked, that basically you did a radical prostatectomy over 15 years, doing it one needle biopsy at a time. That clearly was too much. We were every 3 years for a while, but I think the imaging, patients don't like it. First of all, that's part of the driver.
Yeah.
And I think, I showed the data in my talk that MRI alone could not find progression reliably. But if that progression is mainly to 3+4, does it really matter whether you'd find it this year, or can you wait another year or 2 to find it? So I want to be very clear. We're not ready to stop doing biopsies, but
right.
As time goes by, I think everyone in this field is doing them less and less frequently. So now my kind of default, if I see you guys, everything is fine, it's been 5 years since his last biopsy, I say, okay, it's time.
That's interesting. I know we've gone 50 minutes over, whatever. We'll continue this another time. I just wanted a different flavor today. You gave that to me.
All right.
I won't get teary-eyed and Academy Award winnish on you on a speech, but I appreciate our friendship. I appreciate what you do, and thanks what you do for this organization. It's been life-changing for so many, including myself. So thank you.
Okay, pleasure. Mark, great to talk to you. That's been a wonderful interview this afternoon. I really enjoyed it.
Thank you, Dr. Klotz, and thank you, Dr. Moyad, for that fantastic presentation. Thanks to everyone who joined us today, and we'll be back tomorrow at 8:30 a.m. PDT with Dr. Eugene Kwan with a presentation on lutetium-177, and then we also have Dr. Evan Yu with a presentation on advanced treatments and side effects. And then we'll end tomorrow with Dr. Moyad and Dr. Scholes and their Q&A session, where they will recap everything that was discussed and answer some of our questions. Thank you all for submitting those questions. Thank you to our sponsors, Bayer, Pfizer, Astellas, Janssen, AbbVie, Advanced Accelerator Applications, Blue Earth, Dendreon, Myovant, and Tolmar. And also thank you so much for everybody who tuned in today. We look forward to seeing you tomorrow. The Prostate Cancer Research Institute is an educational organization for prostate cancer patients, their caregivers, and their families. We put patients first and are an unbiased source of information and support. For over 20 years, our goal has been to meet the educational needs of prostate cancer patients at every stage of their journey. Medical technology is advancing rapidly, and new treatments are becoming available. Patients have to make complex choices which have lasting implications. They face unexpected industry biases and doctors who may not be up to date on the latest research. Your donation helps men receive the latest, most up-to-date information, which empowers them to make informed decisions. Our website, pcri.org, is a wealth of information and resources. Our conferences and webinars are a way to get patients' questions answered by leading physicians and researchers. And we have a helpline for men to call with questions about their diagnosis, treatment choices, and side effects associated with these treatments. Each week we produce multiple videos covering concepts and every patient question that we can think of about the disease in a straightforward and easy to understand format. This was a brief overview of what we do at PCRI, and to learn more you can visit our website. Your donation directly funds our educational programs, which give life-changing information to men during a very vulnerable time in their life, and we thank you for your consideration. You can visit pcri.org to learn more.
Provenge is an established cellular immunotherapy used to treat certain men with advanced prostate cancer. Provenge is customized to each individual and is made from his own immune cells. Immunotherapy is the prevention or treatment of disease with substances that may stimulate an immune response. The immune system has memory and can recognize substances it has encountered previously. Immunotherapy is designed to boost the immune system to target and attack advanced prostate cancer. This is why immunotherapy empowers the immune system to fight the cancer immediately and allow the effects to last over time. Indication: Provenge is a prescription medication used to treat certain men with advanced prostate cancer. Provenge is an established cellular immunotherapy and is customized to each individual by using his own immune cells. Important safety information. Before receiving Provenge, tell your doctor about any medical conditions, including heart or lung problems, or if you have had a stroke. Tell your doctor about any medicines you take, including prescription and non-prescription drugs, vitamins, or dietary supplements. The most common side effects of Provenge include chills, fatigue, fever, back pain, nausea, joint ache, and headache. These are not all the possible side effects of Provenge treatment. Provenge is made from your own immune cells, which are collected during a process called leukapheresis. The cells are processed, returned, and then infused back into the patient through an IV, intravenous infusion, approximately 3 days later. This process is completed in 3 cycles, about 2 weeks apart. Each infusion takes approximately 1 hour and requires 30 minutes of post-infusion monitoring. Provenge infusion can cause serious reactions. Tell your doctor right away if you have signs of a heart attack or lung problems, such as trouble breathing, chest pains, racing or irregular heartbeats, high or low blood pressure, dizziness, fainting, nausea, or vomiting. Have signs of a stroke, such as numbness or weakness on one side of the body, decreased vision in one eye, or difficulty speaking. Develop symptoms of thrombosis, which may include pain and/or swelling of an arm or leg with warmth over the affected area, discoloration of an arm or leg, shortness of breath, chest pain that worsens on deep breathing. Have signs of infection, such as fever over 100 degrees Fahrenheit, redness or pain at the infusion or collection sites. Tell your doctor about any side effects that concerns you or does not go away. For more information, talk with your doctor. You are encouraged to report negative side effects of prescription drugs to the FDA. Visit www.fda.gov/medwatch or call 1-800-FDA-1088. Please see accompanying full prescribing information.